collaboration with the Taiwan Association of Thoracic and Cardiovascular Surgery. I'm pleased to announce that the summit embraced the hybrid nature of our times, featuring both physical and online conferences held simultaneously. So today marked the beginning of 3-day filled with thought-provoking discussions, informative lectures, and interactive sections. Due to the nature of the summit, we designed a warm-up section before the official opening. Without further delay, let's promptly proceed to the first session, a roundtable discussion on mitral valve involved, moderated by renowned cardiologist Kapun, Dr. Cao Jianping and Dr. Ying Weixian. The session features esteemed experts Dr. James McCabe, Dr. Dale Murdoch, Dr. Haibo Zheng, and Dr. Yongzai Li, who will delve into the intricacies of this innovative approach to treating heart valve disease. Thank you.
Thank you. Dear colleagues, it is my great pleasure to hold this meeting. And this year, the meeting is held in a format of both in a hybrid format. We have in-person meeting and online meetings. So the first warm-up session will be a session focused on transcatheter mitral valve involved, which is getting more and more popular in this part of the world. 10 years ago, I think many physicians and surgeons start to use biprosthetic valve, and now the valve getting older and failed gradually. So we are facing a wave of need to treat this kind of patient. Although reduced surgery is the standard of treatment, however, I think to ask for the less invasive approach is a very big need. So I think after the starting of transcatheter program in treating this kind of patient, I think most of you are waiting or are eager to do this kind of procedure in the future. Together with me will be the world-renowned expert in this field. Kapun from Australia will moderate the session with me, and we also have distinguished guests from overseas, James McBee, Dale Murdoch, and Haibo Zhang and Yongzai Li to join the discussion. This session will be go through in a format like this. We start from overview of the topic, and Dr. Murdoch will present a case, the first part. That means to show the history and the examination, diagnosis, and the question of the patient. Then we will have a mini review on step-by-step of mitral valve involved. Then a review of LaPrune procedure to prevent LVOT obstruction. Then Dr. Murdoch will show us the result of the procedure. Then we will have a panel discussion. So let's start from the first talk. Dr. James McBee, would you please to start your talk?
Thank you very much. Can you hear me okay?
Yes, very well.
Okay. Well, good morning there. Good evening to those of us in the United States. I'm actually coming to you from my hotel room at Transcatheter Valve Therapies meeting here in the U.S. So I'm attending both meetings simultaneously, which is a great honor. If someone could put up the slides, that would be great.
Can you see it, James?
I can see something. I guess I sort of see my slides in the corner. I think I'm in presenter mode.
Please show the slide on the main screen. Yeah.
Okay, you can see them okay? I can.
Yeah, we are okay.
Okay. So there are my disclosures, and if you could move forward, please. Okay, perfect. So next slide, please.
Next.
Or maybe I can control that. No, I can't. So can we go to the next slide? Great. So I'm not going to spend too much time talking about redo mitral surgery, but in the United States, just for some background, the redo mitral valve surgery carries a 12% mortality. This has been part of the reason that mitral valve and valve therapies have become so desirable. You can continue, please.
Next.
Looking at the VIVID registry, we see that both on aortic and mitral valve, the median time to intervention with a transcatheter valve inside a surgical valve is 9 years. Obviously much more frequent in the aortic valves in blue bars, but mitral valve therapy is also growing. Continue. Next. Currently, the predominant way to do this is with a transeptal approach that has shifted a great deal. Early on, this was done via transapical approach, which did have some challenges, particularly in sick hearts and people who had functional mitral regurgitation and LV dysfunction to start. It is now almost exclusively transeptal in the United States in 2022. Continue. The data, in terms of overview, the data here is from the US TVT registry, which reports 1,500 patients who received a valve-in-valve procedure. It is not perfectly up to date. The dates are 2015 to 19. And you can see now transeptal is 1,300 and transapical is just 200 cases. Can continue. What we see from this is that the primary safety endpoint and technical success are both over 95% or greater, and that survival is actually improved greatly by using transeptal access, as you can see on the right-hand panel. Next, please. In fact, the survival ratio of observed to expected is almost 2 to 1 at 0.45, suggesting that this is in fact a very safe procedure. And as compared to the 12% mortality of redo mitral valve surgery, I think there is very good reason to have enthusiasm about mitral valve and valve treatments, with one caveat, which is that in the context of very small valves, very small surgical valves, the gradients can be disproportionately high. Next. So this is the future state, right? This is a patient who had both a prosthetic mitral valve and tricuspid valve, both of which had failed and both required replacement. It's just a sort of fun image. Performing these procedures generally is relatively straightforward, as long as one develops comfort with the transeptal access and septostomy. Next, please. So if I were to offer any learnings about mitral valve and valve, I would say that the mitral valve and valve app for the phone is actually relatively helpful and is worth obtaining. The app will often show, like this picture on the bottom right, which is from the app. It demonstrates a physical picture of a sapien valve or a my valve inside a surgical valve. And what one can see is the height of the surgical leaflet length, and that is actually quite important. CT planning on mitral valve and valve is predicated or is based on looking at post lengths, but often, like in the case of this mosaic valve, the leaflet height does not approach the height of the post. And so therefore, outflow tract obstruction risks are much lower in mitral valve and valve frequently than in other forms of mitral therapy. I do personally always confirm the valve inner diameter with CT, though it is listed in the app. You should review the CT also to make sure that there is not a post position primarily in the outflow tract. One caveat, and I don't know if epic valves are used much locally, but epic valves are very difficult to see on fluoroscopy. So those are scenarios where I do think it is much more difficult to do mitral valve and valve than with other valves. And I will say that at least for the American companies, they will provide proctors or expert support for those who haven't done this procedure before. So I believe it is a very safe and relatively straightforward procedure with good O to E ratios that suggest it can be done quite well. I would be on the lookout, be careful about valves that are very small and epic valves. Next. So thank you very much. Just a brief overview of the data. I hope that's helpful. I'm happy to talk further about valve and valve.
Yeah, thank you. How would you please share the next talk?
Thanks, Jamie. So I think we'll move on to the next session, and then hopefully you can stay for the discussion at the end. But once again, thank you for the amazing overview. So the next speaker is a friend and a trusted colleague, Dr. Dale Murdoch at the Prince Charles Hospital in Brisbane, Australia. I'm here because he's doing all the work back home, so thank you, Dale. So he's going to show a case that we did together, and please take it away, Dale. Thank you.
Good morning, Carl, and thanks. Can you hear me there?
Yeah, very well.
Fantastic. So if we could pop up my slides, please. It's great to see you there at the meeting, Carl. We've got things under control here, and it's nice to be able to share a case we did together. So if we could go to our next slide, please. We've really shifted to all of our cases being via a transeptal approach in recent years. And here's an example. So we have a 79-year-old man who had 2 previous cardiac surgeries. So he'd initially had a CABG and mitral valve repair in 2009 at our hospital, so 14 years ago. And unfortunately, he didn't get a durable repair of his mitral valve with the first operation. So he was operated just a year later. And at that time, as is often the case when we have a failed mitral valve repair, the surgeon elected for a mitral valve replacement. So he had a 27 millimeter mosaic bioprosthesis placed at our hospital once again in 2010. And he did extremely well for more than a decade after his mitral valve surgery. He was working and independent and exercising and a keen fisherman, but he returned to our clinic with very sudden onset of heart failure. And he had, class 3, almost class 4 symptoms and some fluid overload, which his local physician had managed with some diuresis. They'd identified a mitral regurgitation murmur and referred him directly into the surgeon's clinic. And he was relatively well, but clearly breathless on minimal exertion. And in those intervening years, he'd picked up a few comorbidities. He now had type 2 diabetes. He was treated for his hypertension. But overall, he's a fairly robust 79-year-old man who clinically had new mitral regurgitation and quite significant symptoms. So, of course, as the first investigation, he had a transthoracic echocardiogram, and that showed an elevated mitral gradient, 9 or 10 millimeters of mercury a mean. And it's interesting to note that with his mitral valve replacement with this mosaic bioprosthesis, he'd had a gradient of sort of 9 to 10 really since the time of his operation. So, we talk about the fingerprint of valves, but he'd had somewhat elevated gradients even with this brand new mosaic valve from 2010 through to 2020 when his previous echo was. So the gradient hadn't changed a great deal, but now there was MR. And that can be difficult for us to assess carefully on a TTE. So even before he was referred to me, he was sent for a TOE. So can we go to the next slide, please? I think this is a really important point. Patients who've got failing mitral bioprosthesis, sometimes it can be difficult to assess the degree of mitral regurgitation. There's shadowing from the valve, and sometimes often the leak is very eccentric and can be difficult for us to ascertain the degree of new regurgitation. Oh, sorry, it looks like I've crashed the system there. Okay, that's working again. So here we've got some nice 2D color and 3D images of this patient's valve. And we can see that the leaflet motion's clearly abnormal in 2D and 3D. And we've got this big jet of sort of anteroseptally directed mitral regurgitation. And the mean gradient there is 9. As I said, that's about what he'd had for the last decade. So he was referred to me by the surgeon who asked if we had a less invasive option than a third stenotomy for this patient. And the next step for this patient was to have a cardiac CT. This is really the key planning test for our patients considered for a transeptal mitral valve and valve procedure. So we'll go to the next slide, please. And really, before we go to the CT, it's really important to consider, which surgical bioprosthesis the patient has and how we might be treating that so that we can plan with a virtual valve on the CT. So really importantly for these mosaic valves, although it's listed as a labeled size of 27, the true internal diameter of these valves is much smaller. So, for a 27 labeled valve size here, the true internal diameter is just 22 millimeters. And that's probably the reason for this patient's, elevated gradients, because really he's a, fairly standard sized Caucasian male patient, and he has a smallish true internal diameter with this model valve. So the recommendation from the app is that we can use either a 23 or a 26 millimeter balloon expandable prosthesis patient mismatch with a smaller surgical valve. And the good news here is that this bioprosthesis is fracturable. So we routinely now really think about the larger size transcatheter valve and balloon valve fracture to improve the hemodynamics in a patient like this. So if we have a look at the CT and we'll think about how it will go forward here to the next slide, and we can have a look here. There's a video that plays. So this is the 3 Mencio multiplanar reformat imaging of this patient's heart. You can see that the valve frame is really fairly radiolucent, but we've got these 3 posts or eyelets at the top of the valve post for this valve. So, we can plan a sort of 20% atrial, 80% ventricular deployment of this valve. And, even with just a brief 3D reconstruction here, we can see that it looks like the risk of LVOT obstruction will be low. But I think it's really important here to ask our Edwards colleagues. They provide excellent service and reviewing of the CTs for us, those of us who don't have the mitral module of 3 Mencio, to carefully assess a virtual valve in the mitral bioprosthesis. And really it's about predicting the risk of LVOT obstruction. So Carl, I might just ask, what facilities do we have there at the meeting? Do we have a workstation with the CT loaded, or should we just review the PDF that we've been provided to determine the risk of LVOT obstruction here?
Del, I think we don't have the workstation, but your CT has been very clear. Maybe just move on to the PDF if that's okay, but you already showed
That's
it very
great.
nicely. Yep.
Thanks, Carl. So here we have, a report for this patient, and we get a really carefully planned valve-in-valve procedure here. That's great. Thank you. If we could just scroll down, and as we scroll down here, we'll see the information that we're provided when we assess these patients. Let's just keep scrolling there. We'll go down to the next page. So this is using the dedicated mitral module of the 3Mencio software. Let's go down to the next page. That's great. So we have this multiplanary format picture of the valve here and a hockey puck. So we can use this, if we don't have the patient's valve sticker or valve card to ascertain the size of the true internal diameter here. Although it's always best to go out of your way to find the surgical notes to make sure we're using the correct size transcatheter valve. And let's keep going down. And in these next couple of pictures here, we can see the blue ring is a virtual 26mm balloon expandable transcatheter valve. So we can see how that will behave in the previous valve replacement. Let's keep going forward. And some nice, projections of our transcatheter valve. You can see that we've got approximately the 80-10 position of our virtual valve there. And let's keep going. We can see here that there is the careful neo-LV assessment with a 26mm balloon expandable valve. And this is really the key assessment that we use with the CT for these procedures. And as Jamie explained, the height of the leaflets are different for different surgical valves. These mosaic valves, they're the top of the valve posts, and we can take that into account when we assess the neo-LVOT. So you can see here that the assessment shows a predicted neo-LVOT area of 322 square millimeters. And that's certainly favorable for a valve-in-valve procedure for this patient. So, if we have a smaller area, less than 200 square millimeters, or certainly less than 150 square millimeters, we really start to be more concerned about risk of LVOT obstruction with this procedure. But when it's well above 300, as it is in this case, we're quite confident that that's safe. So, Carl, I might hand back to the panel for a little bit of discussion about the best way to manage this patient who's had 2 prior stenotomies, but is otherwise quite robust. And he now, clearly has an indication for re-intervention. If you sit down and calculate his STS score, it's not that high. It's 3.5%. But the risk of morbidity is quite a bit higher based on the surgical literature. It's about 19% for this guy. So we used to reserve these procedures for really very high risk and inoperable patients. But what do you think for this patient?
Thanks, Del. Amazing. So maybe I'll throw it to the panel. Who would support a transcatheter mitral therapy? Who would operate? Surprisingly, this is quite a low-risk surgical candidate. But just one question before we move on. Any support for transcatheter solution here in a transcatheter meeting?
You are the surgeon. You start from
I think that this case is a quite small true internal diameter, and the surgeon always worry about the patient prosthesis mismatch. when we do the transcatheter one, that's we only put in a small valve. And do you think we need to crack it, or we just redo surgery for this case? We use the balloon fracturing the valve, or we need to replace the valve.
Del?
Yeah, I think I certainly agree here. You know, I think if we use it, particularly a 23 millimeter valve, which you could and might need to in this case, if we're not going to balloon fracture, we're likely to end up with unacceptably high gradients in this patient. So I think for one like this, I think it's really only, you know, to be considered in an operable patient if we're prepared to balloon fracture and use the 26. And you know, the recommendations from our colleagues at Edwards in the US and Canada, based on this case in particular, was that a 26 millimeter SAPIEN 3 and balloon valve fracture with a 26 millimeter true balloon was recommended.
Yeah, personally, I have a concern regarding the stenotic mechanism of the valve failure, because according to the registry, the prognosis will be worse if the mechanism is stenotic one. And also in such a, our own experience that if we use smaller valves such as the lotus valve for mitral position, the valve is not durable. And also the small mitral annulus or small bioprosthetic in mitral position, they will not last long. In average, maybe 5 years or 3 years, the valve will get failed.
Yeah, I think that's a very valid point in terms of you know, preempting some of the talk about not using a 23 in general, if you can help it, make the valve a bit bigger. In terms of, I think, the stenosis and regurgitation, I think that's interesting. Obviously, that's registry data, but I think the message is really using a small valve, particularly in the mitral space, is not a good idea. I mean, in general, a smaller valve probably doesn't last as long anyway in any space, but just in the interest of time, we'll come back to some of the discussion, but I think I've been tasked to talk about a lot of the stuff that's already been covered by Jamie and Del, but essentially the transcatheter mitral valve and valve step-by-step procedure. So if you can bring up my slides on my laptop here, please. So as been elegantly covered already, I think the transeptal mitral valve and valve is an attractive solution as long as you plan well. So both Jamie and Del have highlighted the importance of having sufficient data, CT, but in my institution, we're quite lucky. Almost always we would be able to find the original operation note, being a major surgical center. So the reason is sometimes the label size is not labeled correct. We've had a few cases where even the CT through significant doubt in terms of whether it's really a 27 or 25. So we go to the archive, we go to the basement, we get the surgical note. And it's already been highlighted before, but the key thing here in terms of the type of valves is really porcine or bovine pericardium, in particular, the length of the leaflet. I'll show that in the next slide. Now, sometimes it's important as well to know whether the left atrial appendage has been resected, mainly for safety of the procedure, perhaps, and obviously in a ring and other non-valve replacement, whether the anterior leaflet's been resected. So this is really the message that's already been put out earlier, that when the porcine valve, the leaflet is fully expanded or opened, it doesn't get to the post. So this 2 or 3 millimeters may be all you need and all you get in terms of LVOT flow, as opposed to a typical perimount with longer leaflets, okay? So a Hancock or mosaic, a typical porcine, you have this little gap there. So that really helps for transeptal mitral valve and valve implantation to get that LVOT flow. So like Jamie said as well, the CT is useful, particularly for confirmation about sizing, but it's all about preempting and preventing LVOT obstruction, because dealing with LVOT obstruction after it's happened, I think it's fair to say it's not easy. Even doing rescue lampoon, I wonder how successful it really can be with a valve already in place. So Dale's already shown some of the modules and reconstruction that we can do, and the numbers continue to change. It's not a hard and fast rule, obviously, but some would say less than 170 millimeters square, 190, 200. Obviously, the lower the higher risk, perhaps indexed to the ventricular size, but these are some of the somewhat flexible numbers. But if you have over 250, obviously, the risk is very low. So somewhere in between is a little bit flexible, I suppose, depending on the type of valve as well. As I understand it, no surgeon would ever put a valve so close to the septum, and I think overall the chance of this is always due to ongoing change in the morphology and maybe further hypertension after the original surgery. I think we kind of mentioned about sizing as well. I think in general, the larger the better. But if you were to have concerns about alveolar obstruction, maybe you need to undersize relatively, but you're aiming for procedural success rather than longevity. So a bit of a compromise, and perhaps this is another deciding factor as to whether a patient should have redo mitral valve surgery compared to a transeptal mitral valve and valve. In general, I think that most of these intraannular leaflets, if there's stenosis, you could get away with a smaller valve, but perhaps the better option is really crack and larger valve. In the between sizing, if it's pure regurgitation with no stenotic tissue to hang on to the valve, don't go for a smaller valve. I think in the mitral space, and as same as aortic space as well, valve and valve, the constrained part of a valve that's not fully expanded, I think there's more and more concerns, perhaps not so much data in the clinical space, but concerns about pinwheeling and maybe longevity of the valve. So very quickly, I think a well-planned transeptal mitral valve and valve really is similar to a TAVI insofar as there's the transeptal path. Other than that, it's very similar to a aortic TAVI. But there are extra steps, and I'll just very quickly highlight some of the key points. So transeptal puncture should not be very high, like a mitral clip. You end up having difficulty traversing the valve if you were to do that. So we tend to aim for the lower half of the valve if possible. You can cross the valve whichever way with an Agilis or with just a JR4, but probably picto will be the best to not entangle into any structure in the ventricle. We're starting to save cost by obviating an Agilis catheter if we can help it. So I tend to cross the mitral valve and then do a septostomy. Some would go up to the left upper pulmonary vein and do a septostomy that way. I think we've stopped doing just a 12. For all the valves, we tend to use a 14 and longer inflation. Some would advocate shaping the wire. I played with this a little bit, but in the end, I think it really doesn't help too much. Some would advocate the shape of the wire or the curve of the wire, just like a aortic TAVI, where the curve is facing up. But ultimately, I think nowadays the concern about being able to traverse the septum and the mitral valve is perhaps with experience, it's really less of a concern. That was, I think that was my first one in 2017. So very large safari for what it's worth, but large ventricle. So with particularly something like perimount, don't cross the valve too much because the metal coming back, it's very hard to adjust sometimes and you can end up getting stuck metal to metal. It's very important to know the fluoroscopy, particularly the different valve type. I think Jamie already mentioned a BioCore or BioCore Epic. Very hard to see. Sometimes you just have cells like a mosaic. That's obviously a perimount that you can see very well. But we tend to hold respiration, mostly GA cases. I suppose you can use ICE if you really want to for the transeptal, but placement of the valve is really fluoroscopy rather than TEE guided. But when Dell and I do cases, we inflate very, very slow respiration hold in such a manner that if there's any undue and unexpected movement, you have somewhat time to adjust. So hopefully we're not too much delayed in terms of timing, but operation note, caution to use a 23. I think we've heard that a few times today already. No surgeon would do a 23 ID mitral valve replacement if given a choice. So why do a 23 mitral valve in valve? Understand the valve, the difference, the relative safety of porcine compared to bovine, and lastly the placement. And if you don't size it well, migration can still happen, but rare. And hopefully the data that Jamie will see on Saturday about intermediate P3 mitral valve in valve that we were involved in will be even more promising in terms of intermediate risk candidates. So thank you for the opportunity to present.
Great talk. I think everything has been standardized mostly. Well, next talk will be delivered by Dr. Lee.
No, not they will present down the case.
Oh, after the case presentation. Okay, Dale, would you please show us how do you do the case?
Thank you. If we could go back to my slide presentation, please. So we had a good discussion at our heart team meeting and thought about the pros and cons for this patient, but very supportive from all for a transcatheter approach for this man, and he was very pleased with that. So he had a general anesthetic and femoral venous access only. We routinely pace over the LV stiff wire now, and the procedural plan was for a 26 millimeter Sapien 3 Ultra THV inside his 27 millimeter mosaic with balloon valve fracture immediately post implant in this case. So if we can go to the next slide, please. And hopefully these videos will start playing automatically, but you can see here that I just have an SL sheath immediately after the transeptal puncture. You see if that video will start playing. There we go. Thank you. And then a pigtail and a JY. Sorry, can we just go back to that previous slide? And back, thank you very much. So we just have an SL1 sheath here and a JY inside a pigtail catheter. That's great, thank you. And I think more than half of the time you can avoid the need for an Agilis catheter to cross here. One other comment, I don't have the image, but we would frequently use 3D TOE guidance now for antegrade crossing of the mitral valve. I think it's really invaluable to be able to look in 3D and cross using the guidance provided by our TOE colleagues. But after that, I think Carl's gone through step by step most of the procedure here. Important to have your safari wire in a good position distal in the apex, and we performed a balloon septostomy with a 14 millimeter Armada balloon after the safari wire was in the left ventricular apex. You can use either a 12 or a 14 millimeter Armada, and almost always the delivery system advances without any difficulty after that. So you can see in this picture for the deployment that we don't have a temporary pacing wire. We're pacing over our safari wire, and we have the respirations withheld. And we've lined up the 3 posts of the mosaic bioprosthesis in a row. You just have to know, where the rest of your valve is based on that. And unfortunately, there's good guidance that's provided in the Valve in Valve app. And given that this is a relatively small surgical bioprosthesis, the frame height is a little bit less, and you can see that we've started just a little bit more ventricular than we would for perhaps some of our other cases, and that's based on our plan to routinely go ahead and fracture for this case. So given it was a small surgical valve and the procedural plan was always to fracture, we didn't go ahead and check any particular invasive gradients or do any specific assessment at this stage. We went straight from deploying the valve to fracture. So if you just go forward, I think the next slide, please. So this is balloon valve fracture with a 26 millimeter true balloon. The guidance of which balloon size is provided in the app. And if you just have a look at the bottom part of the frame, just there, we might just let this cine play again. And if you just look at the bottom left corner of the SAPIEN valve as the balloons expanded at very high pressure. So we have a high pressure indeflator with 40 or sometimes 60 cc's, and I think we achieved fracture here at 16 atmospheres with this balloon. And you can see on the bottom there that the SAPIEN frame expands quite significantly with very high pressure post dilatation here. If we could go to the next slide, please. And here's the SAPIEN frame before and after fracture. So we've got drastically improved frame expansion here with fracture. And next slide, please. And once again, careful 3D TOE assessment. You can see that the valve leaflets are now much better. We've got good opening here and no mitral regurgitation. As is usually the case, there was a small iatrogenic ASD for this patient. There was entirely left to right flow in this case, and the longest axis of the defect was about 7 or 8 millimeters. And so we manage that conservatively. We don't routinely close the puncture for our patients. And next slide, please. So I commenced this patient on warfarin. He's in sinus rhythm, and the plan was for warfarinization for 3 months post-procedure. And he went home a couple of days later, and it's hidden by my video here, but we had an invasive a TOE-based gradient of just 3 millimeters of mercury, and his TTE assessment of his transmitral gradient was 5 millimeters of mercury at day 1 and again at 30 days. So a great case here where we've got a patient who's got a better transmitral gradient with a valve-in-valve procedure than he ever had in the previous 12 years with a surgical bioprosthesis. He's done very well.
Okay, I think this is a fantastic case. Well, Dr. Lee?
Yeah, play my slide. So the prediction of LVOT obstruction has published long time ago. That's Professor Jenier here and his colleague reported that the device depth, device flaring, outer mitral angle, and the sepal bulge is a risk factor of the LVOT obstruction. Now we should pay more attention about the prosthesis type and the prosthesis short height, because the bovine valve have the long leaflet, and sometimes it got easier to obstruction of LVOT. So that's every time you implant a valve in perimount valve, you should pay more attention, because the structure, although it's low, and when the skirt will seal the LVOT, so it got more problem. And the pulse side valve leaflet is shorter, so it got is more safe to implant a valve-in-valve procedure. Next. And here we demonstrate a easy way to solve the LVOT obstruction. After septal puncture, we snare out a 0.14 agitator wire. This wire is a bare metal wire and with a very soft tip. When we snare out the wire, is around 300 centimeter and the externalization. After we externalization the wire, we got electrocautery for the anterior levator. And if you do the mitral valve in ring, you should pay more attention about the wire should be in the middle of the A2 and avoid danger to destroy the aortic valve, because this sometimes happen. So we protect the JR catheter protect the aortic valve with JR catheter and protect the other heart valve tissue with the Agilis catheter and the guiding catheter. So let's we check the echocardiography and we pull the guiding catheter and the JR, so we can find an indentation over the A2 area. You can see here very clearly the A2 was the pull up by the wire. So now we electrocautery. Always pay more attention about the aortic valve, and you should pay attention about the catheter pressure. And when we do the electrocautery, a lot of microemboli and evaporize the blood. So we need to do the brain protection device, because we catch some debris in the brain protection device. So that's if we do the Lapun procedure, we need the brain protection device to prevent the neurological event. And in this case, you can see a lot of vaporized thing in the screen. And now we check the mitral valve with MR. So the jet becomes separate. Now we can see two different jet direction, and the aortic valve is okay. It's as long as it's just enough. And sometimes you can do the 3D and see more clearly result. So the anterior levator in this repair valve is cut by the agitator wire. So it's a perfect result for the Lapun procedure. I think if you get used to use the Lapun procedure, and you can prevent the LVOT obstruction more. Next. So this is a traditional tip to base Lapun, and had reported by the group. And the next, in a virtual simulation, and if you do the Lapun procedure, the post-procedure pressure gradient, it got dropped a lot. This is my next slide.
Okay, thank you for your presentation regarding how to and why we should use Lapun in case at high risk of LVOTO. So I ask for comment from James for this case or the talks.
They've been wonderful cases and wonderful talks. It's great to hear everyone's perspective. We do a great deal of lampoon, and I do want to mention that on the echo, what is seen are bubbles with electricity. It's not all emboli, just to be clear that it's not all debris. Though I agree that we also use brain protection for all the lampoon procedures. I also agree with the fracture performed. I think mosaic valves almost always need to be fractured because they have a large sewing ring and the inner diameter is relatively proportionally small. I know I'm in the minority, but it is my opinion that fracturing before the new valve goes in is preferable to after, though the vast majority of people do it after. And so no one knows what's right, but I prefer to not put the new valve leaflets under high pressure. So I think that patients tolerate a fractured valve fine for a few minutes before you put the new valve in. So I fracture and then put in a new valve. Just my opinion, and perhaps wrong. But otherwise, I think that what you're seeing here with the tip to base lampoon, as shown with the balloon valve fracture, all of that is state of the art and really perfectly well done.
Jamie, just a question on that. So when you fracture before, do you go just nominal, and how often do you need to post-dilate to ensure that it's still fully expanded? And second question is really the role for TASH, the timing, in part of the whole cascade of LVOT obstruction prevention. What do you see, and what's been your experience?
Yeah, I find that post-dilating is rarely necessary with a balloon valve fracture before. It's my rule of thumb that I usually do a pre-valve fracture with a balloon that is sized 1 minus the outer diameter of the surgical valve. I don't know why, it just seems to be easy. And then we put in the, whatever valve without post-dilation. I will say so TASH, I don't know what TASH stands for. We call it alcohol septal ablation, but I think it's the same thing. I guess I think it is not commonly required in the context of mitral valve and valve, though it is sometimes more often required in valve and ring, and certainly in valve and native annulus. My feeling is that there is never enough outflow track. I almost these days in native annuli, I tell all patients, even before I see the CT scan, that they're going to have a two-step procedure. The first will be septal modification, and the second will be the valve deployment, separated by about a month. I actually do not do TASH anymore. I now do sesame, so laceration of the septum, but same concept, same goal. So I think you can almost never have enough outflow track. So I'm a strong advocate of a two-step. That said, I don't think it's very infrequently required in mitral valve and valve.
I'm glad you brought that up, the sesame, and perhaps I was going to talk about your Seattle procedure as well, just great acronyms to start off with. But could you just briefly explain to us who have not done or even seen a sesame what you do with electrosurgery, please?
Sure. So it is based on the surgical myotomy procedure before there was a quadrangle resection. It's my understanding, having not been a surgeon, that the original myotomy procedure done by surgery was a single laceration from the mid cavity of the LV along the septum towards the base after exposure through the aortic valve. And then the surgeon would then take their finger and sort of splay that incision. And that was subsequently replaced with quadrangle resection surgically. But the sesame aims to mimic that myotomy. The idea here is that the septal fibers run circumferentially. So if you puncture into the septum just under the aortic valve, in the right coronary towards the left, so anterior to the membranous septum, away from the pacing structures, and traverse down the septum to the mid cavity, and then punch out of the septum and snare and externalize that wire, you can make a vertical laceration along the septum, along the anterior septum, from mid cavity to the annulus, that then will ultimately splay, because the circumferential muscle fibers there pull that slice apart. And so what we're seeing, there have been 79 done in the world so far, so it's still new. But what we've seen is that you can actually get quite large cavity dilation. We're averaging about 85 square millimeters, but of neo LVOT gained, but sometimes you can get upwards of almost 200. So quite, there's some variable response that I think is not well understood, but that is the sort of general idea for Sesame.
We have a couple of cases with the mitral valve prosthetic stenosis and a large thrombus in the LV or LAA. So what would be your approach? Is there any difference with the transeptal approach or transapical approach? Or would you do the thrombolytic therapy first? And what is your approach?
I think all these transcatheter procedures, valves or otherwise, one absolute contraindication is thrombus in the chambers, isn't it? The second one is active endocarditis. Very rarely do we have an absolute contraindication. I'm sure there's probably ways, risk and benefit, cerebral embolic protection device or even other protection device, but I suppose risk and benefit, if the patient can be delayed for the procedure with industrial doses of anticoagulation, give it a really fair crack, then and he or she comes back with still the thrombus, then a frank discussion. You may be able to protect the brain, you may lose your other organs, unfortunately. But I suppose the transapical pathway, again, risk and benefit, I mean, fundamentally, I hope I'm not mistaken, I mean, transapical is definitely high risk, however you look at it. So to suddenly, you take all the boxes of risk and benefit, I probably would shy away from transapical. We've done cases with very well-formed left atrial appendage thrombus. We think it wouldn't embolize, and it did not. We've also done a very well-formed, organized left ventricular thrombus or clot with a large safari to fix the aortic valve without touching, disrupting the apical thrombus, but really risk and benefit.
Okay. Any comments or questions from the audience? Dad, do you want to add something?
Anything to add, Del?
I think one question for the group, are there any concerns about balloon valve fracture in the mitral space? Are there any things to consider? Can we really, fracture with impunity for these procedures?
Dr. Lee? Yep.
Yeah, I'm very concerned about the fracturing in mitral position because the mitral aneurysm is usually thin than the artery valve. When we do the fracturing, is any possibility of the aneurysm rupture or dehiscence? And the mitral debility, if you do the surgery, sometimes it causes the aortic rupture at in the aneurysm level. So I have no idea about the fracture in mitral position because this is the beginning cases and only case report or some few cases done with fracturing. Well, in my center, we do not do the fracturing in the mitral position. And I tried one, but did not success because the valve is not fracturable valve. And it's a Mosaic 25, and I use 24 balloon to fracturing, but did not see any change.
I have a question for James. James, if you do the balloon fracturing before the implantation of the valve, how do you select the balloon size?
Thank you for asking. We do, I will say that I fracture every mitral valve that has an inner diameter less than 28, because the biggest true balloon is 28, so that's when I stop. And we fracture them all, but we always pick 1 millimeter smaller than the outer diameter of the surgical valve. I think that's a balance between safety and getting more internal diameter.
It is my pleasure to close the session. And First of all, thanks, Jamie, Dale, for remotely dialing in probably unreasonable hours, particularly for you, Jamie. But I can tell you it's as hot here as Phoenix. So maybe I should have thought about going to Phoenix. But it's an absolute honor to have you here. And my co-chair, Dr. Yin, I've known over the years, an extremely experienced operator, and the panelists for all your input. It's been a great session. I hope you enjoyed it. I've learned a lot about this area that can only explode in terms of its frequency, and let's all share our knowledge. Some of this is really expert opinion rather than level A evidence, but let's all share our knowledge and propel the field. So thank you very much for your participation and your attention.
So thank you for an insightful discussion. We'll now proceed to the next phase of our program, the official opening of the ceremony. It's with great honor that we welcome esteemed Professor Zheng Wei and Professor Jen Ye, who will share their expertise and set the tone for Taipei Valve Summit 2023. Let's warmly welcome Professor Zheng Wei and Professor Jen Ye. Thank you.
Co-chairman Dr. Jen Ye and dear esteemed experts, I'm delighted to announce that the 2.5-day Taipei Valve Summit 2023 will commence today at Chengxin General Hospital in Taipei. On behalf of the Congress, I would like to express my sincere welcome for your participation. With the gradual easing of the COVID-19 pandemic, people are returning to everyday life. And the medical conferences are gradually getting back on track. This year's Taipei Valve Summit will adopt the hybrid format, combining the in-person and online modes. I sincerely thank for joining us to share your professional knowledge and valuable experiences. As always, the Taipei Valve Summit 2023 will bring together experts and scholars worldwide to exchange groundbreaking developments in treating heart valve diseases. Through surgical demonstrations and discussion, we aim to expand and promote the cutting-edge research and the frontier knowledge, thereby enhancing the quality of and standard of valve disease care. Last year, the 2022 Taipei Valve Summit, held through video streaming, attracted over 60,000 professionals from more than 20 countries who viewed the conference online. This year, the Taipei Valve Summit has invited experts and scholars from over 30 countries to participate. The themes of this conference will cover surgical treatment for the aorta and the aortic valve diseases, the latest treatment and lifelong management of aortic valve disease in the era of TAVR, addressing clinical needs in TAVR therapy when expectations are not met, how to optimize the process and the clinical outcomes of TAVR, and other transcatheter heart valve interventions for mitral and tricuspid valve diseases. The Taipei Valve Summit 2023 promises to be an exciting event. And once again, I thank experts who have come to share their valuable experiences. I also thank everyone for your participation.
Hello. Good morning, Professor Wei, Professor Yin, friends, ladies and gentlemen. I'm very delighted to be in Taipei again for this sixth summit after the unexpected long COVID pandemic. It is a great pleasure and honor for me to be able to welcome you to Taipei Valve Summit 2023. You all know there have been a rapid and dramatic change in management of heart valve disease over the past decade. As you know, from initially how to perform the TAVR, now how to achieve perfect TAVR. And from applying the high-risk patient to low-risk patient, from the elderly to the really young population now. And also our focus is changed from early outcomes to the now is a lifetime management. And also we're dealing with not just the aortic valve, now is dealing with mitral valve and tricuspid valve from single valve to the multiple valve disease. So the TAVR and the another transcatheter mitral edge-to-edge or tricuspid edge-to-edge now become is a pretty routine daily procedure. And but however, we're still facing a lot of new challenges and also several issues remain unresolved. So particularly when applied in the new or young patient population. So this Valve Summit provides a unique opportunity for all of us to learn and to share our knowledges because it has attracted, many physicians, surgeons with a wide range of knowledge on surgical and transcatheter management of heart valve disease from all over the country, as the professor we mentioned, over 30 countries. So Professor Wei and Yin and their conference organized committee built a very stimulating programs. And the program offered over 80 presentations, including keynote speakings, lectures, case presentation, and many live cases transmitted from different countries, covering from surgical, both surgical and transcatheter intervention for all the valve disease. So in this year, there's also particularly several discussion sections that really will be very stimulating for the discussion. So we are, and I'm sure the program will trigger fruitful discussion and will provide a film to share expertise knowledges as well as to find a way to optimizing the management of heart valve disease and provide the best possible care to our patient with heart valve disease. Once again, welcome to the Taipei Valve Summit 2023, and thank you for you attending and bringing your expertise and innovative idea to our summit. Thank you.
Thank you, Professor Wei, Jen Wei, and Professor Jen Ye for your enlightening opening speeches. Without further ado, we will proceed the next section of our program. We are privileged to have a distinguished group of moderators and panelists who will guide us through thought-provoking lectures and offer their valuable perspectives on cardiac surgery in transcatheter era. Thank you.
Okay. I thank Dr. Ye Jian and also Dr. Hong, okay, and also the participation experts. Our co-moderators will be Dr. Hong Miao Ki, right? And our participating experts will be the Zhang Zhongyi, okay, and the Bo Yang and Patrick McCarthy and Dr. Hong Qihong. Okay, so the first topic will be the root augmentation, the experience sharing by Dr. Bo Yang, and Dr. Bo Yang is the professor of cardiac surgery, and he is familiar with the thoracic aortic aneurysm, and his expertise in sparing aortic root replacement using the David and the Bentop procedures. And he also have done a lot of aortic dissection and thoracic and the thoracoabdominal aneurysm surgery, and also aortic valve repair. He's also get a lot of research funds from NIH, including the research topic on using so-called stem cell to model the thoracic aortic aneurysm. Hopefully that will clarify the underlying mechanism to develop and to prevent the aortic root dilatation. Let's welcome Dr. Bo Yang to share your experience of root augmentation. Thank you.
Yeah, thank you very much for the invitation. Actually, I'm at TVT right now, transcatheter valvular therapy in Phoenix, Arizona. I just finished my presentation there and discussion, and run back to my hotel room to give this presentation. Anyway, I am going to share screen. Can you see my slides?
Not yet.
No? Okay, maybe the wrong thing. Let me just share it again. Yeah, you should be able to see now.
Yeah, fine. Yeah, we can see it now.
Good. Let me see. So my task here is to talk about the aortic annular enlargement with the TAVR. In the TAVR era, and that's a lot of progression has been made, as the chairman mentioned. TAVR progress very fast. I want to update everybody here how we're doing in surgical valve, aortic valve replacement. What's new? What we can do better to help patients? First, I want to show this slide. Is I measured all the inner diameter, the opening of the valve. I found out the labeling of the valve is very misleading, and the opening of the valve is about 5 to 7 millimeters smaller than the labeling. The most common use of valve in the United States is 23 in male, 21 in female. The inner diameter here, you can see it's about 16 millimeter. That's a 23. A 29 valve, which is largest TAVR valve, the inner diameter after put it in is 23 or 24, and also depend on technique, surgical techniques. In Asian population, the most common use of valve is 21, and that end up the inner diameter, the opening of the valve is about 14 to 15 millimeter. So every valve we put it in, it's very small than the patient native annulus. This is same apply to the TAVR valve. The 23 avalute valve with inner diameter inside is about 15 millimeter. SAPIEN valve 14 to 15 millimeter. They're exactly the same. Like 34 core valve, avalute valve doesn't mean anything but anything larger than 34. The inner diameter is still about 23, 24. So don't be fooled by the size of the label of the size, and you really want to do a measurement yourself. So because of the discrepancy, the real inner diameter, if for any patients with a normal annulus, we do not do an enlargement. We end up reduce the annular area by 50 to 60%. The most common valve is 21, 23. You can see it's reduced very significantly. In the United States, this is about 2,000 patients, and the homograft, the mean annular diameter for male is 23, female is 21. That's why the most common use of valve in the United States for male is 23, for female is 21. Asian is a little bit smaller, it's about 21, 19 probably. And this inner diameter is about 14, 15, 16, 17. So if you want to have a valve with the inner diameter matches the patient's annular diameter, which is 23, you have to upsize the valve by 3 to 4 valve sizes. A 29 valve has inner diameter of 23, which is about size like this here. That's why the annular enlargement is needed. It's very important. From our institution, we did about more than 2,000 patients. The larger valve make a difference. This is 29 valve with a 10-year survival about 85%. 23 to 27 is lower. 19 to 21 is really low. Less than 21, the 10-year survival is about 60%. Multivariable analysis also showed the small valve, 19, 21, 23, 27 versus 29, the risk factors of optimal mortality and the long-term mortality. So we need to put a valve which with the inner diameter matches the patient's native annular diameter. Any valve we put it in without annular enlargement causes a mismatch because we reduce the diameter so significantly and the area so significantly. Traditionally, there are two techniques used by surgeons to enlarge the annulus, and it's all developed in the 1970s. One is NICS. You can upsize valve by one valve size. Manugian, you cut into the mitral valve, patch it up, and we can upsize the valve by 2 valve sizes. Because this is ineffective, one size, and this is more dangerous. You cut the mitral valve, everybody worry about mitral regurgitation. So annular enlargement is not commonly used in the United States. And if you look at the old data, even just before, even now, actually, this STS database showed that annular enlargement rate in AVR is about less than 3%. And we developed this technique in 2020. It's about actually 40, 50 years after the previous annular enlargement technique. And it's called a Y incision. We made, instead of cut down into the mitral valve LVOT, made 2 cuts. Come down here to in the Y incision. This technique cannot enlarge the aorta mitral curtain dramatically, enlarge the aortic root, enlarge the STJ, and then we can upsize the valve 3 to 4 valve sizes. So this is a 23 annulus, a patient. We upsize to 29. Look at the valve. The inner diameter is 23, 24 matches the LVOT and native annulus perfectly. And you can see the Strauss sewing ring, which is outside. That occupies a lot of space. So if we don't do the annular enlargement, put a 23 valve in, it immediately causes at least a moderate PPM, prosthesis, especially the mismatch, and reduce the annular area by 50%. So it's very important to do the annular enlargement. This is a short video to see how we do the annular enlargement. We made a transverse aortotomy. Now we cut between the left and non-commercial post. You can see here, this is left coronary here. We cut the left side to the nadir of the left coronary sinus, and the right to the non-coronary sinus. We saw a patch from left fibrous trachea to right fibrous trachea. You can see the annulus is not just so significantly from 23 to 29. This is now 20. This is 29 sizer, and I put it in size it and mark the place for the sutures, and then we put a 29 valve in for this lady who had a 23 annular size. This is 29 valve now. It fits perfectly. Then we enlarge the STJ and the proximal ascending aorta for future TAVR, and then we close the aortotomy very easily because of the enlargement of the proximal aorta. So this is the first 100 patients, the consecutive patient that we did this procedure. You can see mean age is 64, majority, 2/3 are female. Female has much higher risk to have a small annulus need enlargement. And 50% are obese. The BMI is 31, the medium BMI, and majority, 50% above is obese. You can see the 1/3 had the previous surgery, and 1/3 had the multiple procedures besides aortic valve, in annular enlargement, they could have CABG, mitral valve, ascending aorta, MAIDS, all the procedures, tricuspid. The native, after the debridement, and the native annulus is 21, we upsize by 3 to 4 valve sizes, and we are able to put a median size is 29 valve. Basically, if we don't do the annular enlargement, the patient get the valve like this, small. Inner diameter here about 14, 15 millimeter. Now they get a 29. Inner diameter 23, 24 millimeter. So you can see that this large valve give patient much better hemodynamics. Also longevity, long-term survival, I showed the slides before, because those valves degenerate with the calcification. You started with such large size, it takes much longer to become critical stenosis. And it will be a very good setup for the TAVR valve. TAVR, I'll show the CT scan post-op. So post-op outcome actually is quite good. We had one stroke after one person stroke. We had 2 patients that had a pacemaker. One had the third time redo. We took the old valve out of the damaged conducting system. One's first time AVI annular enlargement had basically 1% pacemaker rate. And we had one patient died who had radiation of the chest and abdomen and for lymphoma. She had aortic valve replacement, annular enlargement, mitral valve replacement, coronary artery bypass, MAIDS procedure, left atrial appendage ligation or excision. Because she had a radiation to the abdomen too, her mesentery vasculature was stenotic. And post-op day 35, she died from mesentery ischemia. Actually, she was all recovered, ready to go home. And she was over-diuresed and get the mesentery ischemia and died from guts ischemia, unfortunately. Nothing to do with the heart. So this is, you can see most patients, this is native annular size. This is a valve, we put it in. The red line means upsized by 2 valve sizes. Majority of those patients reach the largest valve sizes, including the tissue bioprosthetic valve or mechanical valve. Only 2 patients are upsized by 2 valve sizes, which is not largest. And then the blue line is 3 valve sizes, yellow line is 4 valve sizes, and the green line is 5 valve sizes. We had about 3 patients, and we were able to upsize by 5 valve sizes. In the 100 patients, the majority of patients, 64%, 2/3 of patients, they either had the 29 valve or the largest valve sizes. So most common valve used in this population is 29 size 29 valves, compared to current, as mentioned, in the United States, the most common use of valve is 23 valve. And we developed this technique in 2020. You can see the large valve size keep getting 29 valve size valve, getting more and more. It's about 85% now. And the smallest valve we put it in is 25, except the first case I was a little conservative and upsize from 19 to 18, 19 to 23. After that, everybody gets 29, size 25 to 29 valves. This is post-op. I follow those patients with echocardiogram 3 months, a year, 2 years, every year. And it's been about 2 years. Now you can see the hemodynamics looks really good. The grading probably is lowest and in the literature, in SAVA, even in TAVR. And the valve area is keep getting bigger. Actually, I was surprised to see that. It's 2.4 now. And in 2 years, I think there's the modeling of the native annulus and the LVOT probably make these EOA, the openings, even bigger of the valve. So this is the echocardiogram, including the AS patient and the small portion of AI patient. 2 things I want to point it out. Number one is the valve area significantly increased. The other one to point it out is the root is very significantly enlarged, the 40 millimeter. Why this is important? Because this is very important for the future valve in valve TAVR. If patient has large valve, say 20 years valve fails, it'll be very easy to put a TAVR into this enlarged 29 valve with enlarged root. This is the CT scan we showed here. This patient had the 23 annulus very small, the root size about 29 millimeter. We enlarge it, put in 29 valve in. You can see the root is 38 now. HCG is 38 from 27, very effaced. And the valve to coronary distance about 4 to 6 millimeter. We have CT scans of everybody, about 100 patients, and we did a study of the CT scan analysis. The anatomy is very favorable for valve enlarged salvo valve TAVR. We also did hemodynamics. There's no stasis around the large valve, and the post-op echo have showed no thrombus around the large valve. So the flow is actually quite well on the hemodynamic analysis. So the conclusion is, with the wide incision rectangular patch, any enlargement, we can safely and effectively enlarge the annulus by 3 to 4 valve sizes. This provide potentially better hemodynamics, long-term outcome, longevity of the prosthetic valve, and it's a very good setup for future valve-in-valve TAVR if it's needed. Thank you for your attention. This is my clinical research team and my funding.
Thank you, Dr. Bo-Yang. It's a very, very good lecture, and I think it's very inspiring, and I think it's especially important for in the era of TAVR. So I think it's a very good presentation. And we will leave discussions to the end, to the panel discussion later on, and we will proceed at the topic to the next. The next topic will be long-term durability of a pericardial mitral valve, implications for the decision between the mechanical and the tissue valve. This will be presented by Dr. Patrick McCarthy. Dr. McCarthy is the Vice President of Northwestern University, Northwestern Medical Group of the Northwestern University, and he is also the Executive Director of the Bloom Cardiovascular Institute. Actually, he trained at the Mayo Clinic and the Stanford University, and participated at the Cleveland Clinic. All very well-known medical centers. And afterwards, he went to Northwestern Heart and Heart Surgery program. And in the year from 1990 to 2004, he upgraded from the ranking of the hospitals from unranked in 2004 and up from 1990 to become the top 10 U.S. program in 2004. I think it's very good the management and the team, the surgical team, and also the heart team. So his primary focus is on the clinical integration of the Northwestern medicine program across the health system. So let's welcome Dr. McCarthy.
Good morning. Thank you, Professor Wei. Can you see my screen here?
Yes.
Good. Well, hello from Chicago. Pleasure to be speaking with you. Sorry that I can't be there myself. What I'm primarily going to talk about tonight, or this morning for you, is a presentation that we gave about a month ago at the AATS meeting. Steve Bowling and I from University of Michigan, where Bo is from, got together and were talking about there's not enough written about the durability of mitral valve bioprostheses. And so that led to this cooperation. And so what you'll be looking at will be data from Northwestern and also the University of Michigan. And really the point of this is to help us decide about a mechanical valve or a tissue valve for young patients. These are my disclosures. So in terms of mechanical or tissue, I want you to, as we talk about this, I'll be referring to a 55-year-old man, healthy, rheumatic valve disease that's heavily calcified, can't be repaired, has to be replaced, no atrial fibrillation. What's the best choice, a mechanical valve or a tissue valve? It's a decision that we have to make often, and we haven't had enough data about that. So there's controversy about which one of those two types of valves that you would recommend for these younger patients. The bioprosthetic valves have been becoming more common, and they do seem to be the most commonly implanted these days. But it is a choice of the patient ultimately with the direction of the physician. And many patients, of course, want to avoid an anticoagulant and also don't want to have a stroke. The mechanical prostheses, however, are recommended for younger patients because of the concern of structural valve deterioration and the need for reintervention. So with that background, the guidelines are pretty specific. The American Heart Association guidelines say if a patient is over 65 years old, it's reasonable to choose a bioprosthesis instead of a mechanical valve. The European guidelines have that age at 70 years. And over the past 10 to 15 years, the ages have waffled around between 60 and 70 years about whether to go with a mechanical or a tissue valve. So what about a mechanical valve? What should the patient expect? So this is a paper from the Mayo Clinic years ago, and this is looking at systemic emboli or stroke in patients with repair, a bioprosthesis, or a mechanical valve, and it was running roughly 3% per year. So it's a significant risk. As I tell my patients, 10-year, 30%, 20 years, 60%. If you're that 55-year-old patient that we talked about, it's a significant risk for having a stroke. This is looking at more recent data. This is from the PROACT study to see if we made much improvement here. Not much. The annual rate of thromboembolism still about 2.4% per year. So in that group of patients, they did not find an improvement with low-dose warfarin, so patients still are stuck on Coumadin, not on a NOAC or a DOAC for a mechanical mitral valve. And so if a patient has a mechanical mitral valve, they're going to have long-term need for Coumadin at this point and a significant risk for having a stroke or other embolus. So what about a tissue valve? The two critical questions that inform the guidelines is what is the need for reintervention and what is the risk of reintervention? Note that we're not talking about reoperation because we're in a new age. Many of the previous, if not almost all of the previous reports talk about reoperation. But now that we have mitral valve and valve, it's really a reintervention because more and more patients are having a transcatheter approach with a mitral valve and valve. So the need for reintervention, that takes us to the study that we did between the University of Michigan and Northwestern. So we talked about should mitral replacement age guidelines be lowered because there's better bioprosthetic valve durability. It was just over 1,500 patients between the two centers. The series began in 2004. We stopped accruing patients about a year and a half ago and had near 100% follow-up on that patient group with an average of about 5 years. Overall, during that time of follow-up, only 4.5% needed a reintervention specifically for structural valve deterioration. So it wasn't very common. This is looking at the rate of reintervention for structural valve deterioration by decade. So this, for instance, is patients 70 to 79 up to 30 to 39. As you can see, for patients over 80, their need for reintervention was very low. Also for 70 and 79. This group of patients in the 30s are frequently young women of childbearing age, and they don't want a mechanical valve because of the risk for Coumadin while they're pregnant. But if you look at the rest of these patients, this is low. So take this group of patients here who are 50, like the patient that I talked about, the 55-year-old patient, that at 15 years, we're looking at roughly a 20% need for intervention. So if you look at, briefly, I'll go through by decades, the 77 or 70 to 79-year-old, all indications, structural valve deterioration, endocarditis, perivalve leak, all of those, it's very low risk. If you look at the 60s, not much different from patients in their 70s. Where we're really focused on are patients that are younger, the ones that are below the guideline indication. And it was about 45% of our patients were less than 65. Again, not much difference between the 50s and 60s. And in fact, if you look at the 40s, 50s, 60s, no significant difference. So the durability for that younger age group actually looked very similar. Steve Bowling did this analysis to look at it in smaller age buckets and age groups. So for instance, if you look at it in 2-year intervals, the curve is pretty flat in terms of needing a reintervention, anywhere from 45 up to roughly 65 before, and then it drops significantly and is very high, of course, in the younger patients. But in this group, it actually continued to be quite low. So 45 to 65, it looked about the same. So that is the rate of reintervention. So what if they do need a reintervention? Well, what's the difference in survival? This is a paper from New York State database, and this is looking at survival and outcomes between those two valves, and specifically the group that we're interested in, ages 50 to 69. Survival curves are virtually identical, no difference in late survival between those two groups. On the other hand, there's this paper. This is the other coast. This one is from California. And this one, they concluded the long-term mortality benefit was for a mechanical valve as opposed to a biologic valve, and that persisted until age 70. There's some important caveats about this paper. One of them is that the big difference was in this young age group, but it's interesting that the 30-day mortality was more than twice as high for the patients with a tissue valve. It's on page 82 of the manuscript hidden in the appendix. So right from the very beginning, there was a difference. There's no randomized trials. There's no other papers that show a difference in 30-day mortality between the two prostheses. What that indicates to us is that there's some bias in this group. If you think of this as being a bell-shaped curve, well, these are likely younger patients that fall outside of the bell-shaped curve. They may have things that are not measured by the STS predictive risk of mortality, like liver dysfunction, drug and alcohol use, social determinants of health, young women, as I mentioned, frailty, cancer, patients in a wheelchair. So if patients have that sort of bad protoplasm, the bias seems to be towards putting in a tissue valve. In addition, what they noticed that, again, as I mentioned from the STS database and other studies, there's a very strong trend towards going towards bioprosthesis. During those years, it increased from 17 to almost 54%, and it continues to grow. The bioprosthesis group had a lower incidence of stroke, and a lower stroke or bleeding event was a significant risk factor for death. So the tissue valve patients are less likely to have a stroke or bleeding event, and then they're more likely to survive. So since that is lower with that, and that improves their mortality, and endocarditis is the same, the increased mortality is likely from reoperations, or, as I mentioned, the unmatched group at baseline, in particular in that young group. So what was their reoperation of mortality? It was 14%, which is very high in this report. It's one of the highest that's ever been reported. This is data from the STS database. And what they're looking at is operative mortality for patients that underwent a mitral valve reoperation overall was 6.6%, stroke in 2%, and most important regarding structural valve deterioration with bioprostheses that just slowly wear out. If they went through an elective non-endocarditis operation, the mortality is 3.4%, markedly different than the 14%. There's more recent data. This is from the Cleveland Clinic, published last year. This is looking at patients with a mitral valve replacement for structural valve deterioration. The group that had isolated valve replacement, the mortality was 0.75%. For a group of more complex patients that had coronary bypass, double valves, and a maze, et cetera, it was higher. It was about 7%. But for just replacing the valve, it's low. And then the Mayo Clinic had published something similar. The mortality for a re-op mitral valve was 4.7%, no different than for a primary mitral valve operation. And for the elective reoperation, that structural valve deterioration group is only 2%. In the report that we had at AATS last month, our reintervention mortality was 5.6%, little higher for reoperation versus mitral valve and valve. Separately, we're working on a series at Northwestern, and we have 74 patients with mitral valve and valve. The predicted risk of mortality, 4.6%, but the observed was 1.35%. So it does appear from multiple studies that mitral valve and valve is becoming a safer or a safe alternative for many of our patients. So what would happen to that 55-year-old healthy patient if that patient had a tissue valve? Well, I think you have to use a little perspective here. So the first mitral valve and valve was 14 years ago in 2009. The FDA approved it in the US in 2017. If that patient had a tissue valve implanted today at age 55, even with early failure, if that patient was one of the 20%, he'd go till 2038, and then most likely it would go until 2043. When you consider the progress that we've made with mitral valve and valve in a few short years, 20 years from now, certainly should be a safer operation. So it's time for a paradigm shift in how we think about replacement for younger patients with mitral valve. This is the paradigm from Sir Kuhn, looking at the normal science was our early valve experience. Bioprosthetic valves weren't very durable. Operations were more high risk at that time. There's model drift. The valves started to get more durable. Now model crisis and revolution, because now we have a very low risk procedure, mitral valve and valve. So we're here. It's time to change how we think about this. So instead of looking at age of 65 as a cutoff, we need to move on. So what should the guidelines say? It is a class 1 indication to do shared decision-making with a patient, and we should remove age as a specific cutoff, as if 64 is one type of valve and 66 is a different. We should talk to the patients about things like age, comorbidities, other need for warfarin like atrial fib, their lifestyle, patients that are very active in sports where they may have head injuries or work, and that group of patients with alcohol and drugs, any anticipated upcoming surgery like patients waiting for a transplant or pregnancy. So, and it's important that we remember that we don't live with the decision, the patient does. And so I think that the next set of guidelines should focus even more on this shared decision-making with the patient, because the durability of the valves has now improved. Thank you very much. I'll be happy to answer any questions, or we actually can move on, and we'll do that during the panel.
Well, thank you so much for your excellent lecture, and especially I think you pointed out that the decision making is very important, not only for doctors, especially it's important for the patient, because the patient would leave with the valves and then not our doctors. So decision making is so important. And let's move on to the next topic, and that will be chaired by Dr. Hong. Dr. Hong, thank you.
Yeah. Next topic is the speaker is Didi Checher. As you know, he's the worldwide TAVR expert. He's the French representative of the TAVR procedure. He's in Toulouse in France, and he had experience more than 5,000 of TAVR cases. His topic is the TAVR in a younger patient. This is a real hot topic in the TAVR field. Dr. Cheche, are you ready? Dr. Cheche, can you hear us?
3, 2, 1. TAVR in younger patients, thank you for inviting me to be part of this meeting. It's a real pleasure to provide this lecture about the implications of transcatheter aortic valve implantation in younger patients. So here are my disclosure. So the first important message that I wanted to discuss is the fact that TAVR has quickly expanded to lower risk patients. I recently published were the 3-year outcomes from the Evolute low-risk trial that randomized TAVR to surgery in low-risk patients, and the outcomes that were observed at 1 year were sustained at 2 years and remain the same at 3 years, with a difference between TAVR in favor of TAVR concerning the primary endpoint of all-cause mortality and disabling stroke. So that is reassuring data, telling us that at least at 3 years, we may utilize this type of device, TAVR, in younger patients. But this has inherent implications, because what we are seeing now in the United States is that below 65, TAVR is one of the options that is considered in close to 48% of the cases in the United States. So it's already happening. We are treating patients at lower risk, younger patients, with a TAVR. So this has consequences. Apart from the durability, there are very important aspects of the procedure that we have to anticipate, and most importantly, to prevent. First, the occurrence of pacemaker implantations. Second, keeping the access to the coronary arteries free, and at last, trying to anticipate what is going to be a TAV in TAV in the future. So life expectancy has become a quite central element for the decision making, and that is the key element, to my opinion, when it comes to younger patients. What is going to be the life expectancy of the patient? Because we know from the literature that if we treat patients with aortic stenosis with surgery, they're going to match in terms of life expectancy, get the same life expectancy, and join the curve of survival of a much controlled cohort of patients. So relieving the aortic stenosis has an impact. But when we speak about durability, we always forget about what is the life expectancy of the patient that we're going to treat. And it's not the same thing when we are aiming at treating a high-risk patient about 80 years old. And you can see that in this very important paper from Marlinson, surgical cohort, the mean survival, the median survival is less than 6 years for high-risk octogenarians. If you go downwards to younger, low-risk patients, 70 years old patient with a low-risk profile, the median survival is 12 to 13 years. So this is key to consider when it's time to select the appropriate treatment for our patient. Because if we use a device that is not going to match the life expectancy of the patient, the likelihood of a second intervention and potentially a third one remains higher. And whether we would start with surgery, then go for a reduced surgery before valve and valve, or TAVI first, then explant TAVI, and then TAVI and valve in valve, or TAV in TAV after the index TAVI procedure. All type of sequences may be anticipated by the heart team, provided a central, thorough assessment of the patient, trying to anticipate his life expectancy. What we also know from the literature is explaining TAVI devices is not a benign thing, it's not a simple thing. Within that explant TAVR registry, a high mortality and a high likelihood of reconstruction of the aortic root. So this is very important when it comes to the choice of the index procedure, the type of index procedure. Explant TAVI is not a simple thing. So when we speak about very younger patients, TAVI in younger patients, we need to anticipate what could be the second TAVI procedure, and with that redo TAVI, and what are the implications. The first concern that we have is the risk of coronary obstruction. Even if we can foresee in the future the emergence of leaflet preparation devices, it's already very important to try to understand, figure out what is going to be the configuration of the new TAVI device within the index TAVI that we have selected. And in this example, we can see that this is the same patient with that 3D simulation, able platform exactly at target. If the second device is a sapien 3 really high, the risk of coronary overlap is high. If the second device would be a sapien 3 placed a little bit lower, it's more leaflet overhang that can be anticipated. Another important message for lower risk patients, TAVI durability, and this is reassuring, compares favorably to surgical bioprosthesis. And this is something that we've understood from this randomized trial, the Notion trial, with the 8 years outcome that have been published. And you can see that when we compare TAVI to surgery in these low-risk patients, the survival is similar at 8 years between both cohorts of patients. So the durability of the devices seems to be there. When we talk about the structural valve deterioration that was defined in that trial as either a mean gradient above 20 millimeters of mercury, second, a mean gradient over 10 millimeters of mercury from baseline, or change from baseline, or the occurrence of moderate to severe intraprosthetic regurgitation or worsening from baseline. There is an advantage of TAVI devices as compared to surgical platforms, and that is something that is seen from a very consistent way in the literature. But at last, bioprosthetic valve failure seems to be similar between TAVI devices and surgical ones. Hemodynamic is really something that seems to differ and to differentiate TAVI devices, TAVI platforms to the surgical ones. Larger EOAs and lower mean gradients are achieved with the TAVI devices. Published were the 2 years outcome of the balloon expandable platform sapien 3 in low-risk patients, sapien XT at 5 years, sapien 3 versus SAVR. And what seems to be existent is potentially a higher rate of structural valve deterioration with the past iteration of the sapien XT. That seems to disappear with the sapien 3, and once again, this is quite reassuring, but we need to wait for a longer term follow-up data. Another very important message for this younger population is that hemodynamics post-TAVI affects quality of life and survival. We've seen that from the surgical cohort with increased mortality when the patient have either severe or moderate patient prosthesis mismatch. It's a little bit more controversial for the TAVI literature, but what we know is that if the patient has a residual mean gradient above 20 millimeters of mercury, this is going to impact 1 year rehospitalization rate. So more rehospitalization for heart failure. So leaving a residual gradient that is below 20 seems to have a positive impact. And this was confirmed in that Australian echocardiographic registry. And definitely, the higher the gradient is, the more impaired the valve hemodynamics are, the greater is the mortality for the patient up to 16 years follow-up. So this is really something that we should try to prevent: patient prosthesis mismatch and impaired hemodynamics. So there may be a difference in terms of platforms. We will need to wait for the SMART trial before providing clear answers to that question. Is there a difference between balloon expandable platforms and the self-expanding ones, particularly the supraannular one? Let's wait for the SMART trial. Results will be published by the end of the year, and so let's wait for it. So another important message is that thrombus and classification are in interplay and may play a role in valve degeneration, because these are the various components of the what is accepted as bioprosthetic valve dysfunction, whether it be structural valve deterioration with intrinsic permanent changes of the prosthetic valve, or non-structural valve deterioration that is an abnormality that is not intrinsic to the valve itself, whether it be regurgitation, patient prosthesis mismatch, net embolization, for instance. And at the end of the scope, we have thrombosis and endocarditis. Thrombus and calcification are playing in conjunction and generating that degeneration of the leaflets of the TAVI devices, whether it be extrinsic calcification that are within the thrombus or intrinsic calcification that are more within the leaflets. These could be triggers for bioprosthetic valve deterioration. So one of the reasons for the occurrence of thrombus is the fact that with the TAVI device within the anatomy of the patients, we create a neosinus, and that neosinus located between the stent frame of the TAVI devices and the native wall may play an impact, may be a location of choice for thrombus formation. Where have been identified several factors for leaflet thrombosis: lack of anticoagulation therapy, larger bioprosthesis, and significant paravalvular regurgitation. So one may take this into consideration when it comes to proposing TAVI to younger patients, because leaflet thrombosis seems to be associated with increased risk of stroke. So that could be one of the explanation of the slightly less favorable outcomes of the SAPIEN 3 implanted in younger and older patients at 2 years, potentially higher thrombosis occurrence in this type of platform. So one important aspect as well is that bicuspid active valves is quite frequent in younger patients, so we need to acquire knowledge about this type of disease. And key messages about TAVI bicuspid active valves: we know that bicuspid is a quite frequent disease in the general population, and TAVI patients in particular, 5 to 8% in the Western countries and up to 40% in China. We know that clinical outcomes are comparable between TAVI and bicuspid aortic patients, between tricuspid and bicuspid aortic patients when we use second-generation TAVI devices, with the caveat of potentially higher stroke rates. There have been signals of potentially higher stroke rates after TAVI bicuspid aortic valves, and at last, sizing is currently intuitive, but at the same time correlates with good clinical outcomes. So the idea is to try to put into numbers what we know and try to capture, to do a snapshot at what the type of knowledge and the type of sizing, oversizing that we utilize in bicuspid aortic valves. There is no single bicuspid aortic valves. You can see that there is a huge variety of differences in terms of phenotypes. And what is clear from the literature now, from this collaborative registry, that the association of leaflet excess calcification and neuropathy is frequent, close to 25% of bicuspid aortic valve patients, and is associated to first a threefold increase in mortality and a 4.5 risk of aortic root injury in these patients, and more than 5% risk of moderate paravalvular regurgitation. So that type of combination puts the patient at risk in terms of procedural complications. In younger and lower risk patients, the outcomes of TAVI for bicuspid are even more favorable, but there is still that signal of potentially higher type of stroke. So we conducted the BAVARD registry trying to capture the sizing methodologies utilized in contemporary practice. And the summaries, the key findings are: first, we observe a constant 10 to 15% of the under expansion of THV when the sizing is made in regards to the aortic annulus. So 3 to 5% of the sizing as compared to the aortic annulus seems to be enough in contemporary practice. Appropriate circularity may be achieved when we use second generation TAVI devices and proper TAVI technique, meaning pre-dilatation, repositioning if necessary, post-dilatation. And at last, it is really key to understand the configuration of the landing zone. Those patients with tapered configuration may be the one that require sizing more in the supraannular, at the supraannular level to prevent any type of injury to the aortic root. So Bivalent X data were recently published, and we kind of confirmed what was observed in retrospective registry. Bivalent X was a prospective registry with a single platform, the Evolut Pro, in all type of bicuspid, but the vast majority of the patients were type 1, left, right, or type 0 bicuspid aortic valve patients. So acceptable mortality at 1 year in this intermediate to high risk population, but higher stroke rate, disabling stroke at 4.7% of the patient, and this is slightly higher than what has been observed with tricuspid aortic valve. So potentially the systematic use of cerebral protection devices in bicuspid aortic valve patients that could be of high utility. So to conclude, the essentials to remember for TAVI in younger patients. So first, it has quickly expanded to lower and younger patients, lower risk patients and younger patients. Second, life expectancy is a key element in the king to understand what is the appropriate, what is the estimated life expectancy of a typical patient. Durability of the TAVI platforms favorably compares to surgical bioprosthesis up to 8 years. The hemodynamics, we've seen that affect the quality of life and the survival. Quality of life is one central element and an important aspect of the outcomes for younger patients. And at last, bicuspid aortic valve is a quite frequent disease. It's going to be even more frequent in younger patients. And TAVI seems to compare favorably in bicuspid and tricuspid patients, but further investigation is needed. I really thank you very much for your attention.
Thank you for the nice presentation. We actually regarding to the 3 presentation is a very interesting topic. Any comment or question about the 3 presentation?
Okay, Dr. Boyang, I want to ask, how do you treat for the bicuspid aortic valve for the enlargement altitude?
The bicuspid aortic valve actually annulus is larger than the tricuspid aortic valve in male and female, especially in male. And however, there's still some patients are still small annulus, 21, 23, and in our first 100 consecutive cases with the annular enlargement, it's interesting. I'm presenting at the TVT to 47% are bicuspid, 53% I try different aortic valve. So it's not uncommon we need to do annular enlargement for the bicuspid aortic valve. Your question is a very good question because the coronary can be, the left coronary ostium is close to the left non-commercial post. The way we're doing that is still the same way, and as we described and showing in the video, we still cut down through the left non-commercial post, then cut right underneath the aortic annulus. To the left side, and to the left, the fibrous trigon underneath the nadir of the left coronary sinus. And those sides most times shorter because the bicuspid aortic valve, the commissures deviate to the left side a bit. The non-coronary sinus side is always bigger, and you make a much longer cut, almost double the cut, right underneath the non-coronary sinus annulus, aortic annulus, and into the right fibrous, into the right fibrous trigon, but not cut into the membranous septum. By doing this, you can enlarge the root, put a patch about, I put a large patch, now 3.75 centimeter to 4 centimeter patch, and you can easily up 3 to 4 valve sizes. So there's no difference between those two, but because the left coronary artery is close to the left non-commercial post, it's still doing the same way, and so put the valve stitches around the suture line, then transition to the patch, as I showed in the video. And I have not had any patients at the left coronary arterial obstruction or right coronary artery obstruction or mitral valve issues.
Boyang,
yes.
Actually, your presentation is really fantastic for me. Is the root augmentation, the concept and the technique is quite really fresh, new technique. And I'd like to ask that some more long-term data. What I mean is that maybe 2 year, 3 year, or 5 year, and the incidence of some thrombus formation and the hemodynamic change, especially in the around the aortic sinus, about your technique, is the long-term data.
Yeah, that's another good question. The technique we developed was in August 2020. The first case I did was a small lady with annulus, about 18, 19. We did the first case and reported in JTCVS Tech. And so the longest time we have now is about 2 years. I follow those patients, 3 months of surgery, 1 year and 2 years with echo. And I always get a CT scan 3 months after surgery to check, make sure there's no pseudoaneurysm and those things. And the root is enlarged. There was no pseudoaneurysm in all the CT scans. And we have not seen any thrombosis of the aortic valve up to 2 years. And we did actually, as I showed, we did bioengineer did a flow study, used all the CT scans we got from the patients. And the large valve and the enlarge of the root didn't increase the stasis of the blood. And they only increased the clear time by 1.6% time compared to a normal aortic valve. So there's no mechanism of forming thrombosis around the valve. And we have not seen up to 2 years, no thrombus around the aortic valve either.
In your data, in your presentation of the some patient with the initial valve size lower than the 19 for the 16 to the 18, in some cases of it, the final valve size is 25. It's really fantastic. This is the case for the small size of the annulus. What about the large size of the valve size in this kind of patient? Your root augmentation technique is necessary for this kind of patient, or only for?
That's another good question. The first slide I showed, even a 25 valve, you put it in. The inner diameter is about 19 to 20. I do not use pledges or anything. I try to minimize any tissue protruding into the blood path of the valve. So the valve is much smaller. And the patient started with 25. You can put 25 in, end up with 19, 20. So that's much reduced. That's a lot of reduction of the effective orifice of the valve. If it's 25, I still enlarge to 29. And as our data show, the 29 valve patients had the longest, the best long-term survival. So I try to put a 29 valve for everybody if I can. And if I cannot put 29 valve, I just enlarge it. If somebody thought it was small, like 19 or 21, sometimes I put 25 or 27.
in the background of your technique in the clinical practice is that the actually inner diameter of the surgical valve is smaller than the initial valve size. And then you also comment that this situation is similar to in the TAVR valve. Is it true? What I mean
this is very true. Go ahead.
Small inner diameter size is maybe caused by the surgical valve cage itself. But you know that in TAVR valve, it's only metal, the outside of it. So degree of the reduction of the inner size might be smaller rather than in the surgical valve.
I agree with you. And, you know, I have not expanded all the TAVR valve yet, so I didn't get a chance to measure the diameter, the real diameter of other sides of valve. The expanded valve was 23 on the either the sapien or absolute valve. I have expanded another for 26. I measured the inner diameter. It's about 15 millimeter. It is like that, 15, 16 millimeter. I would recommend, you know, if you have the valve, the TAVR valve, ready valve, not put in patient. If you have one, you can just do a measurement with a dilator, do a 3D measurement, do not do the 2D measurement, and measure very objectively. You can put the dilator, the size through the TAVR valve easily. That's the diameter. And that's the physical diameter of the TAVR valve. That's what I did for the SAVR valve because I have access to those valves. And the company, they designed the inner diameter based on the normal annulus, which is 19 to 25. So that's why the 29 valve, before we put it in, surgical valve is 25. Put it in was about 23, 24. The TAVR valve, like average to 34. The inner diameter is about 20, 23, 24. Same thing. I asked the company. You can try to measure yourself. Just say what's the real diameter of the TAVR valve if you use TAVR valve or not.
Okay, Dr. McCarthy, you have any comment on these topics?
Bo, I really liked your technique. Just a couple of simple technical ones. I thought on one of the slides you referred to Dacron patch, but it looked as if you were sewing in pericardium. So do you want to elaborate on what kind of patch that you use?
Yeah, Pat, thank you for your comments, and it's good to see you. And I use Dacron patch for every patient, all the enlargement. It's because I have done many redos cases done my senior partner for other reasons, such as Cono or Rastali or those procedures. They use bone pericardial patch. Then they came to me for redos, and all the bone pericardial patch was calcified. I can't put any stitches through. So I have to redo the Cono, redo the Rastali, and put the Dacron patch to debride. And the Dacron patch or the Dacron graft, you know, even the out layer, you sometimes get calcified. You can still debride the calcification and put the stitches through. I just prepare for in the future. I need to do another SAVR. I can easily just take the valve out and do not touch the patch. So my valve stitches through the Dacron patch. Everybody's worried about the bleeding from the patch. Actually, the bleeding is not bad at all. No, as we do Taipei dissection, those Dacron graft, you know, they bleed a lot more. And you can see, and I think 80-90% of patients didn't need a blood transfusion. I do this procedure for redo for Jehovah's Witness patients too. I still not just rule to do everything. It's not bleeding is not the issue, but we have to be meticulous about that suture line. And if I see anything suspicious, dog ear or something, I put another interruptive stitch to make sure it's not, you know, have no risk of bleeding. And I think Dacron patch is, a lot of people use bone pericardial patch and they're comfortable with that, but just there's future calcification of that.
Congratulations. It was a really nice video. Good demonstration.
Thanks, Pat.
Excellent discussion. I have some comments and to Dr. McCarthy. First, thank you very much for your excellent talk and share your very interesting data. And my question, as you mentioned, your data show that there's no really difference in terms of redo mitral valve during follow-up between the age 40s, 50s, and 60s. So this is really interesting data. And as you mentioned, that could be the patient selection issue. And because we all believe if their life expectancy is quite different between these three age groups. So this could be, as you mentioned, be a patient, the other comorbidity or the failure of this kind of situation. That's why they got a tissue valve. So my question is, you think in the real situation, we really should move apply the prosthesis valve in the very, very young patients like 40 or 50s, because data show there's no really significant difference. And another comment is, you know, as you know, the number of patients for each center, for each surgeon in the North America per year is very low, and the reported only like five mitral valve cases per surgeon. So I'm pretty sure the redo mitral valve is the case for each surgeon extremely low, probably 1 or 3 cases in most of surgeons across the North America. So, but the data clearly show that the operator risk is really depend on center, depends on experience. So improve in terms of to improve the patient care or the reduce the surgical mortality. What do you saw to how to change this kind of clinical practice? You know, these kind of redo patients should be centralized into the field center with really experienced in mitral valve surgery. Thanks.
Well, I'll take the second question first. Thank you. So I think that what you're getting at is this sort of center of excellence idea. And I think that it is more than just doing redo mitral valve operations. It should also be a center that can do mitral valve and valve. And there will be some new data coming out about that, in fact, at TVT. And it has become a very safe procedure to do mitral valve. Now, just as we heard in aortic valve and valve, you know, there'll be the future findings. So we don't have long-term follow-up on a lot of these patients. But so far, the early results are looking very encouraging. And of course, the valve itself is bigger than an aortic valve. And so you can put in a bigger prosthesis. So, you know, I think going to a center that has either a good surgery, good outcomes with reoperations for valve explant and putting in a new valve or valve and valve is important. The first question had to do with the philosophy about basically what is the discussion with a young patient. You know, I use the example of a 55-year-old when I gave the talk, but even if it's a 45 or 50-year-old, you know, the question is about the lifespan of the patient and how do they want to live their life. There are a lot of patients that don't want to be on Coumadin. It doesn't look encouraging that we're going to be able to get patients off of Coumadin or on a particularly low dose based on the PROACT study. So as I mentioned towards the end, the discussion is about age, but also about lifestyle, you know, people that, you know, work in construction or athletes that, you know, snowboarding and areas like that. And a lot of patients knew people that had Coumadin and, you know, may have struggled with that in the past. And then, of course, there's the other ones with things like liver dysfunction where they don't want to be on Coumadin. You don't want them on Coumadin. You know, I leave it up to the patient at the end, try to give them as good of information as we can. I do say most do choose tissue valves these days. I do think that we should be looking forward at, you know, when they're going to have to deal with that in 2040 or thereabouts. And by then, I think we're probably going to be pretty good at doing either a safe reoperation or a mitral valve and valve. But the you know, novel part of our data was it's a very large series. The largest series before that of mitral pericardial valves was only about 300 patients. And so we had almost 1,500 patients. And, you know, the data speaks for itself. The durability looked almost the same as a tissue aortic valve. So it surprised us.
Okay, thank you. So there is only 1 minute left. So may I ask Dr. Huang, you just have a
just a short question
brief
for
comment. Yeah.
Dr. Cheche. What is the possible reason?
He's not on the line. Cheche, right?
He's not on the line?
Is he on the line? No. Okay. May you just give us a brief comment?
Question for the, because what is the possible reason for the bicuspid with a high stroke rate? The bicuspid, because he is a young group.
Yeah.
What is the possible reason for the group reason have a high stroke rate about the TAVR?
You have any comment on this? Your explanation? Do you have any?
It's reason, maybe the possible reason is maybe with a more high rate popular leak and the cause of thrombus. If that's a possible reason, we needed to routine anticoagulation for the bicuspid patient.
Yeah, Dr. Yeah. You want to answer this question?
Excellent questions. Why the bicuspid valve has led to a high stroke rate? That could be related to the procedure itself, and then the bicuspid valve is sometimes really calcified, and then you put in the valve in, it's probably non-circular, and then you want the redilatation probably more than tricuspid valve, because we know the redilatation or pre-implant dilatation definitely increase the risk of stroke. So that could be the one explanation. And the valve is, as in bicuspid valve, as it could be like a non-circular. So the valve leaflets more like folded. In this kind of situation, may also increase the risk of stroke. Data has shown. So this probably is the two combination. That's why the risk of stroke is led to high compared to tricuspid valve. Thanks.
Okay, because the time is up, and we have to proceed to the next session. So thank you so much for for Dr. McCarthy, Dr. Bo Yang, and
thank you,
moderators and panelists. Thank you so much.
It was a pleasure.
So after these inspiring lectures and the enthusiastic discussion, we now transition to the roundtable discussion. The focus of the session is on the topic of the patient prosthesis mismatch. We are privileged to have an outstanding group of experts who will dive into this topic and share their valuable insights. So let's commence this roundtable discussion and explore the complexity surrounding patient prosthesis mismatch. Thank you. So welcome our moderators, Dr. Li Guozhen and Dr. Carpun and Dr. Michael Riordan and our participating experts. Thank you.
Good morning, ladies and gentlemen. I'm Dr. Casey Lee from Zhenxing General Hospital, Taipei, Taiwan. It's my honor to join this section. This section is around table 3. The focus is on patient prosthetic mismatch. It's my honor to co-chair with Dr. Kapun, a cardiologist from Brisbane, Queensland University Hospital. And it's also my honor to co-chair with Professor Michael Riordan. Michael Riordan is a very famous, experienced cardiac surgeon from Houston. Actually, he's a native Houstonian and inherited the experience from Professor DePecki and Cooley. And he also participate many clinical trial about structural heart therapy. So let me introduce our other participant experts. The first one is Liu Xianbao. Professor Liu comes from China, Zhejiang University Hospital. He's experienced cardiologist, and the Professor Ho Kai Wong from Singapore National Heart Center. He's online. And Professor Bo Yang, a cardiac surgeon from Ann Arbor, Michigan University. And Professor Dan Zhu from Shanghai Chest Hospital, a cardiac surgeon. And my colleague, Professor Chen Yicheng from Zhenxing General Hospital. And the next panelist is Professor Michael Chixin Jiang from Hong Kong, Queen Elizabeth Hospital cardiologist, and the Professor Napun Takasaudan has come from Chiang Mai University Hospital, Thailand. He also a very famous cardiac surgeon, and also Professor Miao-Kan Ki Hong, Professor Hong from Yosen University Hospital, a very famous cardiologist. And the final panelist is Daniel Tai Liang Chen from Hong Kong, Queen Mary Hospital, a very experienced, well-experienced cardiac surgeon. So today our program will be first talk, a short talk by Professor Redden, and followed by my colleague, Professor Chen will show one of his case and a brief introduction of the patient's history. Then we move to speech from Professor Chen and Professor Jiang. Then we will have a short discussion, including a panel discussion about the Dr. Chen's patient, about the decision making and your experience sharing about this case. Then Dr. Chen will show the treatment of the final treatment about his patient. Then we have a final discussion about your share the experience. So now I hand over the microphone to Carl. Carl, please.
Thank you very much. So we'll quickly move on about this topic of patient prosthesis mismatch. You know, we have a lot of data from the surgical world. We need to learn about the transcatheter world. We couldn't get a better, more experienced speaker than Mike. If you want take it away, please, Mike, and enlighten us how we can deal with this dilemma. Thanks.
Well, thank you. Let me try to share my screen here. Okay, is the screen up for you?
Yes.
Okay, great. So in 5 minutes, we're going to talk a little bit about hemodynamics and patient prosthetic mismatch and outcomes. I've conflicted across the TAVR world fairly generally with pretty much all the valves. My major conflict is I'm a cardiac surgeon. I still like doing aortic valve surgery. So there are some things that we need to remember when we start thinking about hemodynamics. There are a couple of differences in the low-risk randomized trial that we ran in the U.S. One is that surgery for the first time had better hemodynamics than the balloon expandable valve, whereas the self-expanding valve had superior hemodynamics at every time point. So we did get a little bit better in surgery against the balloon expandable valve. Now, one of the things that we know about surgery is that we need to give somebody a big enough valve. And this was originally introduced to us by Ramatula back in the 70s. And Ramatula said that if you cannot give the patient an effective orifice area that is good enough for their physiologic needs, you have patient prosthetic mismatch. Well, that meant most of the aortic valves that were used in that generation. Pibereau and Dumasile came along and did a study with 68 patients where they looked at mean gradient versus index effective orifice areas, and they looked for bends in the curve. And that allowed us to come up with our current definition of less than 0.65 centimeters squared per meter squared with severe 0.65 to 0.85 was moderate. But remember, this is only based on 68 patients, even though we all use it every day. Now, we also went back when we did the Paragon study, which was the Medtronic pericardial valve. We had over 1,200 patients, and we did a similar study looking at mean gradient versus index orifice area. And what you find is that the smaller the index orifice area, the more the gradient goes up. You just don't see the bends that you saw in the Pibereau and Dumasile curves, which makes sense because we've added more patients in. But again, the smaller your orifice area, the higher your gradients and the worse you're going to do. Now, does it matter in TAVR? Well, this is Howie Herman's work from the Transcatheter registry in the US. And what Howie showed is if you had severe patient prosthetic mismatch after any kind of TAVR, even by 12 months, it was a marker for increased mortality. Now, as mentioned, we have decades of data in the surgical world. And this is from Fallon's work from the STS. And Fallon looked at almost 60,000 surgical aortic valves, isolated aortic valves, in patients that are 65 or older. It's what the low-risk patients seem to be being sent to us now. And what Fallon showed is that any degree of patient prosthetic mismatch was associated with a decreased long-term survival and increased hospital readmissions, both for heart failure and for reintervention. And Flaming showed us that if you had patient prosthetic mismatch, it was a marker for early structural valve deterioration. And as we showed recently at the ACC, even moderate structural valve deterioration doubled your risk of dying and double your risk of reintervention. Now, there are a number of things that are related to structural valve deterioration: female gender, small body surface size, small valves, small EOAs. But there's only one thing that's really associated with structural valve deterioration and poor late survival, and that's patient prosthetic mismatch. Now, in the low-risk trials, if you got assigned to the surgical arm versus the TAVR arm for the self-expanding valve, you had a 5 times greater risk of structural valve deterioration of a moderate or greater patient prosthetic mismatch. And one of the interesting things about this is if you go from a large annulus to a small annulus based on CT sizing, for surgical valves, the rate of patient prosthetic mismatch soared. For the self-expanding TAVR valve, it did not go up at all. So these are one things that we as surgeons certainly have to think about and compete against when you have people with small annuluses. Now, does it make a difference? Well, this is in the Certavi intermediate risk trial. We did a 6-minute walk before you're treated at 30 days, 1 year, and 2 years. Not surprising, TAVR won at 30 days, but still won at 1 year and 2 years. And that's probably because the mean EOA for the TAVR valves was 2.06. For the surgical valves, it was 1.8. And so with this increased risk of patient prosthetic mismatch also seems to impact your ability of exercise tolerance. In fact, Blyzek showed if you had patient prosthetic mismatch, you could not reach normal METs on an exercise treadmill. Now, does it really make a difference? So this is the 3-year data that John Forrest just presented for the low-risk trial. We know that TAVR has an early advantage over surgery and mortality. And in stroke, the primary endpoint here was all-cause mortality disabling stroke. The delta was 1.8 at 30 days and 1.8 at 1 year. The question's always been is this going to last? And what is it related to? Well, it decreased to 2 at 2 years and 2.9 at 3 years. So in the low-risk trial for the self-expanding valve, we actually see these curves diverging. And it may well be because these younger patients are living long enough that death as a competing risk is not making a difference. In some of the higher risk cases, people have said, well, it doesn't matter that much. It's probably because they're older and they're dying at such a rate you can't see it. These younger patients, it's starting to stratify out. And of course, that led to the US guidelines that says if you're 65 or younger and live 20 years or more, you should still consider surgery. 80 years or older and live 10 years or less, and you're a good candidate for transfemoral TAVR, you should have TAVR. Between 65 and 80, it's the physiologic risk of surgery, the anatomic risk of TAVR, and the patient's wishes. I often get asked by cardiologists if I have somebody that fits in as a low-risk patient, could have either TAVR or surgery, what should they have? And the first thing I ask them is, tell me about your surgeon. If you have a surgeon that's sending back 19 and 21 valves, you might as well just have a TAVR. I know that Bo was on before this, and I'm a big believer in Bo's annuloplasty. We do it in about 40% of our patients. And I think if your surgeon's sending you back 25 and 27 valves, surgery is a good first option because it's a good landing zone for a future TAVR. I think that if you don't know it, you should go look at Bo's work and how he does this. I do it a little bit differently. I don't use a flat piece of Dacron. I take a 30-millimeter graft that I cut in half, and I use the curve of this graft to fix this, and I take it all the way over to the pulmonary artery. But in our OR, the minimum a woman will ever leave with is a 23. The minimum a man will ever leave with is a 25. And to prevent patient prosthetic mismatch, everybody gets a CT scan we do an area-derived diameter of the annulus and pick a surgical valve that has an inner diameter that matches that. So thank you. I think it's very important to remember that patient prosthetic mismatch kills you and it brings you back into the hospital. And it's going to be critically important that we all avoid this. And I'll stop sharing.
Thank you for Redden's Michael's great talk. So now Professor Chen will show his case with us.
Good morning, everybody. I'm Dr. Chen from Zhenxing General Hospital, Taiwan. And now I'll present my case. Can everybody show my slides? Okay, next one. Next slide, please. Okay, this is the 80 years old female. His height is 146.8 centimeter, and his weight is 46.7 kilogram. The PSA calculated as 1.4 meters square. She's not taking any alcohol, betel nuts, or cigarettes before. Her chief complaint was progressive intermittent dizziness and frequent syncope in the recent month. Next slide. Okay, so she came to the hospital after a series of examinations, including echocardiography, end up with valvular heart disease with critical aortic valve stenosis. The aortic valve area calculated from echo is 0.75 centimeters square with moderate aortic valve regurgitation. She has congestive heart failure with NYHA functional class of 2 to 3. She has mild coronary artery disease with single vessel. The AOAD is about 30 to 40% stenosis. She has sinus bradycardia, rule out sinus syndrome. She also has peripheral artery disease with atherosclerosis over bilateral iliac arteries. This is her transthoracic echocardiography. We can see that the area calculated is 0.75 centimeters square. This is the transesophageal echo. We can see that severe calcification over the cusp. Our TAVI member did the CT calculation for me, and we can see that the area of the aortic valve is not circular, it's kind of elliptical with a minimal diameter of 18 millimeter. The maximum is 23.8. So the other calculations, for example, the sinus tubular junction is about 25 millimeter. The right coronary height is about 15 millimeter, and left is 30 millimeter. The annulus is the maximum is 23.8. The minimum is 18. So it's a kind of elliptical. The LVOT diameter is around 16 to 25 according to the calculation. They also did a simulation using the SAPIEN valve S3. You see that this is a 20 millimeter valve. It's kind of slightly oversizing of the aortic. So this is the case.
Thank you, Dr. Chen. Thanks for a very concise presentation on all the relevant anatomical factors. So I think the progress we'll have 2 other speakers analyze, and then we'll come back to you, please, for what you did. So it's my pleasure to introduce Dr. Chen from Hong Kong. I think we've heard a little bit today about mechanical and tissue valves, but perhaps even down to the surgical valve, there are obviously differences between valve designs, and I'd love to learn from a cardiac surgeon how he would decide. So Daniel, please take this away. Thanks.
Thank you, Carl, and nice to meet everyone here. So in the coming 5 years, in talking about choice of surgical valves, so basically that's kind of a speaking out of a surgeon's mind right before we doing the TAVR. But in the context of risk of patient-prosthesis mismatch, I think the basic principle, just like Dr. Reardon mentioned, we try to avoid the PPM because it's bad. So in order to doing the decision, these are some information we surgeons would like to know. Now, of course, age is the most important thing. And basically, on the other hand, we like to know the life expectancy of the patients, because that at least help us what type of a surgical valve we are going to do, or what we're going to choose. So we like to know what kind of comorbidities that affects the life expectancy of the patient. And one interesting thing is that I like to ask about how old their parents are, because we think that the longevity of lifespan might have some genetic running in the family. So sometimes when we know how old is their parents, may have give us an idea that the life expectancy the patient will be. And of course, nowadays, patient preference is very important. What kind of job they are going to do, what hobbies they enjoy. And in Hong Kong, definitely dining is one of the favorite hobbies in Hong Kong. So we like to know what how tolerable they can be with the anticoagulation. And nowadays, for surgeons, we are quite open for them to choose the particular types of heart valve prosthesis. And of course, we like to see whether the patient's having an extreme body size, and also whether any particular disease that cause a higher chance of a structural valve degeneration if we choose the tissue valve. So when we have all this background information, nowadays, I quite recommend to use this app. It's a kind of information app developed by Dr. Vinny Bapak and his group. So it's a family of those very famous valve-in-valve, aortic and mitral valve app, which is available in our smartphones. So it got all the information of available brand and size of the prosthesis. So we can key in the patient information and see what size we are going to use, trying to avoid the PPM. So let's say after every information, we like to see whether the patient surgically is a low risk, intermediate risk, or high risk patients. We have definitely in the low risk patients, we are doing something more than just changing the valve. So for the high risk patient, probably we will probably get ignoring the PPM or just refer for a TAVR program. But here I like to stress again, for surgeons, we should have a low threshold for doing a root enlargement and putting in a larger valve. So first of all, I think for doing a root enlargement, the risk is relatively low. This is a meta-analysis showing that although compared to simple AVR, doing root enlargement, the mortality may be increased, but definitely we bring our patients out of the PPM. And also the risk can be compensated by more of the experience. And also minimally invasive approach is feasible with experience, of course. And also, if we choose to use the tissue valve in patients, thinking about the reason of a future valve-in-valve, I always use this example. One of my patients, I put in a mitral flow 23 valves 10 years ago, and then now the valves need a valve-in-valve. But you can see that the leaflet, everything is definitely recovering both of the coronaries, and the roots per se have been engaged basically by all the tissue valve itself. So in our locality in particular, we need to do a root enlargement in order to get in a bigger valve, also a bigger sinuses, in order to avoid this. So instead of doing extra things, if we use something fancy like the Stenosis valve, studies have shown that using a Stenosis prosthesis, definitely the gradient will be lower, and then we have a larger EOA. But there are a lot of long-term comparative studies showing that the long-term results is quite similar to using a conventional valve. However, when we need to put in a Stenosis valve, the surgical techniques is more complicated, and also some durability issues. In particular, some early products, they have an early failure and high structural valve degeneration risk. And this kind of a data, well, surprisingly, is used most commonly in the comparing the TAVR valve as well. So based on this, the technical issue, durability issues, now the use of a Stenosis valve is out of the favor. So on the other hand, if we, in some high-risk patient, we just try to ignore the PPM, put in the conventional valve, which is not quite recommended nowadays. What types of valve is better? This recent meta-analysis shows that there is no difference in the long-term mortality, whether you use a tissue valve or mechanical valve is a small root. But for the tissue valve, they have a higher rate of a structural valve degeneration and causing less LV regression, as also mentioned by Dr. Reardon in the previous presentation. So also technically, for the mechanical valve, the profile is smaller and it's shorter. So that's why in small roots, most of the time, we tend to use a mechanical valve in a small annulus if we want to ignore the PPM. And then last but not least, which is the sutureless valve or the rapid deployment valve. So for this kind of valve, it's more like the TAVR valve. So the anchoring system is based on the stand outside of the valve, which makes the sewing cuff smaller, and potentially we have a bigger EOA. And a lot of comparative studies comparing the sutureless valve to the standard conventional valve, showing that the gradient and the EOA is better with this group of valve, except that in the PERSIST AVR trial, which is the randomized control trial, showing their gradient and the EOA are quite similar compared to those conventional valve. And most data is coming from the peripheral valve. So, but the trade-off is that by using this valve, they noticed to have a higher pacemaker insertion rate. So this is my conclusion. So choosing a prosthesis for patients with a high risk of a patient prosthesis mismatch. Definitely nowadays we encourage surgeons to do a root enlargement so that we can use our preference kind of a prosthesis in the low risk patients. And the bioprosthesis probably might not be working that well in the long term in the small annulus. And also using of the sutureless valve in the high risk patient could be a bailout option. So thank you very much.
Thanks, Dr. Chen, for a fantastic overview of some of the subtleties for surgical valve choice. So again, if you can please stay on the line, we'll move on to the next talk, please, on decoding patient prosthesis mismatch in the context of TAVI. So it's my pleasure to introduce Dr. Michael Chang from Hong Kong. Please enlighten us. Thanks.
Thank you very much, Chairperson. So let me try to share my screen. All right, are you seeing my screen?
Yes.
Okay. All right. Good morning, everyone, and I'm honored to be invited here to share with you all. So I'm Dr. Michael Chang from Queen's Hospital, Hong Kong. So I had my structural training in Henry Ford, USA. So I'm here to talk about decoding patient prosthesis mismatch for the TAVR part. So which valve to choose? I have no conflict of interest to disclose. So there are a lot to talk about. There are currently numerous TAVR valves that could be used for, sorry, let's slide this. Okay, so there are currently numerous TAVR valves in the world that, so here I'm listing 3 of the most commonly used valves, including a Sapien, Avolute, and an Avatar. Of course, there exist many more of them, but these are the ones with the longest history and long-term data. So which valve would you choose to prevent patient prosthesis mismatch? Before answering that question, we have to understand what exactly is patient prosthesis mismatch. So the definition has already gone through by Professor Riescher before. So the definition is when the prosthesis function was actually normal. However, it's inadequate for the patient's body size. So when the gradient is high, we deduct the reference EOA from the measured EOA, and the result was more than 0.3. This signifies actual intrinsic valvular problem. However, when the result is less than 0.3 and the index EOA is less than 0.85 or 0.7, it signifies the presence of PPM. And the reference range of the cutoff could also be found in the VAC3 criteria, which is very commonly quoted. Now we understand what is PPM, so why is this significant? In this very large meta-analysis involving over 27,000 patients, severe PPM, as circled in red, is associated with increased cardiac and all-cause mortality, while for moderate PPM, there's a similar trend but not yet reaching statistical significance. And in another study with over 62,000 patients with TAVR done either with SAPIEN or CoreValve, 2 independent risk factors were identified to be associated with severe PPM, which includes small valve size use with less than 23 millimeter in size or valve-in-valve procedure. Hence, with the use of supraannular valves, a bigger size valve could be used to decrease the risk of severe PPM. So the aforementioned study and also numerous studies have shown that there are 2 main predictors for PPM. I'm going to go through each of them very quickly. Firstly, on valve-in-valve. So the effect of PPM is usually not immediate, so we have to look into studies with longer follow-up. In this VIVID trial, VIVID valve-in-valve study involving around 900 patients using both CoreValve and SAPIEN valve. Smaller valve prosthesis use, as defined with true ID of less than 20, was associated with significantly higher mortality. And CoreValve was associated with lower incidence of reintervention compared to balloon expandable valve, hence suggesting that self-expandable TAVR performs better in valve-in-valve TAVR situation. And next up onto patients with small annular size. For small annular size patients, we have this choice extend trial involving Evolut and SAPIEN TAVR patients. Evolut valve is associated with lower mean and peak gradient for both smaller and bigger annular size, with the difference in mean gradient being more marked in smaller annular size as shown on the left side of the slide. But why does elevated mean gradient matter? I think we already know about that. So using the National Echo database in Australia, valvular hemodynamics were characterized in over 6,000 patients undergoing this time both TAVR and SAVR. They were then classified to be having either normal all the way to severely impaired valvular hemodynamics, IVH in short, according to their transvalvular gradient. Results suggest that there is a increased long-term all-cause mortality for moderate and severe IVH with hazard ratio of 1.4 and 2.0 respectively. And the threshold for increased mortality is a mean gradient of more than 22.5. So now we have established that high gradient leads to poorer outcomes. So which valve performs better? In this in vitro study of 2 commonly used TAVR valve, SAPIEN 23 or Evolut 26, both Doppler and invasive gradient were measured for different flow situation. Results showing that in normal and high flow situation, as is depicted in the middle and right bars, Evolut Pro was associated with lower gradient in both Doppler and invasive measurement. In another study with real-life TAVR patients using 23 SAPIEN valve and again 26 Evolut valve, Doppler gradient was measured 1 month and 1 year postoperatively. Results showing that Evolut valve has significantly lower mean gradient at both time points. So I'm going to quickly show you a case I performed last year with a patient with a failing small valve prosthetic SAVR valve. This is an 82-year-old lady with SAVR performed with a 23 millimeter Hancock valve 8 years ago, presenting with MYJ class 4 symptoms. Echo and catheterization confirming severe AS. As you can see on the CT, the valve prosthesis is very small in size. So this patient is at the highest risk of severe PPM, as both highest risk factors were present, being the valve-in-valve procedure and small valve size. As bilateral femoral access were too small, so we performed the transcable analysis, showing a tiny few millimeter hole feasible for access despite the extremely calcified aorta, as you can see. So 18 French big sheath was sent up, and the transcable hole Oh, and I choose to use a 23 millimeter Evolut Pro Plus to achieve a larger EOA in this patient of very high risk of PPM, and the valve was nicely deployed with excellent hemodynamic result as well. The transcatheter hole was closed with an A10 ADO1, resulting in type 0 closure. So in summary, severe PPM is associated with increased morbidity and mortality. Valve-in-valve TAVR and small annulus patients are at the highest risk factors for PPM, and supraannular self-expanding TAVR was shown to have lower mean gradient, larger EOA, and less PPM and BVD risk. So with this, I'm going to end my talk. Thank you very much.
Thanks, thanks, Dr. Chiang. That was fantastic, an overview. So with all that we have heard now, and for your particular case, Dr. Chen, in terms of I think the perimeter was 64, the area was about 342, the sinotubular junction was at least 25 or 26 millimeter. In the context of patient prosthesis mismatch minimization, we'd love to hear what you did with the case.
So yeah, any comment from the surgeon? I mean, the online surgeon, Professor Boyang or Professor Reardon, about Dr. Chen's patient?
Well, obviously, you have somebody with a very, very small annulus. So obviously, if we're going to operate on this lady, we're going to make her annulus bigger. But, you know, if you're going to do a TAVR, we have pretty good data that the smaller the annulus, the better you are off with the supraannular self-expanding valve. There is some data that the intraannular navitor may be fairly equivalent. As you know, the SMART trial was just completed, which was a randomized trial between balloon expanded and self-expanding and small annulus. So we'll get some randomized data coming up. We just don't have that yet.
Yeah, and I agree with Mike. And this lady is 80 years old, right?
Yes, she's 80 years old.
Yeah, what's her life expectancy you are seeing here for her?
Well, the average life expectancy in Taiwan for female is around 83.
So I think TAVR will be good choice for her, right? And you know, has good anatomy for TAVR, and then mild coronary artery disease, and you put the Evolut 26 Evolut, probably you can put and give her a lot of relief. Yeah.
Well, I'll make one more comment. As somebody who's 70 years old, we start talking about how long people are going to live, and the quality of life for each year you live goes down as you get older. And I can tell you that my quality of life between 69 and 70 is nowhere near what it was between 39 and 40. And so a lot of these people, once they get to be 80, want to get well as quickly as they can and get back to life. And they're not worried about living to 95. They're worried about their next 5 to 10 years. And I can operate on these people, and I will get them through surgery, but their recovery will be difficult.
So I think Dr. Chen's patient is 80 years old. So if we change the age into 50, so what's your comment? I mean, the cardiologist and the cardiac surgeon about the ladies, the small body size and small artery annulus. So how about in age of 50? What's your opinion about in younger patient? Dr. Chen?
What age?
50.
50. For me, the patient age is 50. I strongly recommend the surgery first. 50. Yeah.
Yes, and for me, I am the surgeon. I will do the root enlargement and put the bigger valve.
Kay-Woon, let's go along with more cardiologists before we ask the surgeon. Kay-Woon, what would you?
Hi, thanks, Carl. I agree if the patient is young and low surgical risk, surgery should be the first consideration. But if TAVI is the only choice, then we got to consider whether to put in a balloon expandable valve versus a self-expanding valve. The considerations factors include the feasibility of TAV and TAV when the first TAVI valve fails, the hemodynamics, as well as coronary access. So if a 50-year-old patient cannot have surgery and we have to put in TAVI, those will be the consideration. The tendency when such young patients are treated will be to put in a short balloon expandable valve such that there is room or possibility for TAV in the future.
Well, as a cardiac surgeon, let me make a pushback on that. You're worried about what may happen 10 years from now versus what's going to affect your patient every single day, and that's the hemodynamics they live with and the valve durability that they live with. And right now we have, the recent data that, at least for the self-expanding valve, the durability at 5 years is better than for surgery, and we know the hemodynamics are better. And your patient lives every single day with that. They may never come back for coronary access. They may never come back for valve-in-valve, but they do live with their hemodynamics every day. So I think that's something you need to consider, but to me, that's the second consideration, not the first.
If it's 50 years old, this lady will live another 33 years, probably based on your longevity in Taiwan right now. And I probably definitely give an enlargement, either a mechanical valve or a tissue valve. I lean toward mechanical valve. She's young, and probably his annual is about 21. We can upsize to 27 mechanical valve. Give her take coumadin. If she does not want to take coumadin, we'll put the large bioprosthetic valve with 27 and plan her for valve-in-valve TAVR. And it's very interesting. And the consideration has been changing. I had one patient, just one patient. She had a 29 bone pericardial valve when she was 28. She came to me for type A dissection, not for the valve problem, when she was 71. The valve is still functioning for her, not open as big as normal anymore. It's significantly narrowed, but she's a small lady. BSA was at 1.7, 1.8. And the valve still functioning okay for her for 43 years. I mean, this is one case kind of extreme, but the concept is if we put a large valve at the beginning, not like a 21, 23 valve, like in all the trials, I think the bone pericardial valve will last longer, larger valve will last longer since the mechanism is stenosis with the calcification. So, I would recommend, for this young lady, mechanical valve or large or tissue valve with the enlargement, definitely.
Or a Ross procedure. If you have a good Ross surgeon, another very reasonable thing in somebody like this, a Ross procedure is the only aortic valve replacement that returns you to a normal survival curve. The only one.
Professor Riordan, for the Ross procedure, we need a good homograph for the pulmonary valve, but in Taiwan we don't have a homograph for pulmonary valve, so not much Ross procedure performed in Taiwan. I know that in US some surgeons perform Ross procedures, but we are worried about one valve problem become two valve problem.
Yeah, if you have a good Ross surgeon, that's really not a big issue. The risk is very low, and I would agree with Bo. We'd have a hard time putting a TAVR in a 50-year-old unless there was something very wrong with that 50-year-old. And typically 50 or less, I put in mechanical valves, and I agree with Bo. The bigger valve you put in beforehand, the longer that valve will last, the longer the runway you have before structural valve deterioration.
Dr. Hong?
Yeah. Even though I recommend the surgery in this patient who is 50 years old, the surgeon should not input the small size of the surgical valve. Right. You need absolutely, this patient need the aortic augmentation, because this patient have a chance to have a re-intervention with a TAVR procedure.
Just a technical question from a cardiologist. I refer to my surgeon to ask for root enlargement and get the biggest valve in, and sometimes I get disappointed after surgery that didn't transpire. What are the predictive factors, perhaps from Bo and Mike? How do you predict on CT that you can definitely enlarge before you go in, and then suddenly it becomes not feasible an option?
Well, Bo's the expert on this. He developed this technique, which I think is just one of the biggest advances we've had in the last 10 years. But we get CTs on everybody now, Carl, that we're going to operate on. We've learned so much from TAVR. And so we know who we're planning on doing enlargement starting off. And as I said, we do an area-derived diameter and then ask ourselves, can we put a valve that has an inner diameter based on what we're seeing? And if not, we know we're going to do an annular enlargement. We tell the patient we're going to do it, and we plan for it.
Yeah, I agree with Mike. The pre-op CT helps quite a bit, and the only patient we cannot do this enlargement, and is the severe calcification of the aortic mitral curtain extend into the mitral annulus. Basically, nothing we can cut, nothing we can solder patch to. And that's the only contraindication I have seen now prevent me to do this procedure. It's a newer procedure, and I think our surgical surgeons anywhere and have been adopting this technique, and it's not that difficult. And once you get over that field of cutting down there, and pretty much all the surgeons, cardiac surgeons, should be able to do this. And yeah, if the really is calcified the mitral annulus and the aortic mitral curtain is calcified, then there's a chance to do a total root upsize the valve with a root replacement. You can up to 2 to 3 valve sizes with a root replacement.
Okay.
Professor Reardon and Professor Chen. So it's great that we have so many cardiac surgeons here, experts. So I always have a question. So say like if for 80-year-old, I'll definitely probably more tend towards a TAVR procedure, but for 50-year-old, after the root procedure, after the root enlargement, of course, a lot of anatomical concerns. Sometimes you may not be able to dilate it that much. In those situations, if you are not to put a mechanical valve, would you consider preferentially going for a fracturable or stretchable valve or tissue valve implantation in view that possibly in 10, 15 years, the patient might have to undergo a valve-in-valve procedure, which again, it will predispose the patient for further PPM because we have the very small root to start off with? Or is there any other technical consideration that we think of? Thank you.
Well, I don't know what Bo thinks about this, but I worry about fracturing a valve where there's a big piece of Dacron in there. We just don't know what that's going to do. And you can always put a big enough valve in there if you use a Y angioplasty. I think, Carl, you get disappointed because your surgeons are probably doing Nix and Manugian enlargements, which lets you go up 1 and at most 2. You can always go up 3 and often 4 times sizes with this Y angioplasty as long as you learn the technique. And so if you're putting in 27 valves and 29 valves, you don't need a fracturable valve. But I really worry about breaking this thing when there's a Dacron graft there and what that's going to do because it's not a native annulus. I don't know, Bo, this is your procedure. What do you think?
Yeah, you got all the points, and with this technique, and the most frequent valve we use is 29. It's 2/3 of patients gets 29, and we sometimes use 25, 27. So you get large valve. You don't need to crack the valve anymore. And most people crack is 21, 23 valve, and try to break the valve. That doesn't give you too much expansion, 1 or 2 millimeter probably, and you also risk the ruptured annulus. So I don't see any advantage to put a valve, fracturable valve, large valve into this technique. If you really want to do that, I'm not sure. And I don't think you can crack that part so into the Dacron graft because that's a regular graft, and you may be able to crack the annulus, the valve, and the other native tissue part, but I don't think you need to because the valve is so large.
For my idea about the root enlargement is not about the technique, but it's about the experience. This is really important because in Thailand right now, as you know, that the single valve is the operation for the young surgeons, and if there is the problem about the small root, they tend to put the small valve. And in Thailand right now, we try to encourage every surgeon to do the root enlargement. I have one question about the Ross operation. For Dr. Michael, what is the cut point age that you will do the Ross operation? If the patient older than that, you will change the valve.
Well, it's like everything else. It depends on your patient and what they're doing. If you have a 50-year-old patient that runs marathons, they're better off with a Ross, because we learned a long time ago that until your EOA is greater than 2 and preferably 3, you can't really increase your flow without increasing your gradient. If you are 40 and you sit on the sofa all day, you probably don't need a Ross. I'm 70 and I get up and go to the gym every morning at 4 a.m. I want if you operate on me, I'm going to come see Bo and I'm going to get a 29 valve. I don't need a Ross at 70. But I mean, I think it's not just an age. Typically I think 40 is about as old as I normally go, but it depends on how active they are. I mean, it's the only one that gives you really normal flows and brings you back to a normal life expectancy.
Okay, we have to move back to Dr. Chen's patient.
Okay, I will present how I treated this patient. Okay, a patient choice, as everybody says, that maybe TAVR will be the first choice, but in Taiwan, the insurance for TAVR, you'd have to meet some criteria. For example, the longevity Euro score 1 should be greater than 20%, or SDS score greater than 10%. But for this lady, her score is 8.44 and 3.375. So she is not qualified for insurance pay for TAVR. And self-pay TAVR in Taiwan is about 50,000 US dollars. So it's very expensive. So she's not afforded. Due to financial consideration, so she chose TAVR. And her choice of insurance pay valve will be St. Jude Epic Supra. Epic Supra has a small diameter. So we see that Epic Supra for 19 millimeter, the EOA will be 1.2. And if we calculate the EOA, it will be 0.85. It's a very small valve. So the ideal valve choice for her will be something greater than 23. And then we know that the root enlargement will have to be done for these ladies. And as before, Dr. Yang and the other specialists present that we have a posterior enlargement, for example, Manokian and Nick. And this enlargement will have some influence on the mitral valves. And maybe you saw in the patch onto the anterior leaflet, later on will cause some calcification or some problem with the mitral valve. And we also have an anterior enlargement like coronary stent, and you have to deal with the ventricular septum defect. And so what I did a Young's method that published by Professor Bo Yang 2 years ago. And this is a wide incision, and we use the patch. I use bovine pericardial patch to enlarge the defect, and then I use the outside in on the page. And before I did it, as we said, we don't have much experience, so I took a bovine heart and practice on the bovine heart before I do it on the human. So this is a video I did. The sizing is about 19, and I incise the commission between the non-coronary cusp and left coronary cusp, and then go along the non-coronary cusp. And I use the bovine pericardium to repair the defect. Actually, the use a continual running suture is pretty easy, and you don't have the hemostatic problem. And then I put in this is still showing on the page. I did an oblique aortotomy. I didn't transect the aorta. And then I put in the suture for the valve. And then after we put a 23 St. Jude Epic Supra valve, which we upsize to valve size. And then I close the aortotomy. Since I did not transect the aorta, I use oblique patch to enlarge the ST junction. This is the final T. We didn't see any gradient below the valve on the LVOT. The maximum gradient is 19 and the mean gradient is 7. This is a native valve pressure gradient. We didn't see any gradient over the LVOT. So this is how I did these patients. I did a root enlargement using the Young's method published by Professor Bo Yang. Okay.
Thank you for your excellent result. So we still have 5 minutes.
I have one comment.
Discussion. Yeah.
Excellent.
Professor
The
Hong.
procedure itself is excellent, and the clinical outcome is better. But I feel it's a little bit. I'm not totally happy. The reason why, for the, as you said, that the usual expected survival is 83, and the patient age is 80. The take operation for remaining 3 years, everything is okay, fine. But anyhow, for the operation, for the at least 10 year more survival is maybe a guaranteed, or that is my personal opinion. Just for the final, the purposes is some. Therefore, it looks like a little bit some sad. My personal bias.
I'm also agree that for my boss, sometimes he teach me that if you have to face a patient with high risk and maybe they're like this patient 80 years old, PAD, not a good, maybe not a good quality of life. If you just have some residual ppm, what will happen? The patient maybe just stay like that until they die or something. This is just only my boss taught me.
Are you saying we're just not doing an enlargement to put a 19 valve with this lady?
In my experience, because we are in the aortic center, so if the case came to our center, I think we do the root in enlargement for sure. But if the patients have like a really frail or something like that, and the patient cannot afford the TAVR, we do the TAVR with just only the small size.
So yeah, and I got those questions all the time for old lady. Why you want to do enlargement? They are not doing something. They are old. So my answer, I think this is a great operation you did. But my answer is, if we think the patient is a candidate for surgery, we'll put this grandma, the old lady, through cardiopulmonary bypass, cardiac arrest, open his heart and aorta. We'll add 10-15 minutes to enlargement, give her much larger valve, and no gradient, improve her hemodynamics and the life expectancy and quality of life. I would spend extra 10-15 minutes to do the enlargement. Well, otherwise, if I don't do that, if I don't think he's a frail enough, not tolerate the operation, I just don't do the operation. But if I have to put this patient through so much, I will do the enlargement. I think those patients do better with better relief of the aortic stenosis. The recovery from ICU and the post-op will be smoother. I don't know how this patient do after surgery.
Yeah, you know, we used to see little old ladies that would come in and they would have an aortic valve. When you looked at it, didn't look that bad. Somebody put a 19 valve in. Next thing you know, they're on a whole boatload of pressors in the ICU, a bunch of alpha drugs. And before you know it, they're developing renal failure and multi-system organ failure. And the problem was you just didn't give them the right valve to begin with. They will do better, not just long-term, they will do better short-term. And, you know, if you're going to avoid surgery altogether and do a TAVR, that's great. But once you bypass them and arrest the heart, as Bo said, that if you know how to do it, that extra 15 minutes, these are all done by my residents. I'm not doing this. I'm helping my residents do this. And they go through these without any trouble whatsoever. You're really better off doing what I would consider the right operation for them.
Look, I think to summarize that particular point, I think it is sad that sometimes we're still limited in various jurisdictions by risk score when the age and other factors are not really taken into account, but it is what it is. I think some jurisdictions we just can't afford it, and maybe the reimbursement's a bit behind. We were like that in Australia a couple of years ago, but let's not take away, I suppose, what really was a fantastic surgical result. I think
beautiful
Bo and Mike will agree that it was a fantastic surgical result despite the age of the patient. So, excellent outcome. So I think we might have to draw to a close. And Mike, I think if you don't mind, please give us a little summary of what we've learned today. Thank you.
Well, the short elevator pitch is patient prosthetics mismatch kills you. Avoid it as much as you can. Clearly, there are mitigating factors of what you can do surgically, and all surgeons may not be able to do this yet, but it's a very teachable technique. It's much more teachable than doing a root enlargement to get bigger valves in. And I think that, for the young surgeons, this is something you need to learn. You can do this even if you do a double valve or they have a mitral valve in place, which you can't do with a Nix or Manugian because you're really up there at the annulus. So it's worth learning. Your patients will do better. Your referring cardiologists will be happier, and your patients will be happier.
Great comment. If I can make one comment to the surgery, and I would recommend the cut a little bit more and put a bigger patch. You put a 1.9 centimeter, you can put a bigger patch there.
Yeah.
Okay, if we translate the aorta, maybe we can put a bigger patch. I just
Actually, fine too, and you did great the first time, and it's great. It's great operation.
Yeah, well, I think like a lot of things in surgery, the more you do, the bigger your patch is going to be. They grow.
Exactly.
And I personally would avoid bovine pericardium. I use a lot of it for these primary sarcomas I do because they're only going to live 5 years. But if you have people that are going to live a while, this stuff really calcifies. Now, she's 80. She's never going to be back. Yeah. But if you're doing it in a 60-year-old, be careful.
Yeah.
Okay, we close this session. I hope to see you in person in Taiwan. Thank you, everybody.
All right. Thank you.
I think all you, like me, learned lots from the previous session. So that's an impressive session. So let's now proceed to an exciting segment of our program, the live demonstration. In this session, we will witness 3 remarkable cases performed by experts from 3 different hospitals. At this moment, I will hand over the reins to the expert present on site. Thank you. So welcome our moderators, Dr. Jianping Cao, and the other 2 moderators will join us online, Dr. Yu-J Zhou and Dr. Yang Wang. Thank you.
Good morning, and I'm Dr. Jianping Cao from Jianxin General Hospital. This is live demonstration sections. And we have a moderator of Professor Zhou Yujie from Beijing Anzhen, and Professor Wang Yan from Xiada Cardiovascular Hospital. And we have also the experts, Professor Luo Jianfang from Guangdong, China, and Dr. Wu Leiming from Zhengzhou, China, and Dr. Li Jie from Guangdong, China. And Professor Ye is also here, and Dr. Qiu Zhengan from Kaohsiung, Taiwan. And I think the first case from Anzhen is almost completed. So can we, Dr. Professor Zhang? Okay, can you introduce your case and your team?
Yes, thank you for your introduction of our case. Can you hear me, right?
Yeah, you're online. Yeah.
Okay, so I'm going to have Dr. Wu to introduce the case for today's. 开始吧，开始介绍吧。
Okay. Okay, good morning. Today I'm to introduce a case. The case is to use the Java for pure aortic regurgitation. This is the baseline information of the patient. The patient is a 72-year-old male, and the height is 175, and the weight is 57 kilograms. The complaint of the patient is chest tightness with decreased activity tolerance for 3 months. The patient felt shortness of breath after mild force activity 3 months ago. Echocardiogram during physical examination at outside hospital suggested that he suffered with aortic insufficiency, and the patient did not have cough and dizzy and blurred and nausea and vomiting. In the last month, the above symptoms worsened, so he came to our center. The echocardiogram in our center suggested that he suffered. The echocardiogram in our center suggested that he suffered with aortic regurgitations, so he was admitted into our department. This is the echocardiogram of the patient, and you can see the aortic sinus that diameter is 42 millimeter, and ascending diameter is 41 millimeter. And this is the X-ray of the patient. This is the ECG of the patient, and the patient was diagnosed with sinus arrhythmia. And before the TAVR, and we have the and you can see the parameter of the aortic annulus was 75.3 millimeter. The left ventricle out tubular diameter was 25.6 millimeter, and ascending aorta diameter was 48.7 millimeter. And the sinus tubular junction diameter was 38.4 millimeter. The RCA height was 9.1 millimeter. Left coronary artery height was 17.3 millimeter. And this is the
Sorry, we can't hear you.
Of the patient, this annulus should be 24 or 24.5 millimeter, and also the average OT should be 25.8 millimeters. 下一张，继续吧，继续吧。
继续。And you can see this patient have no calcium in his aortic valve. This is the angle of the patient. This is the STS score of the patient. The diagnosis of the patient: the first, aortic regurgitation; the second, coronary artery heart disease; the third, carotid atherosclerosis; and the fourth, lower extremity atherosclerosis; and number 5, cardiac function. Number 2, the patient have gastric operation in the past. And number 7, the patient suffered with blood cancer in the past. Number 8. Number 9, the patient suffered with gallbladder stones.
So
this
that's the
cartoon
valve.
shows the Java system.
This is a J valve, and we're going to use this valve for this patient. It's from the transapical way, and to especially very good for the aortic regurgitation. You can see the 3 graspers, and the graspers will automatically into the 3 bottoms of the sinuses, and then will expand the stent, and then release the valve. So the procedure should be very simplified compared with the transfemoral way with other valves. This is the J valve system.
This system is
This is how it works and how it
this is
implants.
transcatheter.
Yeah. Usually we do a very small incision and the transapical, and with sutures 20 or 30 with the platelet.下一张，后边简单过去吧。Okay. So, Dr. Chao, so can you hear me, right?
Yes,
and,
we can hear you.
Yeah, we're very glad to see Dr. Ye Jian also in the meeting room, and a long time no see. Well, today our case is a 72 years old patient with pure no calcification at all. Is a AR patient. Yeah, first of all, I'm going to introduce our team. Dr. Wang Shengxun is just here, and Dr. Wu, and Dr. Meng, and Dr. Lang. And also we have the echo Dr. Fu Jiarong, and she will going to introduce the echo pictures and videos. And also we have the anesthesiologist Dr. Zhang Liang should be there, and Dr. Qiu Wei, and Dr. Lu, some nurses take care of patient in the OR. So Dr. Fu will share with the patients the echo images and videos.
Okay, next, please.
Can you see the, yeah, you can see the echo, right?
Yeah, we can see it.
Yeah, the TEE.
Okay, thanks all. Next, please allow me to introduce the operative echocardiography results of this patient. As the TEE shows, the situation of the aortic root is 3 sinuses and 3 leaves. The ejection fraction of this patient is 58%. The flow locality of the aortic valves is 165 centimeters per second. Through TEE, the VC of AR is 6 millimeter, and the area of AR is 8.7 square centimeter. Through TEE, the VC through TEE, the VC of aortic of AR is 5.7 millimeter, and the area of the AR is 6.7 square centimeter. The MR and TR is mild. Besides, we need to confirm the location of the apex cordis by TE under the left ventricular long axis view. Thanks you all.
So for this patient, the TE measured the aortic annulus is between 22 and 23. And also before there is a CT scanning showed the aortic aneurysm is 24.5. So I'm going to ask Dr. Ye Jian and Dr. Chao and other doctors online. So what size of the J valve you will suggest?
So we have a master, Professor Ye here. He will give some comments. Yeah.
Hey, very nice to see you on the Zoom on the screen. I think you are the expert in the J valve, and I know you as a major operator for all the J valve in China, and then you have a ton of experience in this valve. But you know, I have a sort of compared to you, I have a relatively limited experience. So I think the questions are the sizing, what's your based on the CT or the echo. And I think it's for the AI patient, sometimes it could be a difficulty for CT measurement to have accurate CT measurement because it's a net, you know, because without calcification, sometimes could be overestimated. And but I generally based on the CT measurement rather than echo or TE measurement. So as you know that for the J valve, you really don't need to overlap to oversize too much, but you also don't want to undersize. So this one is 24 and TE 23 up to 23. So I would suggest if I choose, I will choose probably 25 valve. That because right now it's only 23 and 25 for transapical, right? So
we have 27, yeah.
Yeah, 20. No, but for the 23 and 25. So if you're 23 valve, maybe undersize a little bit, and for the 25, I think will oversize a little bit. Of course, the arrhythmia, I don't know. What is the arrhythmia on the EKG? It's a sinus or the
sinus?
AV block?
Sinus.
Or the accelerated junction. It seems like I see that P wave sometimes. So it could be a sinus spreader with accelerated. There's no AV block, right?
Yeah, no.
So if no AV block, I think if with this valve, the AV block is pretty low. So I will more intend to choose a little large size.
Yeah, I totally agree with Dr. Ye Jian. And after discussion, our team finally decided to use 25 J valve. Usually for the echo result smaller than the CT scanning. And for this patient, the CT scanning, we double confirm the result is 24. But the TEE, the annulus, the result is 22 and 23. So after discussion, finally we totally agree with you. We are going to choose 25 J valve system.
Professor, so how about the pacemaker rate in J valve?
In our center, it's about 5 or 6%. Yeah, it's lower than the other transfemoral way because this valve is short, and usually you cannot put too low in the IVOT. Yes. So and also the Dr. Ye Jian just mentioned this valve has some advantages in this field.
Okay. Are there any comments or from our panel? So, can you continue your procedure?
First, I'm going to use the wire to across the aortic valve.扶着点，这下去老拽出来。这是有阻力，看到了吗？ 离它远点儿。这个导师的问题。好，它主脉公露出来。
Professor Ye,
Yeah.
The transapical and the transfemoral approach, how about the clinical outcome of the patients after the TAVR procedure?
I guess nowadays there's no debating the transfemoral is better for sure, transeptal. But I think in the experience center, like
这个当量血压的100，
they have a lot of experience with the transapical. I think outcome probably is compatible.
后床，来，靳导师。
So what guide wire are you using?
This is just normal. The J valve is also J valve. It's a number one exchange valve, and I'm going to exchange with Linaquest.
Oh, you use the Linaquest?
Yes.
Okay.
And for the other centers, they like use Amplas super stiff. Also works very well.
So I found that if the aorta is more like a angulation, that sometimes you do need a pretty like a strong guard to protect any injury to the aorta, particularly with a transapical approach. But the majority, I think, we use most time just Amplas super stiff or the extra stiff. I think that's also
yeah. Amplas super stiff works also very well. But we have one case with Amplas super stiff. The aorta is a horizontal aorta, and the super stiff wire has some angles there. So after that, we tried every case with a Linaquest. But I think in most of the cases with two kind of valve, both works very well. After pre-dilatation of the apical, and we will put the valve along the Linaquest wire.
Dr. John, do you routinely dilate the apex, or you just use a device to push in?
Usually, most of the cases we pre-dilated.
So what is the profile of the sheath?
This is 27, right? 27的吧？25。
Okay.
这个翘27 F 的。Yeah, 27 F。好。放大一点。好。离我远一点的手。
合击少点，上面高点。
好，球位准备好了吗？来，冒烟。Yeah, we just make sure that where is the aortic annulus, and put the pigtail a little higher. 把座位拔高一点。And then we will open the bottom number 1. 再放大一点图像。
最大拓展。好，把那个放在中心。
So you can see the 3 grafts first is opened, released, and we will put them into the bottom of the 3 annulus. Sinus 离我远一点。And then the bottom number 2. Try.
低头放地上。低头放地上。
来打药了。Should be here.
部位往下，部位往下一点，部位往下一点，往逗了一点。
这个老师给我伸直。
How do you confirm the grasp in the right position?
Yeah, it's very critical, and we can use the angiography, and also we can use the TEE to check it. So this position is not good. 来打药，来看一眼。
So to deploy the valve, you don't need to rapid pacing? Like,
yes, no need, no need.
Okay.
远一点，你往后推，往后吧，推走它。来，邱伟打药。下边呢？
打药之前你把周围送到底下，一会儿再
不用太低，我先把这个上去。
可以再提。
Sometimes you can take some minutes. Make
Professor,
sure, yeah.
Professor Zhang, do you think the sheath a little bit too deep? That's eliminate the UU.
Too deep?
Yeah, too close to the aortic valve.
Yeah. The anus should be here. Yeah. 来，打药。Yeah, this looks better. 超声看一下来。
Dr. Zhang, do you choose the coplanar view, 3-point even or?
Yeah, 3-point even. Yeah, we need to make sure the 3 graspers makes even into the bottom of the 3 sinuses.
Okay.
Yeah. So we do not use the overlap.
Okay.
看看3个那个定位架在窦里吧。So we are going to with Andrew again. 准备好照影啊，我踩一脚。
往下周围往下。
来打药。
我看不清。
哦。So what do you think, Dr. Ye?
Yeah, I think the left and the behind the valve, of course, you cannot really tell, or either front of the valve. That in the middle, this is located, whether it's in the sinus or not. I think the other two looks like the motion looks like already captures the leaflets, but the one in the middle, it's difficult to say.
Yeah, the middle is the right sinus, and 超声看的右窦是在是吧 ？Okay. So and with this kind of situation, we cannot differentiate easily if the right grasper is in the bottom or not. Sometimes we use the echo to confirm the grasper is in the bottom of the right sinus. So I think the right grasper is in the bottom.
Yeah, it's already in. Sometimes we do change the angle, just
居中一下，来居中一下。
bring the right side, the middle one into the either left side or right side, and then you can see what is captured.
好，诸位再近一点，我再打一下，我再释放。
一点，往后一会儿再拉上。
好，
这个位置好。
好，打药。Yeah, I think the 3 graspers are in the bottom of the sinuses. So yeah, so I'm going to deploy the valve. 座位高一点来。座位再下来。下来一点点，超声再看啊。来打药。Yeah, I think the valve position is good. So Dr. Ye and Dr. Cao, what do you think about the position of the valve stent?
Yeah, I think it's very good. Yeah.
Yeah, it looks almost no leak.
Yeah.
So we're going to check with the TE, the echo. 有反流吗？几乎没有哈。
血压给它降一点，血压有点高。 稍微降一点。
这样吧，因为我测的话会出血，
对，
心尖的地方。
So, Professor Zhang, can this valve be resizable or repositionable?
No.
No. Okay.
If you deploy the valve, it cannot. Yeah. So I'm going to take back with the bottom 1 or 2. 那个收一下荷包。
来，给我。
So you're going to release the sleeping?
What? I'm sorry?
The sleeping is still attached, right? You're going to release it?
Before I release, I'm going to put the bottom number 2 and number 3 back into the original position. And then I'm going to release. So 现在看超声没有变化吧 Yeah. So now I'm going to release. Actually, for J-valve system, the release is more dangerous than deployed valve. It's different from other transfemoral valves implantation, especially for the regurgitation. 修备好了吗？来打药，打药，不送。
可以。
好 ，Yeah, the position of the annulus, it's good looks. 来涂下小1号。好。准备收荷包哈。进导丝居中。进导丝。好，稍等一下。血压，张亮，你血压还能低一点吗？我知道，我要拔这个输送器。你有多巴胺有什么去甲吗？都停，去甲都停一下。
暂时给点药。
消肝再给一点。实在不行我们就起搏一下，把血压打低了。来，谁来？稍微帮我起搏一下。So you can see the ECG, right? It's still, I think it's still sinus, right? 是逗的吧？有 P 波是吧
Looks similar.
Yeah. You can see the sinus rhythm. Yeah. 来起搏，血压还能低点？那谁，张亮
So what the usual pressure you like before you remove the sheath?
100 or just below 100. So sometimes we use rapidation and make the pressure a little bit lower. That makes safe. We just in case the transapical bleeding. 来起搏吧，120。你手不要扶我的输送器。
摸着
摸着我立刻就有感觉。140，起搏140。好，我准备出了哈，收荷包拢住就行，不要太使劲啊。老师配合哈。好了，收荷包。收荷包。我手松一点，你俩再收紧一点。拿走。从里边往外收。对。好，来，起搏器来50。好。超声看一下。So we're going to check the echo again to make sure the valve is still in the right position. It looks good. It's almost no leak at all. 再测一下那个压差，固定。来上单弯管了。
Looks perfect position.
That looks good. Yeah.
Professor, do you use J-valve only for AR or also in AS patients?
Yeah, sometimes we use J-valve system for the aortic stenosis. For example, if the the femoral artery is too small, or even with a very high risk of the coronary occlusion for the TAVR procedure. You know, the J-valve system has a very special design for the grasper. The three graspers, if you put into the bottom for the sinuses, actually it works, has some function, protects the coronary artery. For that case, for the very high risk of the coronary artery occlusion, we just no need for the double coronary artery protection. We just put a J-valve system there. The graspers can help protect the coronary artery.
Yeah, because there are graspers. How about the post-dilatation? Is it safe to do the post-dilatation?
Yeah, it's safe. Sometimes for the AS patient, we use post-dilatation. The grasper is very soft, and some doctor may worry about if the grasper will some damage of the aortic wall or something. It won't be happen. Okay. It's very soft. Yeah. 老师撤，轻轻撤，慢点，慢点，慢点。别了，贴壁了你就停，对。好，来准备最后打一枪。轻微的好了吗？
放大项。
哦，可以了，不用换就可以了。
放大点。
可以了。好，
可以。算入。
哎，打药。
这都清楚。
It looks good.
Yeah, very good result. Yeah.
Okay, Dr. Tao and Dr. Ye. So any comment of the valve? The valve I think is very good for the aortic regurgitation. Yeah.
Excellent demonstration. There's it's a great result. And I say the position is perfect. That's kind of position that really you wanted. So I think this is excellent outcomes. So for the stiff, very stiff wire, I think it's always safe to put a pigtail as a doctor, a Professor Zhang's doing and trying to prevent any damage to leaflets. But if you use a little softer wire, and then you probably you don't need the pigtail to protect the leaflets. Do you agree?
Yeah.
So Professor Zhang, congratulations, because this is a very great result. You very quick procedure, and
thank you.
Yeah, good result, and you're a very amazing team. Because we still have 3 lab cases to share. So yeah. I will leave you here, and we would go to the other lab. So thank you very much for your excellent lab demonstration. Congratulations.
Okay. Thank you.
Bye.
Yeah. Bye.
Hi, Professor Wei, and
okay.
Professor Ye Jian is here, and also Dr. Qiu Zheng'an is our panel, and there are also panels and moderators. Zhou Yujie from Beijing, Anzhen, and Professor Wang Yan from Xiada, and Professor Luo Jianfang from Guangdong Renmin Yuan, and Professor Wu Leiming from Zhengzhou, China, and Li Jie from Guangdong, and Dr. Qiu Zheng'an also introduced already. So, Professor Wei, can you start our cases?
Okay, this is Jian Wei at the Chengxin General Hospital. Now it's our turn to present our second case, the live demo. And well, I was quite amazed, the quite amazing operation done by Dr. Zhang Haipo at Anzhen Hospital. So we are looking forward to use the more J-valves in Taiwan. This is what I'm thinking. And the second case will be pure, the TAVI, and but the patient had a previous subcoronary artery bypass. So this is Dr. Li Yongzai. Dr. Li Yongzai. This is Dr. Li Guozhen, and Dr. Ying Weixin will come into the room a little bit later. So Dr. Li Yongzai and Dr. Li Guozhen are the cardiac surgeons, and Dr. Ying Weixin will be he is the cardiologist, and the echo man over there is Dr. Lin Huanqiu. He is the echo cardiologist. He will do the cardiac echo. Later on, Dr. Li Yongzai will present the case, and Dr. Lin Huanqiu will show you the echo findings. Okay, so let's move on. Okay.
Yeah, please, slide, please. Next.
Sorry, can you introduce your case? Yeah.
This is a 60-year-old female. He got dyspnea on exertion and comorbidity with all stroke, hyperlipidemia, type 2 diabetes, and hypertension. She received coronary artery bypass to LAD diagonal OM and RCA in 2015, and the graft was patent. The STS-PRM is 12%, and the case severity score was 0. Hematocrit is 13.6, and the creatine was 0.6. NT-proBNP was 238 after treatment. Next. You can see here the transthoracic echocardiography is a severe aortic stenosis and mild to moderate aortic rectification. Classification is mild to moderate. Next. The pressure gradient is 56/35, and the area was 0.68. The heart function is preserved. Next. The multi-slice CT show here, the parameter was 71, area was 393. Sinus Basava was relatively small, was 27. RCA and the left main height was 12 and 13. Membrane certain was 4.9, and the sinus Basava height was 16. Next. The calcium show here is mild to moderate, and the graft was patent under the multi-slice CT showed. Next. And the iliofemoral artery have some classification. However, the diameter is large enough for the device. Next. Today, our case will use the Sentinel brain protection device and the right femoral artery for the device. The 25mm particle hub was planned to use because of the severe coronary artery disease. And we use the 1 per guide precursor left common femoral for pacing. And the multi-slice CT in our analysis showed this patient is a bone marrow arch. So I will show the cine. Please show the cine. And the bone marrow arch, we use the reverse wiring technique and insert to the left common carotid artery, then release the pressure gradient and release the protection device. Next. Yeah.
You cannot see the slides. Oh, okay. So this is a bone wide arch?
Yes, it's a bone wide arch. You can see here the common carotid, the innominate artery and the left common carotid artery is arise from the same position. So I use the reverse wiring technique to insert the wire to the left common carotid artery. Then slowly release the tension and release the second basket. You can see it's a very typical bone wide arch.
Yeah,
now we will introduce the TEE, the battling place.
But is there any interaction of the pigtail and the sentinel system?
No, that we just use the pigtail for mark the innominate artery. And you must pay attention about when you cross the pigtail, so that every time you need to take care of the pigtail. And if you withdraw the pigtail too hard, and the device will pull down by the pigtail. Echo, please.
Okay. So audio expert, let me show you the T image right now. And this is the X-plane of the artery valve. You can see the long axis view at the left side and the short axis view at the right side. So this is a tricuspid aortic stenosis valve, and the calcification is mainly distributed at the non-current cusp and the left current cusp. So now this is the color And you can see there's moderate, maybe mild to moderate aortic regurgitation, and there's some mosaic pattern at the ascending aorta. So this is the 3D reconstruction view. You can see the valve is relatively stenotic, but the calcification is relatively less. So our patient LV function is relatively preserved, and also the RV function. So let me hand over to the operator, Dr. Li Yongzai.
Yeah, that's previous we had inserted the wire into the LV. So now we exchange to the subary wire. We usually use the subary wire for the transfemoral TAVR because the good support. And Professor Yin is here. And
I have a question that this patient has a ST junction is pretty small and there is quite a calcification one side. Do you have any concern about the coronary sequestration in this case? I know this patient have a coronary bypass grafting, probably is not really important, but in general, do you have any concern about that?
hold on.
Dr. Lee, can you hear Professor Wei's question? Professor, yes, questions?
The case, I think that's because the pattern graft and nearly the total occlusion of the LAD in the proximal part, and it's got very difficult to re-entry in the lemon, and the RCS still have some diffuse lesion. After the artery bypass, the coronary is okay. So I think that in the future, if we need to do something to the coronary, it should be from the bypass graft, but not the native vessels. So that we choose the protocol because the hole size is around 11 French. So it's got okay for the future interventions.
Yeah, I think one layer of metal with a particle valve should be okay. Even you want to recanalize the coronary, but it will be difficult if you use a long frame self-expanding valve, valve in valve. That means 2 layers of metal there will compromise the future reaxis.
So, Professor, if for this case, because the patient has bypass surgery,
yes.
So is it important to do the commissural alignment with this case?
Well, we should try that because you never know what will happen in the future.
Okay, because the particle valve and the core valve can do the commissural alignment, but I think SAPIEN 3 it doesn't need it because it's short frame. Yeah.
Well, one study have shown that even in the balloon expandable valve, if you had a misalignment of the commissure, there still have some actually hemodynamic compromise. Although it is mild, we don't know the long-term result.
Now we start to release the valve, and we start from the half detail, please release.
没关系，不要推太凶，3或4嘛，再下去。
Pacing on.
Pacing.
So the advantage of this valve is that almost no hemodynamic compromise during the deployment. They can maintain the hemodynamics.
Oh, good. 不要推太用力，后的，上面多一点，上面多一点。
Pacing off. LAO.
Do you push into the ventricle, or this is just spontaneous, more towards when you deploy? Seems like more towards the ventricle. Was really high at the beginning, is now Looks like a...
Actually, there is some interaction between the sheath and the valve. So it will go downward spontaneously during the deployment. However, we have just pushed a little bit downward because we are afraid that because the the structure of the particle, the lower half is straight in shape, in configuration, instead of the taper one as the Medtronic ones. So we would like to keep the position a little bit deeper, maybe 3 or 4 millimeters below the annulus. I think that would be optimal.
Looks like a perfect right now.
Yeah, in the new devices, they even mark the 3 millimeter dot on the metal, so you can easily to see the implantation depth during the implantation.
Open.
So, does everyone agree that this is a good position?
Looks fine. Looks good. Yeah.
Okay, we will release the device.
Release.
Hold就好了。一点点推，一点点推，一点点推。
有了。
不要推了，不要推了，推太凶了。OK。
Okay,
that's it.
So, Professor, you just mentioned the design of the particle valve is straight both sides. So that means it doesn't it migrate or doesn't change the position once deployed.
Yeah, because it's straight. As you know, if there is a slippery as in the rheumatic or aortic regurgitation, it will just migrate.
Why?
Downward or upward.
Professor Cho, any comments?
Okay. Also, you have
yes.
experience about
now you want to see the next plan of the.
I'm
Pretty
not
sure
sure.
the echo finding. I think maybe we can.
The final position.
There is some paravalvular leakage over the 12 o'clock.
Maybe
And the valve, maybe there's some oval shape.
Sir.
Do you agree that we need to do a post-dilatation?
Yeah, we are planning to do that.
Yes.
Because as you can see, the radial force of the particle is not that strong. So actually, if the calcium is big, and we usually can see this kind of a result. So we are planning to do post-dilatation.
Yeah, this valve probably on the CT is pretty asymmetric calcification, so this kind of a leak probably expected after this kind of.
We still should be cautious, not too aggressive. Usually we just do shaping, because the radial force is not that strong, so it is not fully opened yet.
So what the size of balloon you put?
22. 22 嘛
25 valve, right?
25 valve and the 22 balloon.
The parameter should be 23, and we use the 22 balloon for the shaping the valve. And this is a nucleus valve, but
底下不要出头，再下去一点点，好。OK，
来配线哦，
看看 pacing 以后吧。好，可以。来 ，OK， let's go。Hold it. 1, 2, 3, 4, 5。
配线哦。
一起，等一下。
I just noticed you use a regular syringe rather than pressure. the special one with the pressure syringe. You use just regular syringe for lead dilatation?
Yeah.
I guess someone has a very strong muscle. Lots of pressure. I did it before. It's not easy for the 1 or 2 cc's.
Yeah. As you can see on the screen, the echo show that there is a small protruding on the vascular wall.
Yeah.
So that's why, as Professor Ye mentioned, the choice of balloon size is really important. In this morning, we are talking about the balloon fracture of the valve in the valve-in-valve procedure. James told us you should choose a balloon size about 1 millimeter below the surgical valve. That's what we are thinking about when we choose this kind of balloon size. Dr. Lin, could you tell us the result?
Yes. So this is the result after the prosthetisation. You can see the perivalvular leakage has downgraded to minimal. It's still at the maybe 12 to 1 o'clock the position, but it's downgraded to minimal. So I think the result is very good, and the valve is relatively more circular at this moment.
Okay.
So I will measure the pressure gradient right now. Just wait for a second.
I think the paralytics have been minimal, and I think the result should be fine. And the QRS is narrow, and the implantation depth is okay. So I think it should be a successful procedure.
Yeah, it was very good. Can you do the angiogram for us?
Yeah, sure.
So the mean pressure gradient is only 5 millimeter mercury. Yes.
Okay, the mean pressure gradient is only 5. So please coming out T.
Okay.
再来一点。好 ，OK。Okay. I think there's only minimal amount of regurgitation. The implantation depth is about 6. I think it's okay. In Portico, usually we implant a little bit deeper, even with the use of cross overlap, because of the shape of the configuration of the lower part of the device.
I think an excellent result. So I just wanted the comment on the last aortogram. Can you show it? I think
Yes.
the left side,
the last angiogram.
Yeah, left main, so you can see the calcium sitting there. If without the patent bypass graft, I saw a little bit concern here.
Yeah.
On the left main looks
Yep.
like a little bit compromised. But
Yeah.
of course, in this case, I think it's not the issue because the patent the graft.
Yes, yes. And also, as I said, there is one layer of metal and the side hole is really big for the Portico. So if there's only one valve to re-access, it's still possible.
Okay, Professor Im, very good result. Congratulations, because Shada is ready to do the lab demonstration. We are going to move over there. Okay.
Okay, thank you very much for your support for the
Congratulations.
procedure.
Thank you.
Thank you. Thank you.
Okay, can we move to Shada?
来，可以转了，来，可以。
Professor Wang，
哎，帮我麦开开来，帮我麦开开。
王院长，
哎，你好，曹主任你好。
院长，我是曹
哎，哦，你好啊。
放一遍。
这个是厦门大学附属心血管病医院那个我们的杂交手术室哈。This is Dr. Wang Ping, Little Wang.
So just introduce the moderator and the panel to you. And the moderators are Dr. Zhou Yujie and of course Professor Wang Yanzang, and also Professor Ye Jian is also here, and Professor Luo Jianfang, Wu Leimin, Li Jie, and Professor Qiu Zhengan from Kaohsiung, Taiwan. And can you present your case and your team, introduce your team?
Okay. Thank you, Professor Cao, for your nice introduction of the moderator and the panelist. And this is Dr. Wang Bing from Cardiovascular Hospital, Xiamen University. And Dr. Wang Yan is scrubbing a few minutes later. And this Dr. Chen Xiang and Dr. Yao, and the echo cardiologist, Dr. Shu, and the nurse head, the Wen. First of all, I like to introduce the Dr. Chen to introduce the brief introduction of this case. This slides.
导播帮 PPT
幻灯帮我们放一下。
Next. So this is 70 years old gentleman. He just completed lipid disease for 4 years, and he came to our hospital. We first diagnosed as fever AS, just new heart failures of 3 degrees, and coronary status and hypertension. Next.
下一张。
So this is the ECG, and next. And the baseline UCG shows low EF ejections and large LVD diagram, and it's a bicuspid severe AS, and the large left atrius and large right atrius. And next. So this baseline MRI. Just maybe we choose the diagnosis of the left ventricles. Next. So this is the CT analysis and STS scores. STS is very high. It's about 9.6%. And next. So this is angles of the aorta. Next. So this is the CT analysis about the annulus and LVOT views. This is severe calcificus and BC. Next. So the super is about 4 millimeters and 8 millimeters about the parameters just about 72 millimeters. Next. And let's know this. It's about check severe Aortic. Let's know this about the coronary. Next. So this next. So the CT scan shows it's very serious calcification. Next. So this is images about the CT analysis. Calcifications and Next. So this is angle aortic. Next, and we choose Taurus NTX pages. Next. So this is type 2 bicuspid series aortica, and we choose the left atrius command to as the main approach. So we choose the AV 26 millimeters refers, and AV 23 and negative.
OK.
So thank you.
OK. 中文可以吗？
可以啊。曹主任，还有曹主任，
是
那个叶主任、邱主任，
王院长好，可以听得到，
曹主任好，我现在能看到了，那个刚刚跳到这个道观上，非常感谢给这个林院长曹主任给这个机会跟大家来show 这个 case，这个 severe AS 那个 calcified bicuspid case，刚才大家已经看到了 CT 的分析了哈，那我们呢现在大家可以转到屏幕上吗？转到现在的屏幕，来看看压力。现在一个 pigtail 在 L V， 还有一个在这个 Aortic。然后我们看到了这个心室是192和20的舒张压，所以它的 grading 大概有70。那我们刚刚就是 history 汇报完了，那紧接着呢，我们下面就开始下面的内容了。那也跟大家去讨论吧，因为今天我们用的是配加 Tonus Elite NST 就是 the third generation Tonus 我们正好这个病人是 recruit 一个 clinical trial 所以呢我们就准备开始用它的这个器械，它是一个 self expand 的这个valve， 它也有不错的很优秀的一些品质。那我们现在呢就刚刚做到现在这样的 live 看看那个 X-ray 呢。
王院长，请教一下哈，这个是 bicuspid aortic valve 嘛哈？那你们的那个 valve selection 的根据是根据 annulus 呢，还是根据最 calcified 的那个地方，最窄的那 leaflet 那地方？
这个王斌主任，那个你给回答一下，因为我们本来要做个认真的讨论的话，王斌主任他们刚才已经跟他们讨论过了，我没有参加。王主任，您看看这个。
好的，谢谢曹主任的这个问题。是这样的，就是这个患者的这个半环的平均周长区划的这个平均直径大概是26左右，然后它上面的这个受限制区呢。其实我们大概的测定了一下，也大概也就22或者到23，可能它的受限制区还是在半环上的这么一个结构。那另外我们今天我们计划是用20的球囊先去做一个balloon sizing， 然后同时我们会计划会放一个26的这么一个Tonus XT 的瓣膜。那因为26的瓣膜它的最底边的这个最大的直径是接近29，其实从半环来讲它也有一定的oversize 的这么一个比例。另外一个这个患者从的2叶瓣的结构来看，它还是一个倒梯形的一个结构，说半环的铆钉还是非常非常重要的。是这样子王教授
谢谢。
其实我们可以看到，我们超声的这个压差比我们刚才测的有创的压差似乎要明显的低了一些。可能有时候超声的这个 projection 不是特别非常好的话，可能会低估一个患者的压差。
这个病人我好像现在看的是 sinus rhythm 呢，那个QRS 好像已经是比较宽的。
对，
它是一个
LBBB
对，
他说是比较宽的。说在这个患者，我们在之前做了一个磁共振我们想看一看他心肌水平有没有一些问题。那确实这个 late enhancement 这个显影确实显示他的从内膜一直到中膜，它的这个心肌组织是有明显的纤维化的。 说这个我相信是跟他长期的这种高负荷、长期的重度的 AS 是有关系的。EF 他在1个月之前，他的 EF 大概只有22，经过这1个月的治疗，他的 EF 值现在大概40左右，44左右，对。
我相信这个非常严重的 AS bicuspid， 如果我们解除它的这个狭窄以后呢，对它的临床各个方面应该有很大的帮助。那我们现在就做到了这一步。现在我看球囊，来，我们准备吧，找一个
这是正交是吗
2页半吧
？2页半，我们看一看，2页半很少这个角度。
院长，原来的那个 LVEF 只有22，后来变44，是你们有先做 BAV 吗？
没有做 BAV，来的时候是当时状态比较差，是吧？用一些药物调整，仅仅是用药物，没有用 BAV。
因为这个患者他这样子，因为这个 clinical trial， 因为他的费用是比较紧张，比如他这个 clinical trial 是要求大于70岁。那这个患者刚刚在2天前刚刚满70岁
，2天前刚刚满70，
所以说之前没有去做 BAV 啊，
是 OK，
就是等差在1个月左右时间。
那好，我们现在准备起搏，然后开始扩张。现在是20的球囊哈。
对，好的。
再高一点吧，
可以再高
一点点。那个是兜底了啊。
对。
球囊，球囊怎么推不动啊？卡在那。好。
我们用了20的球囊，这个也是我们那个 Honors 配加的这么一款。
配套的是吧？
配套的，对。
好，这可以的。准备起搏吗？
对。起搏准备180啊。
好，准备起搏哈。
180。
好，准备开始180。对，来往面打造营。
好，起搏停。
来，
有一个很大的 calcium chunk， 刚好是在那个 left 下面一点哈。那像这种的话，你会 expect 它放进去又会有一些 PVL 吗？
对的。
我好像看到了，我再踩一个这个DSA 空的踩一张，好吧？我在感觉那个 leafless 钙化是不是被我们扩了一下以后它移动是吗？之前是这个真相吗？之前是这个真相吗？
我们可以看一下，也是有点。
原来，也有一点移动。OK。
王院长，我想问一个问题，CT measurement 的这个 diameter 是好像是只有24mm 平均，那么你现在 choose 这个26 valve， 这个从这个 aortogram 看来，这个非常 bulky calcification， 然后 also 有那个 subannular calcification， 所以你这样的情况下，你会 change 这个 size 吗？还是根据这个 CT 就是说是 they determine 26？
谢谢叶主任的这个问题。因为这个患者确实他的可能这个 ankle area 是在 annulus 以上，而且他的受限的区域应该也是在上面。那其实我们对于这个 BAV 啊，对于这种 Type 0的 Zero 这种类型的这种 BAV， 到底应该采取什么样的这个策略去做？可能现在可能还没有一个很好的定论。我相信目前这个王建安书记他们牵头在做的这个 Taylor TAVR 这个研究，就是想说明或者解决这个问题，到底是根据半环去选它的 size， 还是根据上面受限制的区域去选这个 size？那这个我估计这个 Taylor 这个研究可以说明这个问题。 但是目前根据我们的经验，可能一方面是根据上面受限制的区域另外一个根据 balloon sizing 的这种情况去选择。因为我们其实因为这个人半环，我们测定了大概也是26左右吧，他的那个半环的平均径。说其实我们选26的这个 tonus NXT 的这种 oversize 比例，相对来说还是比较保守的。说这是我们选择26的一个很重要的原因。
我对这个瓣膜不是太了解，这个瓣膜的 radial force 跟那个 core valve 差不多吗？还是比那个
它可能会比 core valve 稍微会强一点，而且它的这个 radial force 最强的地方大概是它半环大概是它的瓣膜最底边上大概4个 mm 的mm 的位置，可能是它 radial force 最强的这么一个区域。大概是这种情况。它应该来说，它的 radial force，在我们大陆应该是tonus，应该是这个 venous，然后这个tonus，然后这个 weight flow，大概是这么一个顺序啊。那个 core valve 可能是相对来说会比较软的 ，radial force 相对来说不是那么强的这么一个瓣膜。那我们准备去上这个瓣膜。我们看到这个胸腔扩张张之后呢，其实患者的这种血压还是明显的改善，心率也降低了一些。这个我们还可能。考虑到这个严重的钙化，我们今天还是想用了这个 snare 这个辅助技术，看看万一等会跨瓣不是那么好跨的话，我们可能用 snare 协助一下，协助我们这个瓣膜的这个跨瓣。
是。
应该来讲，对，应该来讲不太可能是不需要，但是一个是这个 bicuspid，一个是钙化，还有一个我们刚才在过这个catheter 进去的时候，可能那个钙化那儿还是有一些比较大的阻力，所以我们就 stand by 这个snare 也备好就行了。好，看看远端的钢丝谁调整一下，现在滑的这个没加紧，
这个可能要用一个送一下。确实是有点。
来，一起走啊！好，远端钢丝那个成像抓一下。没有，还在那个滑呢。没拉紧。
那我们这bicuspid地方，我们现在使用的sizing就是在那个我们用 waist method， 就是在瓣环上面最 calcified 的那最钙化最多的地方呢，我们做它的 commissure 的那个长度，加上从那个中间最钙化到对侧的短轴、长轴加起来的平均值来做 valve 的 sizing。我们做了这样做下来。这些都还不错，对。
再试一下。
对，那个 sapien valve 跟那个 core valve 有不同吗？
其实对 core valve 来，对 sapien valve， 因为它是 balloon expandable 的，我们用这种方法比较安全，更安全。因为如果像是 taper 的话，如果这种 大部分当时 tubular shape 比较没有问题，但如果碰到那种 taper shape 的话，如果用 annulus 来做 sizing 的话，有时候怕会伤到那个aorta，所以我们如果用sapien valve 的话，用这个会
放这儿吧，
安全，我觉得。
要是再来还是
可以。如果是那个 sinus 往稍微比较大的情况下，你 choose 还是这个方法呢，还是用那个 annulus 方法
？sinus 的方法都是像那种，譬如
大的
我们还是以那个就是 annulus 上面最窄的地方、最 calcified 的地方来做 measurement。我们这样做，对。
刚才讲的 size 会小一点吗？
还 OK。
用上面这个方法。
OK， 那首先
算是比较安全，对，安全，因为那边上面比较窄嘛，这个比较安全。既然做下来应该都 OK。
好，放大一点有没有？好，我们准备跨弓那个钢丝最备好啊。OK， Elite 呢，它这个还是比较滑的，因为我们曾经1代、2代的时候，第3代可能稍微改了一下，它表面很多这个清水的。那我没事，我们先钢丝注意一下，再左手再多一点点。
院长，你放个 snail 是因为它是 horizontal 吗？还是
OK，没有，我们因为是 Bicuspid，可能我要稍微给他那个什么一点点。刚才只是一个 standby 了，我怕等一会儿完了我再重新装 snare，所以可以不用它，应该是比较容易。OK，好，小心，哎。好，我们已经跨半了，来把 snare 往上拿，其实没起太大作用，稍微给它 shape 了一些往这边。horizontal 的可能我们更需要用这个，但是这个病人是因为那边有点干好，我们只是背一下。就这个 Tonus 的这个款，它这个跨弓的能力，它的 floppy 各个方面呢，对 aortic 的损伤，还有对瓣膜这方面还是不错的啊。血压现在有点低呢，我们就抓紧开始放，轴没对好啊，可以不用起搏，来把轴对好。我们现在用的是啥 overlap view 吗？
可以来。
来，我们准备打个造影剂看看啊。现在血压是65，来打造影剂。OK， 我们想0吗？
是，来准备。
来，尽量的往0释放是吧？
对，差不多这个位置。
因为它的 neck 很高很高。
基本上要走的。
你那，因为你对不要 sorry， 再推一点点。
推一点。
等一下啊，你可能好。
可以啊，来准备起搏一下。
已经很好，稍微起搏一点，140。140，好。
院长在释放的时候，像 core valve 一样，也会 hemodynamic 那边会受影响吗？刚开始前1/3。
影响的不是正向点一下。等一下 ，OK。现在到这儿了，你看我们放到这儿，基本上这个位置呢，起搏停存一下。放到这个位置以后呢，我看血压开始回升啊，65，瓣膜挖已经工作了。在 X-ray 上你可以看到我们收到那刚刚可以 retrieve 的，如果不理想还可以回升。那现在看血压已经回升，然后它的反应可以，我们在 X-ray 上我采个电影可能看得更清楚啊。顺便要不打个造影剂
？OK，
好吧，准备好了吗？来，造影剂看一看答案。基本上是一个0位哈，在无冠窦这边，左冠窦那边呢似乎
足够，
也是够的。那我们用不用其他一个角度再验证一下？流量似乎不大。sorry，
你们这是什么角度？
刚才是 overlap 的角度是吧？
这个角度是那个正好把左右，它是个 type 0的，把2个半叶完全这个正交的这个角度。然后我们做了一些适当的调整，因为它跟这个瓣膜跟这个 annulus 这个平面不是很同轴，所以我们适当往主位打了一点点，做了一个妥协。但我们想还是打到在刚才左肩去 test 去确认一下。左肩啊，对，左肩。
好，我们在这个角度再照一张。现在打的左前，
尖一点可以，
更尖一点 ，OK。
歪曲，好，再往外一点。
底边给它说齐 ，OK， 底边齐的哈，非常好。
这个角度来 check 一下这个左冠窦的高度，好吧？
准备造影啊 ，OK， 打。
左冠窦看起来也是可以的。
对。我们 deploy 完了以后，可能这边会稍微再低一点点，左冠窦那边再校正一下，应该是可以的。
对，就是 bicuspid valve， 所以可能 implantation 也不用太高一点，也还 OK 啊。
是的，
因为它的 anchor 位置在上面一点。
对。
这个角度。
所以我觉得这个位置是不错的。那个陶教授还有叶教授还有各位邱主任、叶教授，大家看看你们同意 deploy 吗？这个位置？
可以，我觉得蛮好。
我觉得可以。
对啊，
大家都认为可以。
那我们就好。我们 deploy 的时候，希望把血压下来一些哈。反流量不大，而且它的舒张压现在也挺高了。准备好吗？起搏可以给到130、140，看看来。起搏吧。OK， 看看他的血压搞到60左右。OK， 慢慢起，慢点。 OK，哎，告诉好，起搏停，起搏停，起搏停。刚才忘记指挥你起搏了。吴冠这边稍微下一点点，但是位置应该还是合适的。那我们把 snare 拽回来，你现在把它 lock 住，收起来吧。收好，那我们把 snare 拽下来哦。OK，
不是特别好拽。再退一点，再退一点，半膜再退一点就好拽。
OK，
再拽snare，这样子比较好拽。
lock 到这儿。好，我们把这个输送器先推出来，然后我们再 check 一些指标。来，很好啊，远端钢丝保留。它的 valve 工作的那个平面来讲，应该苏主任你可以用超声看一看，那个是不是椭圆还是圆？好 ，OK。我们把超声能转一下吗？屏幕
可以的。把它转过去了。
T 的转过去了。好，来你扶一下。
现在是瓣膜工作平面的右侧，
是个椭圆形的哈。
对，
你看看那个3个 leaflets， 那个瓣膜 leaflets 工作那个平面也是椭圆的是吧？
是的。
但我们从左侧的那个长轴来看，半叶还是非常好的哈，它刚好在那个 annulus 的下面，然后呢，反流似乎没有啊，
没有，
就是有一点椭圆，是吧？
对。
22
我打直接打短轴。
22球呢？开。
22的。
这是瓣膜工作位。
我们现在的收缩压115，舒张压55，可能我们这个椭圆有一点不是太能接受，虽然它的这个血液动力学各个方面都好，我们想给它 post dilate 一下，
后扩一下哈。
22吧，好吧。
那陈主任你记一下刚才现在椭圆的那个半叶工作的这点，待会儿我们后扩完再看看它的改变。
对。
22的球呢？
所以这个瓣膜看起来它的 radial force 还蛮好的，
是的，挺好的。而且我觉得它放起来还是有一点这个比较 use friendly 的那种自膨的。我们现在看那个 Aortic flow 啊，它释放起来好像特稳定特好，它当然是它特殊的那种做法。但这个Tonus 的这个系列来讲，我觉得比起其他几个我们 domestic 的一些设备，它放的还是比较稳定。它的包括它的支撑力啊各个方面。还有跨弓的能力，各个方面都还是比较不错的。唯有一个是我们用它第2代的时候，它遇到一个特殊情况，比如说特别 horizon 的或者钙化不太好进去的，我们需要用 snare 的时候呢，它那个头部因为它清水太厉害了，所以它就抓不住 snare。那后来他说，在最新一代里面，他们把那儿多搞了一些相对能够被 snare 住的一个区域。再改进了。
其实用 fluoroscope sometimes 就是有的时候反而更好看这个瓣膜是圆还是不圆的，还是哪个部位，所以可以有的时候可以转一下这个角度，其实更容易看到。但是你可以从这里看到，就是说它的前后这个可能是比较窄的，因为你这个 nose cone pour 那个 pour through 的时候，你可以看到这个地方是比较窄的，就在瓣膜的上，应该是
对，叶教授那对的非常对。我们这样顺便再打其他的角度，看看其他的 angle， 它的这个角度看的还不太清楚啊，可能这个角度更宽一点，是吧？可能比较窄的还是刚才我们的左前的角度。对，
刚才我们打那个这个角度
这个应该是最那个短径的那个角度，
半叶那个缝的切线位。
我们就用这儿进行一个扩张，准备好吗？那个准备起搏哈，好吧？
多大的 balloon， 多大的球囊
？22的，来手上拉着就行了，我们不要进去啊。好，来准备啊，来起搏，180，好。
不停，
起搏停。我踩的是电影，应该，球囊先退出来吧。好像那个腰还是有一个明显的扩张起来哈。
有明显的被撑开的感觉。
但是 recoil 还是很明显。
对，还是有 recoil。我们这样换成主尾擦擦压差，然后我们再看看那个食道超声，看看刚才那个瓣膜的平面是在它的
往上还挺高的，15、16。
在底边往上多少
它这个 Tonus
？Tonus 你的瓣环工作的那个平面离你那个底边的距离是多少？5毫米。哦。
它比较低，
从下面5毫米，也就是在猪尾的中间左右，是吧？就是它瓣膜工作的区域，在缝的呢还更高一点。
这个我们是 annually mounted 还是这个 supra-annually mounted？
它应该属于一个 super annular mountain 的这么一个瓣膜，但是它可能相对那个 Vita 的那个 core valve 要稍微低那么一点点，但是它还是属于一个 super annulus mount 的这么一个 valve。我们叫个0，
交换一下，
叫
个0。那个你去食道超声看看我们刚才的那个同样的位置，看看。
这里的。
好了，上了，可能还是有点压差。哦，还好。
压差有多少？看看。
还好，1。
还不错了，systolic 112、113，也就是1、2的压差，基本上没有压差的。那个我们食道超声再看看。
现在是实时的 live，
还是有点好一些，
好一点。
比刚才好一些。
看看食道超声比刚才的那个椭圆更加好一些。3个半夜在工作的那个平面接近远了，比刚才椭圆明显有所改善了。
是的。
OK， 那个等一会儿我们在这个生主动脉再做一个照影。把这个取出来吗？
放在这钢丝里面。
对，这个
结了。
这个周围取出来。
结了，不用断开。直接拉就好，拉出来。
拉起来。
直接拉。
阿朱，你说这个瓣膜在选择上，你是用 self 的还是用 blown 的？在这种情况下面，
我是觉得，
当然也没有统一的标准。
对，
你的建议怎么样？如果是这种非常 calcified，
造影机，
我还是会选择这种 safe spending，因为它 Q 型太 heavy 了，所以我用 balloon expandable 我还是会有点觉得 concern 这个 Q 型那么多，会不会有些？不过我想大概2种都可以啦。但如果这样选一种的话，我会选择用 safe spending 的。
可能我如果做，可能有不同的想法，因为瓣膜这个 aorta 是比较大的，总的来讲它这个 aorta 比较大，所以因为用 self expandable 都会有这种non-circular 的 situation。不管你这个 balloon 怎么做，到最后还是撑不住，都会有这个 overshape 或者。我可能会选择 sapien valve、S3 valve，因为它没有太多的 risk for 那个 aorta injury 的可能性，我可能会这样，但是这个东西没有什么对不错，这是每个人的有点 preference 或者怎么样。但是当然呢，你讲到这个 risk， 当然还是会有。
是的，就是这个病人实际上也是做 SAPIEN 3，我们看了一下他的钙化结构，应该还是可以的啊，作为一个选择。因为它的钙化没有看到特别大块那个脊，打开以后呢，也完全可以分到那儿，可能会更加圆一点，的这种选择。所以我觉得也是 SAPIEN 3和 Self-Defense 对这个病人都应该合适。有一些钙化的分布可能对 SAPIEN 3不合，这个病人应该是可以。那刚好这个病人经济状况是非常不好，所以基本上现在是 Frey 给他做了这么一个临床研究。看了，
王院长，我想问一下看，现在是 retrospective 啊，这个瓣膜是26号，那么从这个看上去好像这个是会不会是有 underexpand 非常明显？那你现在用的 balloon 是22，你会不会考虑更大一点的 balloon？
看前一张，我们来看那个 balloon 扩张的那一下。
叶主任，这个26的瓣，它的收腰的地方可能最窄，也就是22或者23，其实我们能够选择的最大的这种瓣膜，可能也就是22和23。如果太大的瓣膜，可能会对它的这种瓣架上的这个瓣膜造成损伤，可能会有一些负面的影响。
会有结构上。那我们看到，实际上这个扩的还是非常腰实起来了，但是它还是有一些 recoil 啊，有些 recoil。那因为确确实实钙化比较重，那个支撑啊 radial force 呢，这个算是我们 radial force 里边算是中等度的，还是不错的一个结果。
对，令人非常 impressed 的地方就是说，这种钙化这么多，结果没有看到任何的 AR 哈，那非常好的结果。
所以还有一个想法就是说，虽然我们根据 annulus 的26，我们很有可能单纯以 annulus 为这可以放29的，是吧？但是对这个病人来讲，我们如果放29的，同样他面临一个那个地方的支撑开的，他对，那我们仍然是他的那个 radial force 的比例的话，可能圆更大一点，那可能会更加不好。所以对这个病人的钙化，我觉得选择稍微小一点，而且我们能够解剖结构上看应该漏的不多，主要是在瓣环上的一个分。所以觉得就选择了26，可能对他来讲比较合适一点。这病人年龄有70岁，刚过完，前天生日。那 QRS 呢跟原来一样，还是应该对他没有影响。这个高度的话，应该影响也不大，所以未来病人也没有一个 pacemaker 的担心。所以我觉得对这个病人来讲 ，EF 原来又那么小。症状很明显都是跟这个 Aortic AS 相关的，我相信对病人的预后还是不错。将来即使是我们做冠脉或者是将来在 valving valve 也还是有机会。
我想这病人像之后的 anti-thrombotic 的 strategy， 你们会怎么使用？
我们这个病人没有 AF 吧？
常规我们就是可能双抗3个月，或者如果像这个患者，因为他比较虚弱，出血的风险比较高，可以说我们冠脉又没有什么狭窄，也没有房颤，所以我们基本上术后就是单抗作为他的这个抗栓的方案。
现在好像前一段时间吴永健他牵头跟我们也联合想做一个题目。他是想用一个终点是那个 HOT 的比例的减少，还有一些 stroke 的发生等等那些数字，还要做一些头颅的CT-MR， 然后我们来比较他想直接用这个单抗，现在好像是 warfarin 是吧？keep 一个 INR， 用3个月，后来再转成单抗，和通常我们经典的就是用一个单抗。相比较的这个结果，那我们不知道将来结果，反正好像这样做，我觉得也有意义。到底看看可不可以减少 HOT 呀，可不可以再减少其他的一个风险？ 有做这么一个多中心的研究。
那像这个瓣膜，现在反正没有一个 standard 的这个 protocol 给 anticoagulation。那像这个瓣膜，现在因为的 data 有 show， 就是说你这个瓣膜不是那个圆的话，可能会增加那个 risk of clots thrombosis， 就是说凝固的可能性比较多。像这种病人，你可能会比较会不会用更 aggressive 的，就是说 anticoagulation。
有一些我们没有单纯因为这个稍微椭圆或者椭圆一点就去给他用 anticoagulation 而改变，这个单纯的 antiplatelet 的替代的方法，还是主要是根据他有没有 AF 有没有这些风险，有一些有冠脉风险的，我们可能也会更加 antiplatelet 会强一些，那也是在调整根据他的出血风险。但是呢，我们这种情况，因为我们现在这个structure heart 这个 team，像这种病人常规可能在3个月或多长时间，我们回来还要给他扫一个 CT scan， 还要分析一下，然后我们一直在测这个超声，都在定期的 follow up， 看看他有没有这个压差有没有改变，这些也是跟紧的 follow up。发现有一些病人确是在之后的几个月以后 gradient 在增加了。那我们就及时的赶快再去，加上比较强的抗凝治疗 ，keep 一个 INR 在过渡，是这样。但是好像没有太发现 stroke 的病人，也没有太严重的这个问题。
好，谢谢王院长跟王斌教授精彩的演示哈。请问您是不是还有个 live 要做一个 case 吗？没有了吗？哈。
还是看时间。
那个病人在接的吗？
在对面。
哦，我不知道有没有时间，因为那个是一个 J9 valve 的。
因为
我们本来是放那个 J9 valve， 后来咱们那个曹教授，你们希望我们做一个 bicuspid， 那因为前2天都没好，刚好这个病人比较合适，所以我们又把它 bicuspid 去做了。如果有时间的话，我们那边也可以就是再放，因为都准备好了。
不过很可惜，因为刚好时间刚好。
好的。
要转播到这个时间，刚好时间差不多。
好的，好嘞。
本来很希望看，可是刚刚时间没办法那个。那今天非常谢谢王院长跟王斌教授还有厦大的团队非常精彩的演示，那结果也非常好。那恭喜大家。那我们的转播到这里结束，谢谢院长，谢谢王斌教授，好，谢谢。
好，谢谢大家，谢谢。
1 p.m. and therefore let's take a break first and enjoy your lunch. Thank you. Thank you. Okay. After a refreshing lunch break, we are ready to dive into the engaging afternoon sessions with a focus on lectures associated with conduction disturbance after TAVR. So please join me in extending a warm welcome to our esteemed moderators and the online panelists. Thank you.
Thank you to everyone that's joined our evening program. And today's program will focus on the conduction disturbance after TAVR. And today I introduce co-chair with Dr. Huawei for the program. And he will introduce the Liu Hongxia for the conduction system patient in patient with follow TAVR. Please, Dr. Huawei 教授。那个华伟教授，你要不要介绍一下牛教授？Dr. Liu is a very famous EP doctor in Huai Hospital, and he focuses on the conduction patient, and there's a well-known the conduction system patients, physiological patient after TAVR, or even any kind of the conduction disturbance. And he focused on the conduction patient after TAVR. We'd like to invite the Dr. Liu for the speech.
Okay, first, I'd like to thanks for the introduction. Today, I'd like to present a conduction system pacing in patient after TAVR. As we all know, TAVR is an effective treatment for patients with severe stenosis at moderate to high surgical risk. However, it is also complicated with conduction disorders, for example, the AV block or LBBB. It was reported after TAVR, 19 to 55% patients may develop new onset LBBB, and 10% develop high degree AV block. Although half of their disorders can recover, yet some do need the permanent pacing. The incidence rate was reported to be 3.4 to 25.9. Recently, guidelines or comments have addressed the indication for pacing after TAVR. If patient with complete or high degree AV block, which can't recover after 2 days after TAVR, this is the class 1 indication for pacing. A patient with new onset alternating BBB after TAVR, this is the class 2 indication. As for the pacing therapy strategy, the most common pacing mode is RV pacing. For example, the RV apical pacing or septal pacing. However, RV pacing was associated with pacing-induced cardiomyopathy or heart failure or increased rate of atrial fibrillation. Given our patient, the TAVR patient, usually have decreased ejection fraction or heart failure, so we wish to perform a physiological pacing for those patients. That is to say, one choice is the CRT, the traditional cardiac resynchronized therapy to insert a CS lead for those patients. Another option is hip-bound pacing or LBB pacing, that is to say the conduction system pacing. Hip-bound pacing is first reported by Dashmaker 20 years ago. It can directly stimulate his bundle to engage the native conduction system. So data have improved that hip-bound pacing can decrease death or heart failure hospitalization compared with right ventricular pacing. The LBB pacing first is described by Huang Weijian 教授 in 2017. It is a ventricular pacing intended to engage all or part of the LBB system. More and more data have improved that LBB pacing can reduce all-cause mortality and heart failure hospitalization compared with RV pacing. Nowadays, there are some trials here addressed the conduction system after TAVR. From those, the figure we can tell the hip-bound pacing success rate is a little bit lower. The success rate maybe 50 to 63. The LBB pacing success rate is a little bit higher, from 80% to over 90%. However, we can tell those studies are all small sample studies, and most of them are retrospective studies. Only one of them are a prospective study. So we did a study to prospective to compare conduction system and traditional RV pacing. So this is a non-randomized single center study. Patient who required pacing due to AV block after TAVR from April 2018 to December 2020 were enrolled. After enrollment, patients were randomized to receive RV pacing or conduction system pacing. As the conduction system pacing, they were alternatively allocated to attempt hip-bound pacing or LBB pacing. This is to say, one patient tried to hip-bound pacing, the second patient LBB pacing, the third hip-bound pacing, the fourth LBB pacing. Then, excuse me. In all, 60 patients were enrolled with mean age of 78 years old. We can tell from the figure on your right, right ventricular pacing was attempted in 30 patients, and all were successfully implanted. Of the 30 patients who underwent conduction system pacing, 50 patients first tried hip-bound pacing. Among them, two patients who have the float time over 20 minutes, and 4 patients who have a high capture threshold was failed the hip-bound pacing. That was transformed to LBB pacing. And for 15 patients who attempted LBB pacing, 14 of them will succeed. Only 1 patient failed due to high threshold, due to cannot screw into the myocardium after 3 attempts. So in all, a total of 10 patients was assigned to the hip-bound pacing group, 20 patients to LBB pacing group, and 30 patients to RV pacing group. according to the baseline character, there were no significant differences. We can tell from the table, the QRS duration, there are no significant difference in the paced QRS duration between his-bound pacing and LVV pacing. However, in the RV pacing group, the paced QRS duration is very longer. Is longer. The patient in each his-bound pacing group, the threshold, the pacing threshold is very higher. And the sensitivity, the R wave amplitude is very low. After 15 months follow-up, the pacing percentage were very similar among the three groups. The his-bound pacing group still had the highest capture among the three groups, and the lowest R wave amplitude among groups. For echo, we can tell some echo parameters. The conduction system pacing group and RV pacing group had similar baseline LV ejection fraction. However, after follow-up, we can tell the conduction system pacing group had achieved a higher ejection fraction compared with RV pacing group. During follow-up, we can tell some prognosis. There are one patient in RV group had a capture threshold increase. This is only one procedure-related complications. There are no procedure-related complications in other two groups. 3 patients in RV pacing group was admitted to hospital due to heart failure. As for the all-cause deaths, there are 4 deaths in RV pacing group, 4 with including 3 patients due to progressive heart failure and 1 due to non-cardiac death. In LVP pacing group, there are only 1 non-cardiac death, and there's no death in his-bound pacing group. So our experience tells us conduction system pacing achieved a shorter paced QRS duration and better cardiac structure and function in patient after TAVR than our traditional RV pacing. LPV pacing had a higher implant success rate and a better pacing parameters than his-bound pacing and RV pacing. So in summary, TAVR is an effective treatment for intermediate to high-risk AS patient. Some of the patients require permanent pacing after TAVR. Some studies have addressed the feasibility, the safety, and effectiveness of a conduction system after TAVR. However, our concern is how to improve conduction system success rate and at the same time to ensure the safety of the procedure, to decrease the complication rate. In the future, a large-scale prospective randomized long-term follow-up study are needed to address the conduction system pacing in those special kind of patient. Thank you.
Thank you, Professor Neil's excellent talk. That we have 2-3 minutes discussion, and I will have a question for you. Is how do you decide LVV pacing or the his-bound pacing? And could we use the conventional lead to do the conduction pacing, or does we need the his-bound pacing lead to do that?
Okay, thanks for your question. Actually, in this study, we just designed, this is a randomized study. As for the conduction system pacing, we are alternatively allocate the patient to his-bound to LVV pacing. But in fact, in clinical study, I usually do LVV pacing. You know, his-bound pacing can achieve the native conduction system and is considered as a physiological pacing mode. However, there are several limitations. I mean, the high threshold, the low success rate, the high lead dislodgement rate. So usually we now perform LBB pacing, but not hip-bound pacing. Another question, another reason for not perform the hip-bound pacing is because the lesion site of the conduction system caused by TAVR is usually located at the distal part of the conduction system. So maybe the hip-bound pacing cannot cross the lesion site, and then T2C cannot correct the conduction disorders. So we prefer to do the LB pacing. Just I present my result. You can tell in this study, LBB pacing did achieve a higher implant success rate and higher at better pacing parameters. So in my opinion, LBB pacing may be more suitable than hip-bound pacing than RV pacing as a primary treatment option for patients after TAVR who need pacing. Thank you.
Thank you, Professor Liu. And please stay in the list. Maybe we have time to discuss more about the physiological pacing. And the next speaker is Dr. Man Chatatombi Mo. He is a very world-class famous cardiac surgeon, and he will talk about pacemaker after TAVR. And we welcome Dr. Man.
Hello, thank you, Dr. Lee. And my talk today will be on pacemaker after TAVR. This is my disclosure. As we all know, the relevant anatomy of the conduction system is run just below the implantation site, which is perimembranous septum, and so it's almost inevitable for the valve implantation, in particular with the TAVR system, that we use the oversized way to anchor the TAVR valve. So there's a good chance that the TAVR system can have interaction with this conduction system as shown here. The distance between the membranous septum varies, and it can be very short, just below the bottom of the non-coronary cusp. And the mechanism of the conduction disturbance could be from direct compression, could be from hemorrhage, hematoma, could be from inflammation. And some of these are quite difficult to be avoided. However, TAVR valve with high radial force, large oversizing, or the self-expandable system that had ongoing enlargement over time, or valve material plays some roles. Also some ischemic injury from hypoperfusion or aortic regurgitation. Incidence of pacemaker has been in the past, I think it's been one of the major TAVI-specific adverse event. You can see here ranging from 10 to up to 35. I still remember when we first do TAVR, especially balloon expandable system, or when we have the Lotus system, the pacemaker rate can be as high as 35%. But that was back in 2017, and since then we have been making changes. In terms of timing of the AV block and PPI post-TAVR, usually occurs in the first 48 hours, up to 70% of the case, and 90% within the first week. However, it still can occur later on, but much less. The predictors that are well known to cause conduction disturbance are clinical, EKG, anatomical, and procedural related. And EKG, as we all know, the pre-existing right bundle branch block, first degree AV block, left atrial hemi block, or prolonged QRS, anatomical risks such as membranous septum length, calcium burden at the location site, annular LVOT calcium, or the procedure itself, oversizing, TAVR system, and relation to the prosthetic oversize in terms of two annulus and LVOT, and the depth of implantation. In the old study, 2017 again, the predictors that seems to have the highest predictor would be the baseline right bundle branch block or self-expandable valve. Depth of implantation is also important. Oversizing, the more oversize needed, the higher risk of PPI. It seems that also the operator volume appears to be related to the PPI rate, not so much in the balloon expandable valve, but in the self-expandable valve when we need to be deployed not low into the annulus with a self-expandable system. So volume is helpful in terms of get improvement. Also, there's different ways to look at how to reduce the pacemaker. One is the membranous septum length, and if we can deploy the valve or implantation depth less than membranous septum, then the risk of new permanent pacemaker is much lower compared to if the implantation depth is more than membranous septum depth. And I think with that, lately we had been measuring membranous septum length in our pre-procedure planning as well. As you can see here in the high-risk group, is if your membranous septum less than 2 mm, if you had underlying right bundle branch block, but still, if you can deploy the valve less than membranous septum, then the risk of pacemaker is low. So that seems to be important. A newer risk factor to predict a pacemaker also that not only corporate membranous septum length can also use right bundle branch block or calcium in the landing zone area. And if you have all three risk factors, the risk is higher. Also, the calcium in the left coronary cast, which is the opposite of where the conduction system is. If you have high calcium on the left cast, there's a chance that the valve may not stay in the center and be compressing more. So all these are anatomical risk combined with underlying EKG. Next is people talk about if pacemaker is related to clinical outcomes. There was some conflicting data. Some data up shown here show that pacemaker is related to mortality, but this is at 1 year, but some study, meta-analysis also show that it does not affect mortality. Why is that? I think with the most recent meta-analysis, I think this is quite recent, 2020, involved more than about 50,000 patients. If you look at here, if you have new onset left bundle branch block, you increase all-cause mortality, cardiac mortality, hospitalization, and also pacemaker implant. But when you look at the pacemaker implant, in this meta-analysis show that if you have no PPI, all-cause mortality is better. Cardiac mortality favor if you implant the pacemaker. But I think this the reason of the pacemaker had kind of unclear if it's related to mortality or cardiac mortality is that when we decide to use a pacemaker or not, it's had some depend on the threshold of the implanter or the center to implant the pacemaker, and that's why this had some kind of conflicting benefit or not so benefit. Whereas if you use a left bundle branch block or conduction system issues, which is not we don't have a physician opinion into it, then we can clearly see that it's definitely not a good thing. And most also importantly, if you have a left bundle, you also increase risk of permanent pacemaker. So I think that is important to point out that when you look at the pacemaker alone, the result is conflicting because of there's some judgment involved. We also look at a little different thing in terms of whether ventricular, we use the endpoint of ventricular pacing dependency, meaning that we would like to look at if we use a pacemaker, is actually how much patient really need to be paced, because some of them can recover after a certain time period. So we have conducted a small study from our data, 150 cases, excluded 3 cases. We found that, and this one, we include the patient who already have a pacemaker, and to see if they will require being paced more after a TAVR or not. And what we found is that we implanted 22 new pacemaker, and at 1 month, 7.9% it has become a ventricular pacing dependency, and about 6.7% at 1 year. So to see if they really need to be paced. And with this as an endpoint, ventricular pacing dependency, we found that the only 2 predictor of these are baseline right bundle branch block and the PR prolongation of more than 178 milliseconds. And in the group that required pacemaker dependency, relatively small volume, but had up to 8 years follow-up, it had not affect the mortality difference. When we look at all-cause mortality, new pacemaker rate and ventricular pacing dependency is not a predictor of mortality, whereas baseline ejection fraction and SDS score is. So that's of interest. I think also the impact in terms of economical impact on a pacemaker is also very important, because pacemaker make expensive procedure even more expensive. Also, I think it's prolonged hospital stay, potential added risk and complication from the procedure, and also long-term related PPI clinical outcomes. When we talk about now, we are moving towards lower risk patient, and this is the randomized trials come out of a low risk patient of a partner tree and Evolute low risk trial. When we look at the numbers of 2-year pacemaker rate, it's 8.9% in the SAPIEN group, whereas the Evolute group, 2 years pacemaker rate is still 17.4, which is awfully high in a low risk patient, and that give us all to improve, including the company, to trying to improve this pacemaker rate significantly. Having said that, I think in the surgical group had a pacemaker rate of about 6%, 6 to 7%. So all these patients are deemed to have pacemaker in some way because of their had conduction abnormalities probably. TPT registry, again, same for balloon expandable. The pacemaker rate hasn't been changed much over time, whereas the self-expandable valve has been increasing, and this is data up to 2020, and this is kind of comparable with the randomized controlled trials. So let's focus on how can we do better in terms of different kind of valve, and how can we choose the valve. This is the 4 kinds of valve we have available in my center. Or the balloon expandable, self-expandable, supra, intra-annular design valve. And when we look at for the SAPIEN itself, the data from the SAPIEN 3 and the XT, actually the pacemaker rate is a little slight higher in the SAPIEN 3 group. Ultra is about 6%, and it's pretty much the same as our data as well. For the Evolute, it start off with the 26.3 in the core valve group. With the Evolute come down to 17, as mentioned, and now with the Optimized Pro, it can go down to 8.8. With the new system, Navitor, which is a new generation of particle, the pacemaker rate is ranging about 10 to 15%, and Accurate Neo is about 5 to 10%. Focusing on Evolute Pro with the cast overlap techniques, I won't go into detail. We all know that we can reduce the pacemaker rate to about 7.6% in hospital, 30-day 9.4%. And most recent Optimal Pro clinical trials, when focusing on a proper valve deployment techniques and specific looking for aortic valve conduction disturbance. If you have all 4 steps, which we all do for the cusp overlap view, we found that the pacemaker rate can go as low as 5.8%, 9.8% permanent pacemaker rate. But if you do all 4 steps correctly, can go down to as low as 6%. Accurate NEO is also another important. We can deploy deep, but because of the loadal strength, which is very less lateral strength, the pacemaker rate in the accurate NEO2 registry of 500 cases is only 6%, which is also very acceptable. Also, there's a registry on a patient with underlying right bundle branch block comparing the NEO to SAPIEN 3 also show that it may help reducing pacemaker rate in these patients. For the SAPIEN itself, implantation height also important. If you deploy low, the rate of pacemaker is high. High implant is definitely less pacemaker rate. So there's also room of improvement in a SAPIEN 3 or SAPIEN family deployment too. For interest of time, I think this is the way to deploy it high from the new techniques which use RAO caudal view, which is like a cusp overlap view, and use radiolucent line with the targeted implantation depth of 1.5 mm compared to the deployed in the coplanar view. And that has also shown that even with these techniques, a balloon expandable SAPIEN can reduce the pacemaker rate to 5.5%. Also, the left bundle branch block also down to 5%. So this is a sample of deploy high in the SAPIEN valve, and you can see that the EKG has no change at all. Another important part to decide in terms of pacemaker is when to put in a pacemaker. So this is the expert panel consensus in 2019, focusing on pre-procedural evaluation, procedure prospect, and then divided the patient into 5 groups from no EKG changes to in between and to the high grade heart block. If there's no EKG changes at all, there's no need for temporal pacemaker at all. But if you had pre-existing right bundle but no EKG change or EKG change, you can do the temporary pacemaking overnight and then further reassess. And for example, in group 4, if you have new onset left bundle branch block, it really depends on which part of the algorithm you are in. And in some that had left bundle branch block resolution, no further EKG change, we can remove the pacemaker and telemetry for 1 day and promote early discharge on day 2. Whereas if you had a progression of QRS complex duration and or PR prolongation, then consider a pacemaker. So this is a kind of algorithm in terms of when to decide to deploy the pacemaker. Also, some rapid atrial pacing to assess PPM risk is also of interest. You pace the atrium and see if there's any ventricular block. If no, then you think it might be okay not to put a pacemaker. So my conclusion that because of the proximity of the anatomy, conduction disturbance will remain one of the complications, will stay with TAVR. And it also had adverse clinical implication. I think with a better understanding of mechanism and predictors of conduction disturbance, now we have a better TAVR design, better implanting techniques to lessen the pacemaker. And I think special attention is needed to the modifiable predictors, some of them that we can make it better, and also appropriate post-procedure patient management. Thank you.
And because of time limit, we move the next speaker.
Okay. Our next speaker will be the local host, Dr. Lee. On this section of the conduction disturbance after TAVR, we have speakers talking on how to predict the conduction block and how to do pacemaker implantation after the procedure. And next, we are talking about the telemonitoring of the conduction system after TAVR procedure. Dr. Lee, as the speaker, as we all know, he's a very famous cardiovascular surgeon here. However, he's also one of the doctors who are doing cross-field expertise. His main focus is the TAVR procedure. He has been mentoring the TAVR device implantations in this island. He also mentored us before. Dr. Lee, please.
Today my talk is Tele EKG monitor after TAVR. I'm Yang Chai Lee from Chengxin General Hospital. Next. And we know same-day discharge or minimalist TAVR, that the patient go home earlier, and almost the patient hope that one-day discharge. However, in the largest trial, the 30% of patients already have the pacemaker, and the after TAVR still have 1% of patients need the permanent pacemaker. And if patient need a pacemaker after discharge, maybe bring some risks such as the sudden death, accidental injury, even the head injury. So that we need to take about what kind of patient need the special care. So we do a telecare monitor for patients. Next. And in the previous, but this is a very old trial, as they show the pacemaker rate usually there's occurred within 7 days, and the most in the OR or after 3 days. However, still have some patients need the pacemaker even after 30 days. So that 1 day discharge is still safe for patient. Next. So we do a prospective non-randomized EKG monitor for this patient, and then totally 204 patients received the Tele EKG monitor. 49 patients signed the permit for routine device. The routine device is a 24-hour continuous monitoring the EKG, and every day the machine automatically send report to the telecare center. And the other 165 patients signed a permit only for symptomatic drive telecare, and if they have symptoms, they just send the EKG to the telecare center. And sometimes they were required to send a report every day. Next. And our results show 49 patients received the continuous 7-day routine telecare. As 3 patients needed the permanent pacemaker within 7 days, and one of the 49 patients without symptom, and he was found bradycardia in our clinic regular checkup. So that he come back for the EKG. Totally, the 61.1% of patients, because of bradycardia, needed the permanent pacemaker. Then we see another 160 patients next. And 2 patients with symptom, and within 7 days, and he need the permanent pacemaker. However, still have 2 patients without symptom, and he sent daily EKG. We found that the patient had no pulse and needed the permanent pacemaker. After 7 days, 3 patients had symptoms, and 1 patient without symptom needed a permanent pacemaker. Totally, there's 8 patients needed a permanent pacemaker in this symptom driver to EKG. Next. So there's a risk in this 2 years, we shift our strategy to cups overlay, and we found the cups overlay technique significantly decrease the incidence of pacemakers, such as before we need implant a pacemaker as high as 50%, and then now we use the cups overlay technique, and that's the overall pacemaker rate is around 3.5%. And also the LVBB conduction block that's from the after the self-expanding valve decreased from 20% to around 10%. Next. And in our retrospective analysis, we found
when we implant higher, then still have the conduction block is related to the baseline QRS and also the depth of the LCC side. Because when the valve implants obliquely, and sometimes we will compression some part of the conduction system. Next. So that's in our conclusion, the EK early discharge is visible, but it should be cautious because there's some patient without symptom and got a falling or something and send back for the pacemaker. Most conduction disturbance within 7 days. Sometimes we found that the pacemaker need implant after 30 days, and half of them are asymptomatic. Early discharge should be incorporated with continuous telecare at least for 7 days, and the symptomatic drive the telecare maybe should be followed up at least 30 days. Thank you.
Thank you so much. It's not very interesting. And it's so short, and have given us a lot of time for discussion. Is any question from the panels? Well, perhaps I can.
Maybe I have a question.
Dr. Wei, please.
Excuse me. Okay, so the complete heart block can occur in the 40 hours, but some delay to 7 days. So this is what is the percentage after 48 hours they have the conducting block?
In our study show that we had found that sometimes the self-extending valve just touch the septum. So in that condition, the conduction block already transit. However, that sometimes the self-extending valve was cut into the septum, and this kind sometimes cause the delayed conduction block because if the valve cut into the septum, sometimes it causes inflammation or swelling, and that cause the conduction block, and this may be lead to the permanent conduction block because of fibrosis or swelling. So that's we usually take care about the valve device and the septum relationship after the procedure.
Dr. Lee, perhaps I can ask you a question. Given that you have the data like this, how do you select your patients for the tele monitoring after that procedure? Do you select patients with a particular type of the device, or you selected them randomly, or you select patient with the existing bundle bunch block before the procedure?
In our center, every patient should need a telecare after discharge at least 30 days. Because in our previous patient, a lot of patients, elderly that's just falling and did not know why. When they go back, and we found that that's the conduction block. So after that, we just monitor every patient at least for 30 days.
Do you provide this service for free, or the patient have to pay out of their own pocket?
They just cost some money, but not much, because we educated the patient about the self-monitoring. And the continuous monitor is much expensive. It's around $200,000 US. And the symptomatic drive is 1 month is around $100 US per month. So that's we just ask the patient pay for the continuous monitor the telecare.
Thank you very much for your excellent talk. Based on your data, I guess in our clinical practice, it is really difficult to predict the delayed conduction disturbance that develops later on after, let's say, 7 days and on. Is there any specific speculation or predictor that somehow you can speculate this kind of patient could be a risk factor for delayed conduction disturbance. Let's say like who develops left bundle right after the procedure and afterwards develops complete heart block.
And in this status, that because our sample size is not quite large, and the pacemaker rate is around 5 to 10%, so that we cannot find any predictor. So we just assume that maybe every patient have the conduction block, and we should know when we retrospectively collect the data from the pacemaker. Even some patient only patient rate is around 3 to 5%. But if we discare these patients, maybe that's have some problem. So that's we need to take care about such a patient. And I think that telecare should be fine for the patient because it's cheap than the admission fee. Because there's a telecare, there's the driver, there's just some few dollars compared to the hospital fee.
Thank you.
Dr. Lee, given that you have the tele monitoring service here, so can I ask you the last question? What is the average hospital days in these patients in the hospital?
Just before telecare is around 10 to 15 days because in Taiwan just a long time ago we just have the CoValve, the first generation CoValve, and most of the patient the implantation depth is around 6 to 10, and after LUR Pro and the CEPIC, the pacemaker rate is around 5, and we introduced the telecare. So the average days post TAVR is around 5 days.
Okay, thank you so much. So perhaps we can move on to the last speech of this session, and I ask Dr. Lee to chair the last. Dr. Lee, please.
So Dr. Yohei is a very famous cardiologist in Japan, and he now practices in the Tokyo University Hospital, and he was a world famous interventionist and joined a lot of trial. Praise Dr. Yohei, and will give us a revise for cost overlay technique for optimized self-expanding valve implementation.
Thank you very much for your kind introduction. And first of all, I would like to appreciate the kind invitation for this wonderful meeting. For the next few minutes, I would like to review the latest cost overlay technique for optimizing valve implantation specifically for self-expandable valves. As shown by the previous speakers, TAVR-related conduction disturbance is mainly with these two, new onset left bundle branch block and advanced AV block, which requires permanent pacemaker implantation. So the recent low-risk trials show that for balloon expandable valve platform, the permanent pacemaker rate was almost comparable with their surgical arm, 6.5% versus 4%, whereas in Evolute low-risk trial, the pacemaker rate was significantly higher than the surgical arm. So why should we reduce pacemaker implantation? As shown by the previous speakers, it is associated with higher medical cost, higher rate of risk of infection, prolonged hospitalization, and negative impact on cardiac function. I guess most of you already have gone through this recent review named abnormal conduction induced cardiomyopathy in JACC. And it is associated with adverse cardiovascular event. This slide was already covered by the previous speakers. It is a new bundle branch block is also associated with higher all-cause mortality, higher cardiac mortality, and heart rate hospitalization. And permanent pacemaker implantation is also related with higher all-cause mortality and heart failure hospitalization. The predictors of left bundle branch and permanent pacemaker is quite described in the previous literature. Obviously, the baseline right bundle branch block carries a really high risk for permanent pacemaker implantation. Recently shown that shorter membranous septums carries higher risk. And for us physicians, implanters, what we can do during the procedure is to modify these technical issues, mainly control the implantation depth and based on the appropriate sizing to avoid overmuch sizing. So we know that there is a variation of the conduction system from patient to patient, and pre-procedure CT assessment is feasible that we learned from the previous literature. So I would like to just go briefly review the highlight of the cusp overlap. The key point is to isolate the non-coronary cusp, which is basically the lowest part of the annulus. And cusp overlap view isolates the non-coronary cusp by overlapping the right and left coronary cusp. So it usually goes to the RAO caudal imaging plane. And the advantage of this view is that it maintains the basal plane alignment. The three cusp is aligned in the straight line, same plane, and also elongates the outflow tract of the left ventricle. And it reduces and almost reduces or removes the parallax when we implant the valve. So we don't need for further adjustment in most of the cases. So this middle picture is the so-called three coplanar view that we started with the procedure to go for the aortogram. We are familiar with this view, but mostly we cannot implant the valve because we need to remove the parallax. We used to go to LAO to remove the parallax, but basically the LVOT shortens in this view, so we can mislead the depth of the valve in this view. So nowadays we switched to the cusp overlap view, which we started, let's say, several years before. And at that time, we were not so familiar with this view, but now we're quite familiar and used to it. No need to remove the parallax in most of the cases. If needed, we just adjust a little bit by the fluoro. And the advantage is, as I mentioned, it isolates NCC while LVOT elongates. So first, we need to determine the cusp overlap imaging by the CT scan. We can move to the RAO caudal view by using these S-curves. And by doing so, we can assess the depth accurately, especially on the NCC side. So the L and left and right cusp overlap projection isolates the non-coronary cusps, elongates the LVOT, and maintains these cusp alignment to provide a better view of the depth. So by making the projection to RAO caudal cusp overlap view, we slowly expand the valve as shown in this movie. So it minimizes the interaction with the conduction system, which highly potentially avoids the new onset conduction disturbance. So after deciding the depth of the non-coronary cusp side by with cusp overlap view, we go for the LAO view to make sure that the valve frame is under the left coronary cusp as well. And then we finally release the valve. So just two cases. This is the Avril Pro Plus case. So first, we expand the valve in the cusp overlap view. I basically used the control pacing to stabilize the valve while expanding and confirm the NCC depth at cusp overlap view. In this specific case, there's, let's say, 3 or 4 millimeter depth. And check the conduction at this point. If there's an advanced AV block at this point, we can recapture and implant the valve a little bit higher. And if there's no additional conduction disturbance, we go to the LAO view to confirm the LCC side with this view. And this leads to the final angio, really nicely implanted both at 4 to 5 millimeter depth, both on NCC side and LCC side. This is a navigator gaze. Basically, we can apply this cusp overlap view technique with all self-expandable valve. Currently in Japan, we mainly use Evolute FX and Navitor for the self-expandable valve platform. So basically the same thing, the cusp overlap view implantation, confirm the NCC side with this view, and go to the LEIO view to confirm the LCC side. And this leads to the final deployment of the valve. So what does the evidence show? It was already shown by the previous speakers, but recently published optimized pro study showed that if we strictly follow this 4-step cusp overlap technique, there's a higher chance of reducing incidence of pacemaker implantation. Obviously, the baseline right bundle branch block carries higher risk for permanent pacemaker implantation. So we have established this Ocean TAVR registry. I guess Kentaro Hayashida will give us an overview of this registry tomorrow. But for this study, the pre-cusp overlap view era, we had a very high permanent pacemaker implantation rate of 16.9%. Since it was mainly the valve used was classic core valve, we could not recapture the valve for this specific valve. Evolute low risk had 17.4% of permanent pacemaker implantation rate. Optimized Pro now reduced to 9.8. The recent data from our Ocean TAVR registry using this cusp overlap technique reduced dramatically to 6.1%. And additional tips and tricks can further improve to lower our permanent pacemaker rate. So what kind of effort can we make to reduce pacemaker implantation for the procedure? As we discussed, the optimized implantation depth using cusp overlap is essential. To make the transcatheter heart valve depth less than the membranous septum length is crucial. Imaging guidance also helps. We basically use ICE, intracardiac echo, since this can really nicely visualize membranous septums during the procedure. So we use this for, especially for self-expandable platform guidance. And we published several papers based on this evidence, really dramatically reduces pacemaker rate. As for self-expandable platform, we can appropriately use the function of recapturing, which also helps to reduce pacemaker rate. And optimized sizing, the message is in some specific anatomy, we should not go too aggressive oversizing for, since it could cause a higher pacemaker implantation rate. So as for summary, pacemaker rate can be reduced with cusp overlap technique. A low and single-digit pacemaker rate can be achieved, as shown by the previous speakers, with Evolute platform and potentially with other self-expandable platform valves. Implant depth and valve deployment techniques are obviously important factors. Cusp overlap approach provides a more accurate view of the depth during deployment. Several experiences with the cusp overlap technique showed better outcomes with single-digit pacemaker rate. And this is also shown by the previous speaker, but conduction disturbance could be reversible. And we quite often experience this reversibility. Therefore, site-specific protocol for permanent pacemaker should be established with the EP team. Thank you for your attention.
Thanks, Dr. Yohei. Dr. Edgar, Professor Weika, do you have any idea from the Singapore experience about the cusp overlay or conduction disturbance?
Yeah, so nowadays it's a routine for us to do the cusp overlap view for all the self-expanding valve platforms. We have been trying to use the same concept also for balloon expandable, but not as much. I would say majority is routine for the self-expanding. Our main challenge is actually trying to understand also some of the newer nuances in the bicuspid, which I don't want to bring too many things into this talk, but but the bicuspid one's a little bit more complex. And it's sometimes also the other thing we also learned is that this cusp overlap technique also isolates the left main. So there's not just the advantage of the implantation of it being perfect, you can also look at how the interaction with the left main is in patients with concern about coronaries. So I enjoyed your talk very much, Yohei. Congratulations.
Thank you, Edgar. Nice to see you.
Any question from the audience or the panel?
Yeah, I have a brief comment. I know that we are in the conduction system session, and I think it's important to reduce the pacemaker rate. But at the same time, because we gonna implant this valve in the younger, lower risk and probably younger patients, there's also a price to pay to deploy high, because that will make us more difficult to do TAV in the future, especially in younger patients. So what's your thought on how to compromise the ideal spot? You know, we actually, I have moved back to not so high recently, but again, yeah, just want to see your thoughts, just to look at all around for our patient.
Well, this is an excellent question and comment. Thank you so much. Really appreciate it. Actually, as you mentioned, for especially for relatively younger patients, this concept is really important to for the potential for second intervention, as you mentioned, TAV in TAV, or for coronary access standpoint, it is really important. So we basically change the strategy based on the patient background, let's say age, if the patient has previous coronary disease or potentially future need for future coronary access. For those kind of patients, we intentionally implant the valve a little bit deeper, but still within the length of membranous septum. So there's always a trade-off and difficulties for this specific scenario, but it is really important. Thank you so much.
Dr. Ono, can I ask you a question? Because when we went through the slides, we saw one case that you deep advanced the some kind of catheter. It should be a guideliner deep down.
That's right.
The LED
right.
for the protection.
Yes.
Is that the unique practice in hospital? Is a general use the product?
Thank you very much for another question. That patient had a very low coronary height, especially for the left coronary height was like 8 or 9, with very small sinus of Valsalva, with really bulky calcium in the left coronary cusp. So it was a perfect combination for very high risk coronary obstruction. So we intentionally implanted the valve a little bit deeper, and we protect the coronary arteries, as you mentioned, using the guide liner. So we basically implanted the valve, inserting the guide liner quite deep in the mid LAD. And after that, we slowly removed the guide liner and checked whether there was a direct occlusion for the left main. At that specific case, we ended up implanting a drug-eluting stent to cover the left main as well as the let's say neo left main, a little bit longer for the coronary flow, to obtain the coronary flow.
Because of time limitation, and we still have a lot of questions to the Professor Huawei or the Dr. Neo and the Yohei. Because of the time, that's we must close the section. And thank you all speakers and the panelists. And thank you again.
Thank you very much.
Thank you.
Okay, thank you.
So the lectures were truly impressive. So I hope that all of you have learned as much as I have. With further ado, let's now proceed to the next topic, optimization of TAVR in bicuspid aortic stenosis.
I enjoy.
Let's welcome our moderators, Dr. Wei Xianying and Professor Zhen Ye and our esteemed panelists.
Okay.
于院长好。
先宝。
于院长好。
嗨。
祝贺大会圆满成功。我看叶剑教授也在。你看他从加拿大都飞过来了。
飞过来，就差你没飞过来。
于老师好。
Okay. Hi, dear colleagues. I'm Dr. Ying from Zhenxing General Hospital. Together with me will be Professor Jian Ye. Is Superintendent Su Xi online? 还没有。Okay. This session will be a really hot topic regarding bicuspid aortic stenosis. I think this is really important in this part of the world because Oriental people, the instance of bicuspid is much higher than that in the Western society, more than 10%, I think. But from the TVT register, just only 2 or 3%. So it's a very, very important issue in Asia. So we invite all the experts in this field. Hopefully we can start with a case and then we discuss how do I treat for this case and from different center opinions. And then we will have a mini review to discuss current update of knowledge or data regarding TAVR for bicuspid aortic valve. Then we will have a panel discussion. Well, shall we start from a case? Have we prepared? Ready? Should be a live case. Can we go to the case room? Oh. Well, we'll have to wait. Okay. This case is a live case from Zhenxing General Hospital. The on-site operator will be Professor Cao Dianping and Professor Lin Yongzai. Dr. Li, are you ready?
Professor Ying?
Yes. Dr. Cao?
Yeah, we are still preparing. Can you go to Zhe'er first?
Okay, we go to Zhejiang University affiliated second hospital. 先宝，你那边好了吗？
院长，我们是3点50分转。
哦，你们是
就先把这个 bicuspid 的这个 session 先讲。
OK。先宝是要讲 case 嘛，对不对？
他先是讨论这个 case， 就是你们那边是先把这个 case 讲一讲，我们发表一下意见。
现在赶快 case。不急就算了。
总之还在准备嘛，是吧？我知道，准备好了没有
？Professor Ying, we are ready to present.
Okay, good. That's great.
This case 4 is a bicuspid valve. Please next slide.
Okay.
And, the patient came for hospital because of the short breath and the pulmonary edema, pneumonia. He has osopnia for times within these 2 months, and she has comorbidity of the psoriatic arthritis, multiple joint involvement, and she was under immunosuppressant, and he have a previous infection endocardititis for the aortic valve, and also he had the tuberculosis disease pneumonia and cured by the anti-TB medications. The STS score was 2%, and the case priority score was 0. Hemoglobin was 13, and the creatinine was 1.08. And the NT-proBNP was 4,000, even after the inotropic and the diuretic therapy. Next. And here we can show the echocardiography, and this is a very typical bicuspid valve with moderate to severe aortic dilatation and moderate aortic stenosis. Next. And the pressure gradient was 19/35, AVA was 1.2, and this view have severe aortic dilatation. Next. And multi-slide CT show here the area was 517, 1 parameter was 87, and this is a true bicuspid valve, quite high, coronary high of the left and the right. Membrane septum is also long and around 15. Next. And quite good iliofemoral artery. And we also check the waist method measurement for this case is around 26. Next. So this our plan is a right radial artery for sentinel brain protection device, right common femoral artery for main device, and with a 34 millimeter Medtronic LR valve. And the 2 profile will be used, and the left common femoral vein for the patient.
Okay, thank you for your presentation. I think because in every center, they have their own strategy or approach for this kind of patient. First of all, we would like to invite Dr. Jimin An from Asa Medical Center to discuss this case. Dr. An, please. Great to see you online.
Okay. So I'd like to show you my slide. I prepared some slide. Can you see my slide?
Not yet.
Yes.
Okay.
Am I correct? What is the patient main pathology? Aortic valve stenosis or regurgitation?
Both, mixed type.
Both.
You have moderate aortic stenosis with the area around 1.3. And severe regurgitation.
Yes. Thank you, Dr. Chairman. So I'm Dr. Tan from Assam Medical Center. So I'd like to discuss how to treat this patient if this patient is our patient in Assam Medical Center. As you know, the Assam Medical Center favors SAPIEN 3 for the even bicuspid AS. After introduction of SAPIEN 3, predominantly we implanted a balloon expandable device instead of self-expandable device. So the next issue would be the device sizing for SAPIEN 3. Based on this body registry show that the annulus is the most smallest portion of even in bicuspid AS. So we mostly use the annulus sizing instead of supraannulus. We consider the supraannulus structure, but we mostly depend on the annulus sizing. SAPIEN 3, the another important consideration is don't do oversizing too much. So for bicuspid AS, calcification is very important. So compared with tricuspid, the bicuspid is associated with a higher calcification volume and associated with the bad morphology. The eccentric calcification, left calcification, alveolar calcification may be associated with worse clinical outcomes. So this is our oversizing device oversizing in bicuspid and tricuspid. Look at the small amount of calcification. Even though bicuspid, we apply the similar oversizing with tricuspid, but the severe calcification volume is more than 400, 1,000. We do not oversizing too much, just nominal sizing. So bicuspid aortic valve stenosis, heavily calcified, particularly with a high-risk morphology, we do not oversizing, sometimes less undersizing. This is our strategy. So far we implanted 125 Sapien 3 for bicuspid AS. Acute in-hospital and procedure outcome is very favorable. So compared to this patient, annular stage was the 502 square millimeters, very low aortic valve calcification. I would like to consider the two things: annulus size, annulus area, and calcification volume. So annulus, based on the annulus sizing, 29 is 18% oversizing. So 26 is minus 6% undersizing. So I'd like to select 29 Sapien 3, and with the 2cc underfilling around 10% oversizing, I'd like to start with the 29 Sapien 3 with the 2cc underfilling. In this case, this is our center's strategy. Another interesting point is the patient, the calcification is very low, even though bicuspid AS. So I think the dominant pathology would be the AR. So that's one cause. But today we published the new data. Some patients have very low aortic valve calcification. This data based on the tricuspid aortic valve disease. Such a patient associated with the higher mortality compared with the high calcification volume. So this patient, I like to call it the fibrous dominant AS, younger patient, the female, more frequently dialysis, so higher rate of long-term mortality. So I think this is a very interesting finding. We need a further study on this field. Thank you for your attention.
Thank you very much, Dr. An. Next, we ask Dr. Liu Xianbao to present your opinion on how to treat this case if it were your patient.
Okay, thank you, Professor Ying. Thank you for inviting me to join this fantastic session. Yeah, so for us, for bicuspid, we usually use the Hangzhou solution. Professor Wang developed the Hangzhou solution for bicuspid AS, especially with significantly calcified leaflets. We are based on the CT scan. We'd like to use a proper size of the balloon and do the balloon sizing with simultaneously contrast injection in the aortic root, and then we can divide it in four groups. The first one is very severe waste with no regurgitation, and then we have downsizing choice of the valve. If there's waste with the regurgitation or no waste, we will not downsize of the valve. Is moderate to severe AS with the severe AR. And we can see right here, the patient is bicuspid and the almost no calcification. We can see right here. Yeah, so this is not typical case for the Hangzhou solution. So maybe for this patient in our center, we will not use the Hangzhou solution. So how would I treat this case? The first one, the indication, severe AR, moderate to severe AS, very symptomatic. So it has absolutely, we have to treat this case. So however, for this case, I think, so both of the SAVR or TAVR will be indicated for this case. If we choose TAVR for this patient, for the challenges, the type 0, with very, very mild, almost no calcification, and with a little bit of fusion, and the dominant is the severe AR. So for the procedural strategy, I think both of the balloon expandable or self-expanding is okay for this case. For the balloon expandable, I think we should use the 29, the Sapien 3 valve. For the self-expanding, I think we should use the 34. So shall we use the BAV for this case or not? So I don't think we can just directly to treat the case. So for the both of the balloon expandable or self-expandable valve. So the self-expanding valve, I think, is the 34 average pro. Okay, this is my opinion. Thank you so much.
Thank you, Professor Liu. Next, I briefly discuss if it were in our center, what will we do? Please show the slide. In our center, ever since 2016, we found that for bicuspid AS, TAVR is a matter of sizing and consideration of calcification. Next. Because for this kind of patient, the valve is almost always anchored supraannularly. Next. So in our center, we developed the comprehensive sizing method by Professor Wei. Next. We will measure supraannular size first. Next. We choose the NC surface with maximum leaflet opening and throw up and down from annulus to the tip of the leaflets to identify the narrowest part of the opening. Then we measure the long axis, which is usually the intercommissural distance. Next. And then the minimal diameter is from the leading edge of the calcium to the aortic wall. Next. Then we divide them and obtain an average number. Next. Then we make a virtual circle. Next. On this cross-section to see if the valve is fit or not. Then we do conventional annular sizing. If these two measurements are disagree, we choose the smaller one because we want everything to be safe. Next, we will measure the membranous portion and see whether there is a LVOT calcification, and then determine the depth and the coronary takeoff. Then we determine the implantation depth. In this way, next, we think that we can have a minimum diameter for safe anchoring, not necessary to be a final size, because in case there was still paralysis after the valve anchoring, we will optimize the result by underfill or overfill the volume of the balloon. Then next, I think for the balloon expandable valve, we will do the procedure in this way. Next. In some difficult case or borderline case, we will do balloon sizing as Zhejiang Hangzhou solution. Next. But we based on the measurement that we obtained before the procedure. Next. Next. Then we use a stepwise deployment. We first positioning and anchor the valve. Then next, if needed, we post-diet the valve from the inflow or the outflow part. Next. Our method can also apply in self-expanding valve. To do this, the valve sizing mainly determined by the presence of calcification. If the valve is heavily calcified, we usually choose a smaller one with about 15% oversizing. But if the calcification was mild, a regular sizing method will be applied. Next. So in this particular case, we measure the narrowest part of opening, the long axis and the short axis. We obtain 26.2. And the annular sizing, we obtain 26.8. Next. The membranous portion was 4.8 to 5.3. So I think we will have an implantation depth of about 4 to 5 millimeter because coronary takeoff is good. Next. As the valve to be chosen, I think a 34 valve is okay for this patient because the mechanism of the patient's disease mainly come from the artery regurgitation. Fortunately, there is still some stenotic mechanism. So we think the calcification and the fibrotic band can provide good support in this case. And I hope that everything will go smoothly. Thank you very much. Next. Okay, we all present our strategies. Any comments from the, sorry, we should start from discuss how to optimize TAVR with self-expanding valve by Professor Xiu Jiancheng. Because today we are going to use self-expanding valve.
叶院长好啊，那个叶教授好啊，好几年没见了，一下非常高兴啊，再次见面啊。应该是会议沟通的问题啊，所以我并没有准备幻灯但是根据我们这个用自棚瓣来处理这个二叶瓣的这个经验来讲，我们首先还是要第一个还是要确认它的这个瓣叶的这个这个形态是左右共斗的还是左右分开的这种这是第一点。第二来讲呢，因为这个对我们定位的角度选择是很重要的。第二来讲呢，我们要看它整个的瓣叶的这个分布的情况，尤其是一种不对称性分布的时候呢，这个对这个自棚式的瓣膜释放的影响是非常大的。一方面呢是在最初的锚定会存在差异。第二个来讲呢，就是在二次的释放转位方面呢，也会存在不同那么第三个来讲呢，就是我们要非常关注这种二叶瓣的这种瓣环的角度因为常常很多的二叶瓣呢会合并这种横位心大角度的横位心这个也是我们在非常重要的。第三个呢，就是这个生主瓣环到生主横位的这段的这个长度我们也要考虑如果过短的话可能是自棚瓣的这个一个风险的因素那么我们会根据它的这个瓣叶的钙化程度与是否这种偏心来决定是否来进行预扩根据它的瓣TAP 0的这样的一个左右分斗，我们来确定我们的这个定位的体位然后呢这个针对这个病人来讲呢，因为是今天早上给的我看了一下这个病人我看他整个的瓣叶的钙化不是很严重只是在瓣环的少部分钙化像这样的病人呢，我们中心做自棚瓣的话呢，我们可能不会做预扩会做直接的这个释放因为它是个左右分斗的所以在这个Castle Lab 的这个斗底的定位来讲呢，是存在一定困难的，多半是要从左头角度来起始释放，然后释放到工作位之后呢，我们再在这个右足的角度来确认它植入的这个深度这个病人来讲呢，他的冠脉的风险相对是比较低的因此我们会不会事先做这个冠脉的保护第四来讲呢，就是由于它的整个的这个瓣叶的钙化比较轻所以我们整个的释放过程中呢，更会像我们做存反流一样在整个的这个释放过程中，我们也会给予一定的这个起搏包括最后的释放脱钩我们也是会给一定的起搏来保证这个血压的这个平稳这个是我对这个病人的这个整体的自棚瓣，如果是我们做的话的一些理解谢谢殷主任。
Okay, thank you, Professor Xiu, for your excellent comment. I think although you are also very experienced in using self-expanding valve, so what's your comment regarding this case?
Yes, thank you. So we basically choose self-expanding valve for severely calcified bicuspid valves, especially with type 1 calcified Rafa case because it provides better sealing with safety. And for this specific case, since other experts has already commented, but there's minimal calcium with AR as a dominant pathology. So I guess maybe we can apply kind of rapid pacing during the implantation to facilitate stable implantation. Should be my tips and tricks.
Okay, please.
First of all, I have two questions on the patient. First, from the history, it looks like the patient had infective endocarditis. What was the location of the endocarditis, if it is aortic valve or other valves? And secondly, what was the aorta size? Wasn't the aorta dilated? And my second point is, from a different point of view, I would consider surgical replacement seriously. The patient is young, bicuspid valve. So I wonder what was the heart team discussion, the result of the heart team discussion.
Yes, the first question for this patient is the autopsy. I think that when we measure the aorta, the largest is 41, and then the ST junction is around 3.8, and the whole aorta is not so enlarged, so that the patient accepted the TAVR. The second thing is the IE is from the Artery valve is a couple months ago, and he has cured. Because of the 3 months ago, he received an immunosurgery because of spray up of the psoriatic arthritis and the skin lesion. So that the problem is the patient did not hope to flare up again after surgery because it's high incidence of the psoriatic flare up after major stress or the surgery. So that after discussion, the patient insists to receive the TAVR procedure instead of the conventional surgical artery valve replacement. And initially, we asked the patient to receive the SAVR. However, because of immunocompromise and the possibility of flare up, so that after discussion, we decide to do the TAVR procedure for this lady.
Thanks. Good luck on your procedure.
Okay, Professor. Professor, any comment?
Professor Yin?
Hi. Great.
You are ready to go?
Yeah, the valve is in the aorta.
Okay,
go.
Just go.
For a period of time. So
Okay.
we continue, okay? This is 34 millimeter core valve. There's some interaction with the sentinel. 那个形状改了。Okay. And also the pigtail is also
the pigtail. Yeah.
Okay. So we adjust the pigtail. Okay. Okay, 下去。Okay, here. Okay. Okay, 进去后再照。OK， 照个相好了。
照你的近视。
好。下去一点点，要不要
？OK。等一下，再拉伸一下。
好。
哦。还没有。
So how about this position? We are going to deploy at this position.
Sure, please.
Here, this is 34 millimeter valve. We will deploy with pacing and slowly deploy it.
Is that too high?
Too high.
Release tension.
Okay.
More.
Back the wire.
哇，再缩多一点。
行。 Pacing
140，
hold 住一下哈，有没有题目在那边
？Too deep, too deep, too high, too high。
诶，往前推一点。
It's too high. Maybe reaches.
下去一点点哈，
要收回来，收回来。
要收回来吗？等下照我先看看好不好？
嗯。
要知道。先到这里好不好？
再见哦。
好。too high，
too high。
那个。
哇，守住。不能
对
回收吗？嗯。不用。哇，前推，我把它拉起来。
别停到下去一点。小心。
Fully reaches.
Yeah. OK。wire position 刚好一点。要放个啊，对啊。好。
讲什么？哇，回收再重放一下。
OK。
回收。OK。对，好。
OK， 好，这样可以哈。
OK。
这样放吗哈？
开始。
OK。那个。
再见哦。
那个。为什么这声音 ？OK 哈。
等一下。哇，再稍微拉一下。
Pull back the wire, release the tension.
Yeah. 那个 pigtail 在底嘛？
继续。
OK， 好，可以，很好。
Okay, good.
好。对，这样可以。
飞机180。
Pacing。
有点深，太深了，等下
不
再拉看看就好。
你拜拜的准备再开2个。
好
来配线好不？给到 A 哦。跟回
太深了吧？
先缩回来一点点。
好。
不是不能放。
对，你拉好哈，你拉一下，对。
It's too big, too deep.
再收。140。
对吗？
再收。
你说哈。
Okay. No.
好，快速。
Release.
再撑一下，再顶一下。
不用。
Okay. Just go ahead.
上面。OK， 配线好不？
好一点。
Still too
deep。
再一下。
再一次哈 ，one more time。
表示你不要看后面。配线哦。140。
可以哈。
Okay.
好。
Hold on.
慢一点。
慢慢的。
Slowly.
这可以。
Much better.
好，
配线好不？
应该可以。
Okay.
还差一点。
Shift to LAO.
没有 ，It's already LAO.
Okay.
Yeah.
I think it should be a little bit higher because after release it will dive again.
Yeah.
A little bit higher, maybe.
It dive. Yeah.
It doesn't change.
再次来。它是滑下去哈。那这个。再次来。好。Yeah.
I think you should deploy slowly.
Okay.
来，120。
配线。
140. more stable. Slowly, slowly, slowly.
Okay. Okay.
Check.
Okay.
有压力哈。
I think it's much better.
Better. So I think it's better, huh?
Yeah, much better.
Any
How about this, all the panelists?
Yeah, I would suggest to put a little bit higher.
Even higher?
Yeah, so I think after the release, the fully deployment, so maybe dive into the, yeah, maybe again, maybe
You
too
should
deep
check
again.
RAO view. From the LAO view, the depth of the left concept looks greater than millimeters.
No, right now you can see right here, it's too deep again.
Pass over there.
太高会好不好？
来。
Actually, the coaxial is not good. So I think even after the several trial, the depth is not easy to make it. So why don't you rotate the device a little bit counterclockwise? Sometimes it can make a coaxial.
Okay. That even we implant a little bit higher. 来，收一点点就。
那你稍微 rotate counterclockwise rotate。
我觉得 rotate 没有用。好，
拉
慢慢拉，120。
对，因为我觉得它这个形态啊，可能你一放完就往下走。它 anchoring 还是靠这个半叶，我觉得再高一点可能会更好一点。
再说。
我怕放错了，看一下。
底端的挤压不明显。
大一点好吧，好吧。
正在那。
再收啊。
再收。
Deployment, yeah.
Please.
I'm afraid the valve will lie more flat and the depth will go even further.
应该可以了吧？
还没，来查一下。
So can you rotate the device further so the device come to the close to the pigtail? Then it can make the more coaxial.
好，差不多，我觉得差不多了。
可以放了。
可以放了，差不多了，不能再高了。
太高了，
手可以松掉一点，手松掉一点。
多了。
不要拉了，不要拉，我觉得可以的，放，没事，放。我觉得可以放。
放开给他们看。
可以放。放快一点，可以放。血压比较低了，先放开工作再说。
No。
出海。
先看看。
滑下去了。
It's too high. I think it's too high.
来配件我付。
再也看一下吧。
你换个角度看看。
OK。
要打药吗？
This position is better.
No。
这个位置。
对，这个位置是最好的位置，最好这么高才可以。对，药鞋用一点。
那个底对齐，现在底是。
因为它的前面是不同的角度啊，所以看起来是比较高啊。
Aligned 吧。
Yeah, from this view we can see.
好像好一点。
对，因为它底部现在是有挤压的。
现在才对齐。
前面没有挤压，所以说它这个现在这个是最好的结果。
现在好些了。
对，它不能再拉了，再拉可能要弹出来。
再拉就飞出来
了。
对，导师要收一收。
The valve position looks good, but since the patient does not have severe calcification, the valve is moving. So please, very slowly release is, I guess, recommended.
看一下那个大
under pacing.
Yeah.
Okay.
Yes, I agree. 180 rapid
pacing, please.
Yeah.
下去点了。OK 啊。
差不多，现在位置还可以。
可以，好位置了。
This position is good, huh?
Yes.
好位置了。
pacing 呢？
对。
pacing
释放。
160或180了。
对吧？
不用。
这要不好拿哎。
现在有一点在滑了，有一点在滑。
对，不用拿住。
它一定会倒一点点下来。
不用顶吗？
不用。
不能顶，这个病人不能顶。
Slowly.
OK，
挺好。
没问题。
对，这个病人，顶的话就顶下去了。
还有一个，OK，
good。
要不
看一下
It's a very difficult case.
Perfect。
它是结构太大了。
对，这不好做。
再说。
太小心。
OK，put back the nose cone。
再说。
OK。
等一下，这样。
Keep the wire。
好，对，OK， 好。
OK， 非常好 ，perfect result。
非常好的位置。
哇。
换句可不可以说一下，看一下那个 echo result。
Okay, so audio expert, this is the echo after the valve deployment. You can see this is the expand of the short axis and long axis view. And the valve is mentioned very well as it's a circular shape. And there's no, I think it's only minimal paravalvular leakage. The central leakage now is caused by the wire right now in the position. So I think the valve is functional very well. It's a very good position. Yes.
OK，
应该是这照相。Take out the wire.
So you can retrieve the wire.
Yeah， 这个的我在照。
对。
再下来一点 ，OK， 好，可以，你可以留着它。好的。
OK。I think the result is really good.
你的压力要打太低。Will you check the pressure gradient? Okay.
0.
1.
0 gradient differences. There's no pressure gradient.
Excellent.
And the arterial waveform is fine. It's good.
Minimal amount of regurgitation.
So we do the final angio.
拿出来吧，一定拿出来。
Pull back the pigtail. Yeah.
The mean gradient is only 3.
3, okay.
Good. Please show the final angio.
T 上来一下。OK。很好，还是。
Wow, excellent.
Yeah.
Move a little bit deeper.
Good result.
Yeah, good enough. 6 millimeter. Both sides.
Yeah, the perfect result, not a good result.
Yeah.
Congratulations.
Congratulations.
So we close the case.
All right. Thank you very much for your excellent presentation and the live demonstration. Yeah. Next, we discuss if the balloon expandable valve is to be used, what should we be taken care of? The next talk will be delivered by Dr. Evandio Cantero to discuss the optimized TAVR with a balloon expandable valve in bicuspid. Please. Yeah. Sure.
I would say congratulations on the team. That was a very good result for a very challenging case. Again, thank you for the invitation. And my talk today is going to be how to optimize the TAVR procedure when you use balloon expandable for bicuspid aortic stenosis. My name is Ivan Dido Kunjoro. I'm from Singapore. And this is my disclosure. Now, we all know that performing TAVR for bicuspid aortic valve is definitely more challenging than our normal conventional TAVR. We know that the anatomy is more challenging. A lot of time, especially in the Asian population, we deal with a lot of asymmetrical calcification, very eccentric, and a lot of time the annulus is non-circular. It's very elliptical, and of course, with the presence of raphe, especially with calcified, we know it's going to be more challenging. And some more in the bicuspid, we're going to have to deal with a somewhat younger patient, so we have to start thinking about the future coronary access and the possible need for re-intervention, such as performing TAV in TAV in the future. And not to mention as well, a lot of this patient has associated conditions, such as low coronary height, anomalous coronary origin, and dilated root. So all these things will make a procedure will be more challenging. Now, I would say there's no one perfect valve for bicuspid aortic valve. But I think, in my opinion, balloon expandable definitely have an advantage when you use it for to treat patients with bicuspid aortic valve. And I think one of the reasons is because balloon expandable have an increased radial force. So they have somewhat stronger expansion when we implant the valve. And that makes the expansion more uniform. And this is important to achieve what we think optimal circularity. And if you look at this is one of the study that was done for SAPIEN 3, and you implant for the bicuspid patient and they look at the annulus on the CT scan after the procedure, you can see even when you compare with the conventional native calcific aortic stenosis, even in the bicuspid patient, the ellipticity index is closer to 1, suggesting that SAPIEN 3 can maintain the circularity even in the bicuspid patient. Now again, this is important because optimal circularity will promote the consistent leaflet function and the coaptation. So possible, this one will have a positive effect on increased durability and potentially can decrease the incidence of leaflet thrombosis. Now, of course, by having an increased and stronger radial force, this could also create disadvantage for bicuspid patients, especially for patients who have LVOT calcification, severe calcification on the commissure, especially if it's in the bulky in one side, because this potentially can cause annular rupture, malposition of your valve, and also significant paravalvular leak. Now, again, there's always this challenging about advantage and disadvantage. So how we overcome all these things and just combine into how one strategy, how to optimize the result when we do TAVR using balloon expandable. So I'll go over a few points. The first point that I want to highlight is the valve sizing in the bicuspid aortic valve. I feel like this is the most challenging part of performing the procedure in the bicuspid. However, this is probably one of the most important things that we need to pay attention to if you want to achieve a good outcome. So this is, I guess we all familiar with this picture. This is from Bavard Registry. And this is when they first introduced the concept of what we call the annulus and the orifice mismatch. A lot of time in the bicuspid, the sizing supraannulus is not going to be the same as the annulus sizing. Now, in the bicuspid patient, if they have what we call a tube configuration of the flare configuration, using the annulus-based sizing should be okay. But we have to pay attention when we have a patient that have a taper configuration. So this is probably about 20% of our bicuspid patient, which I believe, at least in my center, we see more and more Asian patients who have this taper configuration, especially this patient. So taper configuration basically means in which that the supraannulus sizing is smaller or significantly smaller compared to your annulus, especially when the patient has extreme calcification, commissural calcification. This is very important to consider under sizing the valve and not just use your annulus sizing. The circle method is one of the things that we also use when we measure for balloon expandable. And basically, we put the virtual valve on the annulus and go up by 3 millimeter. This is important to predict where the sealing, the optimal sealing will be. And then you also try to predict what potential complication that can happen, such as shifting of the valve, potential causing corneal obstruction, and where the paravalvular leak will happen. And this is how we do the virtual simulation by combining all the method. As you can see on the left-hand side, we think if we put the 26 valve plus 2, on the other hand is 26 minus 2, you can see the interaction in each different level, and you can kind of predict how the valve is going to sit in terms of the interaction with the calcification and the sizing. Now, the good thing about balloon expandable, as we all aware, by using this virtual simulation, and once you predict, you can tailor the sizing just by adjusting the volume of balloon influation when you deploy the valve. So again, I think this is the method that was proposed by the group here from Taiwan. And I think I thank you guys because this is very important, because you emphasize the importance of identifying where the anchoring plane when you do a patient with bicuspid valve. Once you identify where the anchoring plane is, you then measure the intercommissure distance, which is called the maximal diameter, and you basically then measure the other distance from that line to the opposite aortic wall, and then you get what we call this supraannulus dimension. And of course, you compare with your annulus base sizing, and then based on that, then you make adjustment. And of course, the controversy comes when the supraannulus dimension is significantly smaller than the annulus base sizing, which will then make you think that you probably want to undersize the valve. So the second point that I want to mention, in addition to the sizing, is we should try to be able to predict where the valve is going to shift, or if there's any potential problem of shifting the valve during deployment. And when you compare to the conventional tricuspid aortic valve, in the bicuspid aortic valve, we see definitely more shifting of the valve deployment, especially if the patient has raphe, especially if the raphe is very calcified. And the second thing that you have to pay attention, if there's significant calcification on the leaflet, especially if it's only happened in one side. And I guess this is highlighted very nicely from this study from Yoon et al., in which that they also identify that there's two characteristics that the patient have, especially if you have both, then it will have a negative impact on your outcome of the procedure. In terms of paravalvular leak, you will have more annular injury and even mortality. So one of the things that you can try is basically just doing this, what we call a virtual hockey puck, in which you can visualize the amount of calcium, and they put a different color here. The orange color is the one that on the right facing cusp, and the blue one is the one on the left facing cusp. This is one of the patients that we have bicuspid type 0. And you can easily predict that no matter what you do, you cannot have respect the anatomy, then your valve will get pushed towards the left cusp because of the plate of calcium on the non-cusp. And this patient happened to have a slightly low coronary ostium with a long leaflet. So because of this, we predict that this patient has a high risk of left main coronary occlusion, and we end up deploy the stent before the TAVR procedure. So the third thing that I want to mention is that you have to realize that the positioning of the valve when we do a TAVR for bicuspid will be slightly different when we do a conventional TAVR. So the anchoring plane of the bicuspid valve in the majority of the case will be above the annulus, or what we call the supraannulus. And this is where the tightest spot, where there's a lot of calcification on the leaflet and also the commissure. And it is important to realize that we need to implant the valve a little bit higher, because if you just do a normal conventional depth of implantation, you potentially miss the lower half of the TAVR valve, and the lower half of the sapien valve is where the anchoring position is and where the inner and the outer skirt located, to try to reduce the incidence of paravalvular leak. This is one of the example, the case that we do. The red line here is where we think the anchoring is. We implant the valve, definitely is a high implant, but this is intentional. We aim for 90-10, but we end up 100-0. But again, the thing to watch when you implant the valve high is number one, if you put, there's going to be more foreshortening, especially you put more volume during balloon inflation. So you may predict that the valve will probably a little bit higher than what you think. And the second thing, if don't implant the valve too high, if you think that you're going to need to do a post-PAV. The other benefit of high implant for bicuspid patient is probably you potentially can further reduce the incidence of pacemaker and reduce the risk of LVOT trauma. And the third thing I want to mention, if you have a very challenging case when there's a lot of calcification, you can think about doing what we like to call a two-steps deployment, in which the first deployment where you just deploy the valve, you intentionally undersizing the valve as long as you're sure that you can anchor the valve. And then subsequently, you plan to do a post-PAV, and you can adjust the position of the balloon. Now you put the position of the balloon lower as what I draw in this diagram here. If you, you adjust the balloon a little bit lower if you want to avoid the STJ calcification. Now you want to put the balloon a little bit higher, like what I draw in the diagram here, if you want to avoid the LVOT calcification. And the benefit of doing this is that once you put the balloon a little bit higher, so the part that touches the LVOT will be the shoulder part of the balloon, in which somewhat has a less radial force and smaller diameter because they start the taper. So by doing this, you're still able to achieve the optimal outcome, but you're not compromising the safety of the procedure. This is one of the case that we did. In the first deployment, you can see we intentionally undersized the valve. There's a little bit of waste that you can see here. And then you can see the post-ballooning. We put the balloon definitely lower because this patient has STJ calcification. So around the STJ, you can see that only the shoulder part of the balloon is touching the STJ somewhat safer. And then the other thing is, by doing this is sometimes you want to flare the inner skirt of the valve as a little bit bigger, especially if the patient has PVL. So that's the other benefit of putting the balloon lower. And I guess that's few of the things that I want to highlight, but also consider putting an embolic protection device. We don't do it for all our patients, but bicuspid patient is one of the thing that usually we put sentinel protection device, especially when you deal with the younger patient, high burden of calcium, and if you plan to do a pre and post PAV. And I guess some of a lot of debris, most of the debris that we capture is coming from our bicuspid case, like what we show here. So I guess we all agree that bicuspid is still quite challenging in the TAVI era, but the more we know what things to avoid and what things to watch, it is reassuring to see that from the TAVI registry 2019, this is a real life data showing that even when you compare with the tricuspid aortic valve, SAPIEN 3 performed quite good in terms of there's no significant difference in the mortality, stroke, and other complication. With that, thank you very much.
Thank you for your excellent review regarding how to perform balloon expandable valve in bicuspid anatomy. Moxin, can you comment something regarding this? Because you are experienced hand and proctor of balloon expandable valve.
Most of your presentation, that because I personally prefer more using the BV than SEV for the bicuspid valve, because of the bicuspid valve has prone to have a horizontal aorta, heavy calcification, so the balloon expandable valve have more resistance to the calcification, and also large annulus. You can see that the demonstration that during the large annulus is a little bit, a lot of unpredictable movement during the deployment. So I agree more about that. And personally, I will, during the deployment, the first deployment, I will undersize a lot if I make the heavy decalcification. Undersize 5%, 6% is my routine to anchor the balloon first, and then to see what happened, whether to have a post-dilatation. That's my practice.
Let me ask Dr. An. I understand your preference is self-expandable valve. What are the benefits of balloon expandable valve for patients with bicuspid valve over self-expandable ones?
Me? Okay, yeah, thank you. So yeah, most cases we can implant the balloon expandable and self-expandable, but I favor the balloon expandable due to predictable outcomes. So for me, I think the self-expandable is less predictable than the balloon expandable device. And there are two different complications. The balloon expandable high risk of PVL, balloon expandable high risk of aortic root injury. Self-expandable is a higher risk of PVL. So we know how to implant it with the balloon expandable device. We can reduce the risk of aortic root injury. In our registry, SAPIEN 3 registry, no patient suffered from the aortic root injury because initial device size is less than 100% undersizing. So 5% undersizing or severe calcification, sometimes 5 to 10% undersizing start with. So it can make the safe implantation with predictable outcomes. That's why I like to select the balloon expandable instead of a self-expandable device even for bicuspid AS.
Good insight.
Professor, what's your preference?
Excellent topic and very excellent discussions. And I learned a lot actually from everybody. But my own experience more with the SAPIEN valve, I agree with Dr. Lin. I think I usually based on the annular size, but I really based on the amount of calcification of the leaflets or annulus, and then I would usually do undersized first, and then I would decide how much a second balloon. That's how to make the decision. That way you really can avoid the annular rupture. Personally, I never had the annular rupture for the bicuspid valve. I think that's a good strategy to reduce the volume, and then you decide how much you increase. For the self-expanding, I use a core valve, but I just feel sometimes it's always difficult to get the circular, especially for the asymmetrical, very calcified valve. Like this case is this case is mainly is actually AI bicuspid valves, not much calcification. So in terms of sizing on these kind of things, I think it's really not like a typical bicuspid valve. So and then you perfect circular is excellent, outcomes. But just for this morning case, a very calcified valve, so it's always have some non-circular, situation. So that's my preference with the SAPIEN valve. And in terms of the position, how high, I don't go to very, very high, and because if you go too high, and then for the next valve implantation, you may compromise the coronary artery or ST junction if you put it very high. So for the second time, you probably will be the standard will be pretty high. So I'm not intended to very high positioning.
Thank you for your comment. I think today's case is a very good demonstration of using self-expanding valve for aortic regurgitation. Because as you can see, usually we don't use self-expanding or balloon expandable for aortic regurgitation because lack of calcium for anchoring. But in this particular case, because she has calcium and the fibrotic band, so we use that as an anchor. That's why we can do this kind of case with the use of self-expanding. Otherwise, usually we will use a J-valve for this purpose. And the next talk will be delivered by Dr. Lin Huanqiu, and he's gonna show an extreme case with heavy calcification, as mentioned by Professor Ye.
Thank you. Good afternoon, distinguished moderator and panelists. I'm Dr. Huanqiu Lin from Zhenxing General Hospital. It is my great honor to share a case which is the topic of management of paravalvular leakage after TAVR in bicuspid aortic patient. So we came across with this 72 years old male who had a history of severe calcified coronary artery disease and accepted the CABG and complex PCI for several times. Also, he had type 2 diabetes mellitus and hyperlipidemia. Years after the CABG operation, he has diagnosed for bicuspid aortic valve for several years. And years after the CABG operation, the valve degenerated and become more stenotic. So he complained with dyspnea and chest tightness, and it's about functional class 3 status. His ECG is atrial fibrillation with old anterior myocardial infarction. The creatinine function is relatively well, but the NT-proBNP shows that the valve is relatively stenotic to induce his heart to have a very high pressure level. The STS score is 12.9%. So you can see this is a focus view of the aortic valve in transthoracic echocardiography. This is a very severe calcified aortic valve, and also there's a huge calcium burden extend from the aortic valve into the LVOT. So the mean pressure gradient is around 40. Let's see the CT review of the focus on the aortic annulus. The average diameter is 27.9 millimeter, and the area is 618. Also, there's the huge killer nodule over the LVOT. You can see in a long axis view and a longitudinal view also. So as the patient is a type 1 bicuspid aortic valve with left and right fusion raphe. So usually the anchor point is located at the supraannulus plane. So by using the WAS measurement, the supraannulus measurement intercommissural diameter is 29.5, and the leading edge from the aortic wall to the calcified raphe is 19.3. So the average diameter is 24.4. In this WAS comprehensive sizing master, the goal is to identify the minimal safe anchoring diameter. So we choose 26 millimeter valve for, we choose a 26 millimeter valve for simulation. And under the simulation, you can see the valve is relatively mild undersizing, but we see it is more safer than if we, according to conventional annual sizing, will be much safer. So this is the valve deployment. You can see we deploy the valve, start with underfilling 2 cc. So after deployment, the T image at long axis view shows there's a significant paravalvular leakage, which is inevitable and acceptable, yes. And so we optimize the valve further with underfilling 1 cc. However, because of the severe calcified fusion raphe, the valve cannot be it's quite hard to overexpansion to prevent a paravalvular leakage. So with the 3D reconstruction view, you can see the valve is maybe it's an oval shape, and it is constrained by the fusion raphe over the 3 o'clock. And the valve is, although the function is relatively well, the mean pressure gradient is only 2, and peak pressure gradient is only 6 millimeter mercury. So at that time, we stopped the procedure and we accept the paravalvular leakage and try to use medical treatment to control his symptoms. However, 7 months after the procedure, he suffered from several episodes of hospitalization for heart failure. You can see the follow-up CT scan is formed like a diamond ring shape. The diamond is the calcium fusion raphe, and the ring is our valve. So it's pretend to be an oval shape, and there's two paravalvular leakage. On the short axis view, you can see it's on the 2 o'clock and 4 o'clock. And long axis view confirm is a very severe regurgitation. So we decide to manage his paravalvular leakage with occluder device. So we use a retrograde approach manner and to cross the lower portion, the 4 o'clock paravalvular leakage with coronary wire and following with the guiding caster. So after that, the 36802 occluder was deployed successfully. You can see the 3D reconstruction. And now it's from, we see the aortic valve from the ventricle side. So the lower portion is from the 4 o'clock change to the 8 o'clock. And this is the 36802 occluder, which can conceal the paravalvular leakage lower portion successfully. So now we like to deal the second one, which is the more larger one, paravalvular leakage. And now we cross the paravalvular leakage with the coronary wire and follow with the guide caster, and finally with the shuttle sheath. So a 912 VP2 was deployed successfully. You can see down in this angiogram. So with the simultaneous TE guidance, because in this area is very near to the left main coronary artery. So with simultaneous TE guidance, we deploy the occluder successfully. And you can see on the right corner, the occluder did not affect the blood flow of the left main coronary artery. So this is the final 3D reconstruction. The patient has two occluder with one SAPIEN 326 valve, and there's nearly no paravalvular leakage after the occluder deployment. And the left main blood flow was also patterned. This is quite happy ending for the patient, yes. So my take-home message for this case is that paravalvular leakage is not uncommon in aortic stenosis patient, especially for the calcified raphe for the bicuspid aortic valve patient is more prominent. I think this is an independent negative prognostic factor which has negative clinical consequences to affect our patients. So since TAVR has been expanded to a lower risk patient groups, this is necessary, and we need to move our attention to the paravalvular leakage management. Also, the valve development technology is also essential to improve the favorable risk-benefit ratio to the patient. And the third one is the last one. The coronary intervention guiding catheter is useful for delivering occluder device in this case. But it's important to make sure the guiding catheter size is enough to accommodate the selected closure device. Thank you.
Thank you, Professor Dr. Lin, for your talk. Any comments from the panelists? Yes.
Thank you so much for your excellent and very challenging case. So seven months later, for the index procedure, the patient developed heart failure. So based on your image, I recognize that the paravalvular leakage was kind of worsened over the month. So was there any recoil of this balloon expandable valve due to the very heavily calcified native valve?
I think in this patient, the valve is undersizing, and maybe there's some recoil after the valve deployment and after the post-dilatation. Because the calcium is so huge that it cannot be optimizing the valve at this patient.
Yeah,
yes.
Understandable. Thank you.
Thank you for the compliment.
Yeah, we have Dr. Okay Woon from Singapore. Any comment from today's program and the cases?
No, I congratulate the last speaker for the paravalvular leak. I think it's always challenging in this situation to handle paravalvular and TAVR procedures. I think the use of a balloon expandable valve compared to a self-expanding valve may facilitate the sealing of paravalvular leak with the device. But the challenges may still remain, given that it's quite close to the left main, in assessing the coronary artery. From the CT scan, I can see that the closure device is actually pretty close to the left main. Would you think there will be any concern with coronary access if there is a need to do so in the future?
Yes, in this patient, the coronary access is an issue if in the future, as he's a relatively young age, mean age 72 years old. But also there's, I remember there's some graft after the capital procedure. He has some graft is also patterned. So coronary is an issue, but in this case, not that much bigger in this patient. Yes.
I have one question. Thank you very much. Very nice case presentation. How many cases for PVL do device closure for PVL do after the TAVR in your hospital?
5 or 6.
5 or 6. Yes. One. My question is, what kind of the catheter, guiding catheter, do you use? Usually, based on my experience, wiring can be done, but the guiding catheter delivery to the LV is sometimes not easy. So is there any tips for?
Yeah, if it is not easy, it's because of the irregular shape of the track.
Right. Yeah.
So sometimes we will try even to pre-dilate the track.
Oh.
That can facilitate the passage of the catheter, something like we use extension catheter, and then we can deploy the plug easily.
Yeah, thank you.
Guiding catheter do you use?
Usually a straight one, multi-purpose or something like that.
Sounds good.
If there has been no more question, we move to the next talk. Our dear friend from Thailand just arrived in Taiwan, rushed here from the airport. Thank you very much for coming, Dr. Natau from Thailand. He will give us an interesting case presentation. Please.
Hello. Good afternoon, everyone. Thank you for invitation to bring me to Taipei. Just alive, as you have mentioned. So I have the interesting case initial as planned for case discussion, but so this is the case with bicuspid type 1 with calcified raphe and LV dysfunction. So it's an 85 years old female with the past history of diabetes, hypertension, and CX sigmoid. She has been presented with acute decompensated heart failure, and she have clinical failure index about 6 and CSS score of 7.8. This is her BSA and laboratory. EKGs normal sinus with LVs with strain pattern. Echocardiogram have been done have been shown that moderate to severe ejection fraction, reduced ejection fraction, EF about 36% with global hypokinesis. Aortic valve is heavy calcified bicuspid valve with aortic valve area of 0.44 with mean gradient of 70, even though EF is only 36%. Coronarograms have been done. Is no significant coronary artery disease that can explain reduce of EF, and mean gradient in the cath lab is about 64, compatible with the echocardiography. This is her pre-assessment of the CTA with annulus area of 446, and coronary is a borderline low of 9.8 on the left and 11 on the right. You can see it's acceptable of the peripheral access, but there's a problem with bicuspid type 1 with calcified raphe and calcium prevalent on the left cusp, and also calcium score is about close to 4,000. This is the pre-CT assessment. The left is a little bit low, but not that bad. SOV is big, but a lot of calcium on the left cusp, as I have mentioned. And this is scanning on that bicuspid. And this is access pathway. So I think this is bicommissural left and right calf calcified raphe with the type 1 silver. The concern is aortic valve area, aortic valve calciums of 3800 with calcified raphe. Low ejection fraction, gradient is about 70 with borderline left low coronary height and have some calcified nodule in the LVOT. Anyone want to discuss up to this point? If you want to manage, or I should maybe move on to present.
Okay, maybe we can have a discussion on how to and what will you do for this case. Free discussion.
Right.
We have talked a lot about bicuspid today, and start from Mao Xin.
Yeah, I think this is a very critical as already caused the LV dysfunction. So type 1 bicuspid. I have said that I personally I still prefer the BV because of the very heavy calcification. So I think the copper-chromium can resist the calcification. And this one I will do before that. The LV function is not good, so I will do predilatation. Then do the do the BV about a size choice that I will a little bit downsize because it's a borderline between the 23 and 26. So I will choose the 23, even a little bit on the field. So that's my strategy to do for the treatment.
Okay, other option?
I think I probably also agree that I probably will use a balloon expandable in this case. One of the concerns that I have is if you look at the hockey puck view, there's the calcium bridge on the non-cusp. The only concern I have is that although there's a raphe there, my concern is where the valve is going to move towards your left cusp. And you mentioned that the left coronary height is a little bit low.
Right.
So that's the concern that I have. I definitely agree. I will undersize the valve and and go from there. What is the size of the LVOT? Is it? I think the LVOT. Okay.
Yeah, this is the LVOT sizings.
Yohei, are you going to propose a self-expanding one?
Yeah, extremely very challenging case with reduced ejection fraction. But the thing is that patients still can produce high gradient pressure. So if we treat this valve, the patient will feel very well. So I will agree with all the speakers that mentioned about the appropriate downsizing for this specific case. So I would go with Evolut 26. But as already discussed, the patient has relatively low coronary height. So maybe I would go for coronary protection in this case.
So what we did.
How old is the patient?
86. 86. She's
And
quite old.
I'd like to do one comment to them that actually I favor the balloon expandable, but so definitely I'd like to do the balloon valvuloplasty before the valve implantation, but we have to prepare the device valve before balloon valvuloplasty in case of emergent situation.
Okay, so
yeah, that's a good suggestion.
So I think this is all that discussed. We have been concerned about the calcified raphe with heavy calciums, and this is on the THP size evaluation. I think you have been go through. I think with this patient is bicuspid type 1 with calcified raphe, and is on the Bawat is maybe taper type because at ICD is smaller than the annulus. And as you mentioned, it's borderline between 23 or 26 If we put the virtual valve in 23, we have the coronary distance about 5.8, 5.4. But if we put 26, coronary distance will be 3.8. And we did some circle method on this patient on both 23 and 26 valve. I have feel the same that balloon expandable for this heavy calcium is will be appropriate, but we have to be very careful. And the valve, as mentioned, could be shifted to that left side. And on the way method, this diameter minimum is 18, maximum is 24, and average diameter is 21. So I think on this, based on this one, we plan for ref access. We plan for sentinel protection to prevent the stroke. We do a plan for pre-dilatation with 20 balloon for sizings and evaluate for coronary risk obstruction. And if the PBAV is acceptable, we also same the planning for 23 valve, and we have some potential complication with root rupture, paravalvular leak, stroke, and obstruction. And this is the PBAV with the balloon testing. You can see that calcium move and sit in that left main where it is still open, but it's but the paravalvular leak is not that much. So with this information, we thought that we don't need coronary protection and 23 valve would be appropriate. So we did first deploy with the 23 valve at nominal volume. That will be about 9% under sizings. And this is when we deploy the valve. And after deploy the 23 valve, we have the moderate paravalvular leak. And how would you treat it? Would you go with the stop? This is acceptable, a lot of calciums and have we calcified, so maybe this is maybe enough, or maybe stop and maybe wait and see if we need paravalvular leak closure later, or maybe post-dilatation with the same volume or add some volume. Maybe just one quick answer.
Dr. Lin, now you are the expert.
I think I would like to add some volume for prosthetisation in this patient.
Okay, yes, add volume, okay. So we thought about add some volume, but we also have some concern. So we start with the, do the nominal volume and just full expanded. And this is at same volume. And this is our final arthrogram. So I think all the paravalvular leak has been gone and no coronary obstruction. And the final outcome, this is my last slide. So I think this is the, you can see valve is sit appropriately, coronary is no obstruction. And based on the TE, it's just very trace paravalvular leak. We measure, we always measure pre and post, hemodynamic gradient is no gradient and no complication. And she did very well after that. Thank you very much.
Thank you. I think to our experience, the first deployment almost always have some recoil. So maybe
right,
same volume,
yeah, exactly.
Yeah, optimization.
Right, we same with optimize.
Yes, can also reduce the paralytics. Yeah.
I agree. For this kind of valve, you always first reballoon. You don't add the additional CCs because this kind of valve usually under, like you say, they always recoil and under deployed. So you always use the same size, same volume to do balloon first, and then you will decide whether you want to increase or not. Particularly for this kind of very calcified valve, they always under deployed.
Thank you so much.
Thank you very much,
Dr. Nathan, for your excellent presentation. We have a slide show. Why we do this is because we discuss about the cerebral protection in doing bicuspid. We have many cases like this because of rescission and pre or post dilatation. You can catch many debris from the sentinel. As you can see from the basket, you can get this. That's another issue.
Amazing, and you always capture this kind of debris, but clinical stroke is about 2 or 3%. I always amazed. Where did they go?
Yeah, the things are still there. That's why I raised this issue, because we are doing patient younger and younger, and nobody knows in the long run what will happen to this patient. Maybe he will get dementia earlier or something. Mm-hmm. So I think that's an important issue. We need more evidence. So anyone want to add something to this topic? We come to the end earlier. Yes.
Yeah, I guess this is extremely important topics, but unfortunately in Japan, we have Evolute FX, Sapien Ultra Resilient, but Sentinel is not available. So I would just like to ask all the experts, in what kind of patients do you use? If we will sometimes comes available, I would definitely want to use in bicuspid and valve. But what is your routine clinical practice? This is my question.
I think if there's no problem with the cost, I will use it for every patient. But again, cost is an issue. So in our center, we use it for bicuspid aortic valve in valve. And I think whenever we do a valve in valve, mitral valve in valve, etc., there's a lot of debris that we captured. The other thing is if we deal with the young patient, because we don't want any stroke at all, and we sometimes put it for native calcific AS when the gradient is very, very high and it's very eccentric, and you think about post-BAV.
Okay.
Yes, cost is also a problem in Korea. Sentinel is available in Korea, but TAVR device itself is covered by the national insurance system, but Sentinel is only partly reimbursed, so it is more expensive than TAVR itself in Korea. So it is another issue. It looks like most panelists prefer balloon expandable valve for bicuspid valve, but as shown in this case presentation, live presentation, the beauty of self-expandable valve lies in recapturability. So you can do the procedure more prudently. The most difficult part of bicuspid valve TAVR is the accurate angle, the best angle for deployment. So during procedure, we can adjust the angle for parallax and check angio repeatedly. So we can do more prudent, careful procedure using self-expandable valve, I think.
Yeah. The other thing I want to comment is that from the Protect TAVR trial, actually the disabling stroke has been reduced. So I think that's an issue, because if you ask the patient, the most scary thing he think is the stroke, especially the disabling ones. So I think maybe this will be the future. I'm not saying Sentinel is the best, but he can solve many of the problems. Yes.
Sorry. In terms of the bicuspid valve, there was always heavy calcification. Do you guys think any experience with the lithotripsy before the procedure, or do you think that it helps to facilitate the device implantation in these cases?
My personal opinion would be yes, because there are several case reports already been published, but it's also a costly procedure. If you use more than one, and you have to have the more than one lithotripsy IVR machine. Yeah. Anyone had experience on that? Yeah. I think that's the way to go. As I know, the company are developing the bigger balloon for that purpose. All right. If no more question, thank you for your attention and your participation. And I think the discussion and the case and the lecture are all fantastic. Thank you very much. Let's having a break and wait for the next session.
Thank you for your enthusiastic participation. So let's commence the next session. We will have 2 cases will be demonstrated. The first case will be demonstrated by the second affiliated hospital, Zhejiang University School of Medicine. And another case will be demonstrated by our Zhenxing General Hospital. So let's start our.
So we start the first case from Zhejiang. 先保院长线上。
尹院长好。
Yeah.
OK， 我们用中文用英文，我不知道主持人怎么样。
英文比较方便，因为有一些外宾。
OK. Dear Professor Wei and Professor Ying, thank you so much for giving us the opportunity for the live case. I'm so sorry that Professor Wang have the conferences from the government this afternoon, so he will be missed the live case. So at first, I would like to introduce our team for you. Okay, next to me is the Dr. Hu and Dr. Ren and the other fellows from the nationwide for the trainees in China, and also the engineers, the echocardiographer, and an anesthesiologist right here. Okay, next I would like to introduce the case for you. Okay, next slide, please. 下一张。幻灯加下一张。The patient is a 63 years old gentleman and a very severe symptom. And the patient has the mitral prolapse and the paroxysmal atrial fibrillation. And also the patient, because the patient is quite young, however, the patient has the history of the idiopathic thrombocytopenia. The platelet is quite low. So that's why we choose the TEER for this patient. And from the echo, we can see right here the P3 prolapse with 4+ the severe MR, and the LV EDD is about a 5.5, and the EF is normal. Next one. This is the EKG, looks good. Okay, next one. And the coronary angiography is good. There's no need for the intervention of the coronary artery. Next one. Okay, this is the echo. This is the TTE. And next one, let's see the TEE. Next one. Okay, we can see the P3 prolapse, and the gap is about 5 millimeter wide, and the leaflet is long enough for the P3. Posterior leaflet is about 11 millimeter, and the anterior leaflet is about 26. And the mitral valve area is about 4.6 centimeter square. Next one. So the strategy for this patient, so because of the patient is very low platelet, so we'd like to use TEER for the patient. And from the strategy, because of the leaflet is long enough in the P3 area and not near to the C2 commercial, so we will use the long and wide Dragonfly system. Next one. Okay, the Dragonfly is the first device, transfemoral TEER device in China. Next one. So the design is similar with the mitral. I think the mechanism is similar with the mitral clip. However, there are some innovations. So we can see right there, there's a spacer. 不要翻下去，翻回来。Yeah. So we can, and the clip system can be locked at any angle. And also there are some changes of for the guiding catheter. So we can see there are readable parameters. So very precisely manipulation. So then we can, during the live casing, we can see there. And also the stabilizer different there. There's a knob A, knob B, knob C to control the guiding catheter or the clip. And then we can control the system very precisely. Okay, that's all. Thank you.
So it's a Chinese product of TEER device. What's the difference of the Dragonfly from Pascal? I noticed that there is a spacer in the center of the device, the clip. What's the difference between the spacer? The Dragonfly and
I think the mechanism is quite similar. So there's a spacer, and there's a self-locking system, and it can locking at any angle. So at some patient, because of the valve area is not so big, so sometimes we should not close so tightly. So maybe we can locking at maybe 10 degree. So then maybe the gradient is good. Yeah, we have one case at that time, locking so tightly. So then we can lose a little bit. Then the gradient improved. Yeah.
So that can avoid the damage to the leaflet.
Yeah, I think so. Yes.
Okay, great. Okay, where are you now? So you cross the septum and in the left upper pulmonary vein.
Yeah, we already just just finished the septal puncture. Yeah. Then we will introduce the guiding catheter. Okay, Dr. Hu, please. So right now we check the ACT. ACT is 多少?
Yeah, as mentioned by the operators, I guess for this specific case, since the pathology is the 8-3P3 lesion, I guess the septal puncture point is crucial. We need to gain sufficient height in order to aim the medial side of the valve. So I guess the puncture was appropriately done, posteriorly and superior position, I guess.
Yeah. Thank you so much for the point. 新平，你秀一下这个房间一个穿刺，给新平带个耳麦。Yeah, that's the point. So we tried several times. So that first time we tried a very high from the bicaval view. It's too high. So however, the height is not so good. So it's only 3.6. So then we just push a little bit lower, then much more posterior. 你把它放到前后的角度。这是前后的。不是这个，后面那个。最后一个穿刺的 bicaval 保存了吗？没保存对吧？也不要紧。So I think you can show them the puncture side right now. 不是这个，你就直接最后的现在实打一下好了。
Does this patient has PFO?
No.
Okay.
No, yeah. Okay, you can see the puncture side right now. So I think this is a posterior.
Yeah,
and the bicaval view. Okay, this is the bicaval view. Okay, 它进去了。So at the last, the final height is about 3.7, not so high. So we've already tried our best.
够了。
Dr. Liu, I'm Dr. Lin, Lin Maoxin from.
Hey, Dr. Lin.
Okay, because we know that mitral clip, the height, at least we need to 4.5. So is there any different Dragonfly that use such a short height for
导师进去点，导师先进去，导师。
Dragonfly design.
好嘞。I'm sorry, so just a minute. I just focus on the guiding catheter. 啊，你这个方向弄错了，兄弟们。对啊，兄弟们，你这个方向弄错了。来，头一次看一下。They are not familiar with the system. I'm sorry. 来，再看看进去多少，看看。
可以了。
应该进去不少了。
啊，可以，现在可以了。
2公分。
因为它这个可以做2间半，也可以做3间半，所以把这个方向搞反了，做3间半的这个方向。放进去。I'm sorry about that. OK. 看看透视一下，看看。
So you use the same device for tricuspid and bicuspid. I mean the mitral.
Dr. Lee, I'm sorry. Can you pardon your question?
Question.
My question is that because we only have a mitral clip in Taiwan, and we always at least we have need a height of about 4.5 millimeter. So is there any different that of the Dragonfly that you can achieve your procedure with such short distance?
Yeah, we just try. So I'm not really. So honestly, I'm not sure we can do the case successfully at this height, but we can try.
So the bending, the length of the bending side is how long?
现在是进去多少了？看看。
这方向很怪，这方向。
等一下看看，倒试一下。我先看一下啊。
是。
你再是在里边的对吧？
在里面的。
在里面。
好，顶上去了。
没事，不要紧。好。
感觉我看不到刚才多少。
感觉好像进去太多了，感觉。
对，我们再看一下啊。
To be too deep, yeah, more than.
下面你把这个看清楚啊。
more than
我感觉我看不到你，不应该是朝顶上去的。
我要把它打下来一点。再看看。所以不好意思啊，我先把这个操作先操作好，再跟你们交流。
没问题。
你看看现在好一点没有
？Well, can you explain the current situation of using mitral TR or tricuspid TR in Japan?
Thank you. So as for commercial vase,
现在是不是好一点？
as like in Taiwan, we only have mitral clip.
说你那个。现在那个方向各方面是好一点。
We just finished the clinical trial a year before, so I guess the 1-year data is now about to complete. So we're looking forward to commercial approval for the Japanese FDA, PMDA, soon.
What about Pascal?
Pascal, the Edwards are trying hard to launch. They haven't done clinical trial in Japan, but they will use the overseas data and try to bring the Pascal. So I guess within maybe 1 year, we will start maybe.
And how about the indication of are there any reimbursement or commercial?
We have indication both for primary and secondary. Primary, obviously, for high surgical risk patients. For functional, there's no surgical risk. Only there's no high or only limited to high, but the ejection fraction has to be more than 20. We have some limitation for if the patient has some mechanical support device, let's say Impella, unfortunately, it's not indicated. But in the real world clinical practice, we would like to do clips in those kind of patients. So it's a little bit difficult indication.
So such as today's live demonstration case, is it indicated for reimbursement in Japan?
Yes. Yes, for
66,
no.
65, primary, but he has idiopathic thrombocytopenia.
Yes,
yeah. So if the heart team made a decision as a high surgical risk case, it's indicated. But usually based on the age, we send for surgery. Yeah. So I guess this patient, since he is not atrial fibrillation, he's still on sinus rhythm. Although he has significant MR, the left atrial volume is relatively small. So I guess this is also challenging for this specific patient.
There's no too much space for your mitral clip manipulation.
I think that's one of the reasons is that it's eccentric. MR instead of central MR. So what's the surgeon's perspective of TEER in Japan? As I know, for TAVR, initially the surgeon really
always there's a conflict in the beginning. So still the primary, the surgeons insist that the surgical approach is the best option. And we really agree with that, unless the patient is inoperable or very high risk. But for functional MR patients, at the very beginning, the surgeons were very skeptical about this treatment. But since we have a lot, quite good result, especially for patients with low ejection fraction, they now are kind of tolerate. Yeah, they are generous now.
Yeah, before COVID, when I visit Japan, I asked them, at that time, you don't have necessary mandatory condition to use optimal medical therapy before you decide to go for the TEER.
Basically, for secondary MR patients, the guideline-directed medical therapy is mandatory from the beginning. Yes.
Okay.
And after that, if the patient still has significant MR, we can consider TEER.
Are there any peer review process before to get an insurance reimbursement in Japan, or in Japan?
What was the question? Sorry.
Do you have a mandatory peer review process before getting the reimbursement?
We had a clinical trial of Japan.
So the heart team can decide everything.
Right now, yes, based on the local heart team discussion.
Yes. So the insurance company will pay everything.
Basically, yes.
I think it's a rich country. We have Dr. Chen Yisen. You also perform TEER, and you are an best hand of mitral valve repair surgically. What's your comment on mitral TEER, and what's your indication and allocation of the patient? Yeah. You can come up to the stage, actually.
Well, in my opinion, I always think that mitral clip and the TEER will be always my last option in my doing the surgical planning for the patients, because the TEER, I always think that always resolve part of it, because the mitral valve regurgitation is not only the valve or the coda problem. You always have to consider the annulus. If the annulus is dilated, if you are not resolve the problem, then the MR might progress after the TEER. You only resolve the short term. And then in surgery, we perform the valve repair, not only the cord and not only the leaflet. We always stabilize the annulus with the annuloplasty. So maybe the combination of annuloplasty plus TEER might be final result.
Are there any combination in Japan being used? You don't have a cardioband or
we don't. We
Synchin?
only Perctinence devices.
Okay.
TEER mitral. Yes.
先宝院长，我看你们已经放 device 进去了。You have already put the.
就一步一步，我已经到位了，已经。
哦，我们 miss 掉最重要的东西。
没关系，其实没有最重要，我还。OK， 我讲这个 camera 能不能对牢我们这个，把我们 device 再看一眼。camera 摄像机能不能 focus 到我们这个 device 上面来？摄像机能够 focus 到了吗？能看得到吗？看不到好像。对，
看是 M 色。
哦，看得到了 ，OK。So right now, Professor Ying, you can see the device, right?
Yes.
Yeah, okay. So you can see right here. So this is the Dragonfly system right here. Okay. 你们正在
We
看
can
近一
see
点的吗
it.
？And we can see the guiding catheter here. There has the readable parameters. So from the guiding catheter, we can close right here at any angle. 0, 5, 10, we can see right here. So then we will know. So how many angles from the guiding catheter? Or right here, you can the M knob or the AP. So we can see. So there are parameters right here, readable parameters. Then we will know right here. So where is the guiding catheter? So for the 这个中腔怎么讲？什么？Oh, steering guiding catheter. Yeah, so we still can see the readable parameters right here. So for the device right here, so it'll be better for the M line at the 10 to 11 o'clock. So however, for this patient, maybe because the anatomy for this patient is different from the others, so we will not use that. This is only about 9 o'clock. So this the position of the guiding catheter and the steerable guiding catheter. Okay.
Yeah, for H3P3, is there any tips and tricks for this device?
The same.
Same.
Yeah, the orientation, position, trajectory, I think the same.
Okay.
Yeah. Yeah, the challenge for this case is the very small left atrium and the low height of the puncture site. Yeah.
Yeah.
Yes. So slowly, yeah, so for the Dragonfly device, it's much easier to get the right position because not at the straddle. Before the straddle, we can get a more M to change the position.
Okay. So you are going to cross the valve now?
No, so I would like to open the valve Dragonfly system, and then to release the tension, and then check the trajectory before advance the system into the left ventricle. Okay, I would like to open the Dragonfly system right now. Okay.
Orientation.
The orientation is not so good.
Clockwise?
Yes.
Counterclockwise.
Counterclockwise. 你那个再对准我的手啊。So we can change the position right here or close a little bit. And then we counterclockwise rotation.
Does this system have independent grasping?
Yes.
Okay, great.
Yes. And simultaneously LA pressure monitoring.
Oh, great. I think for A3P3, usually simultaneous grasping is enough. Yeah.
没转过来啊。再转一下。So I just rotate the knob C.
So, by the way, what is the left atrial pressure? We expect quite high left atrial pressure with this extremely
Yeah,
severe.
right now it's 38 over 13.
The V wave is close to 40, so very severe.
什么？
It should be an acute MR. Or
再给它打开看一下啊，现在差不多了。好，打了 explain 看一看。So orientation right now is much better.
Yeah. I think the alignment is also acceptable.
So the quality of the imaging is not so good for this patient. 我试一下 trajectory 啊。So what do you think of the trajectory?
Yes.
It looks good.
A little bit medial dive, maybe.
Yeah, a little bit medial.
Yeah, check. Yeah, a little bit. So maybe I can lead. Okay, I'm off a little bit. 这个位置是不是 So the position should be more medial?
A little bit, I think.
Do you still have room to pull the entire system, or the guiding catheter is only a little bit into the left atrium?
Yeah, 再看看大鞘。Okay. Okay, so very small room.
Yes, almost.
That's right.
Yeah.
Yeah, please be careful.
Yeah, almost against the wall.
Yeah.
I think you should bend a little more.
Yeah, yeah. So maybe a little bit. 我退一点点啊，看大鞘。真不行退出来也不要紧。Okay, still a little more room. 好，就这样。可以了。Okay, much better.
Yeah, can we see the color?
Okay, color please.
Yeah, it's.
我觉得你这个图像质量不好。对，线拉过来。
在这里，他们在这里，位置是这里。还往 M 侧去。
So shall we move to more M? More media? I think maybe good.
Yeah, I
我觉得
think
可以了。
have a try.
Yeah, yeah, I think it's good. 但是你 LVO 踢不清楚啊。
宝哥，我觉得还要往 M 侧，血流也是从这边来的，血流从这里来的。
这超声的 gain 是不是太强了？
对 ，gain 可以降低一点。可能是有尾影了。
Yeah.
这就看小的，就是
或者你到3维再去看 3D。从这里看应该可以啊。I think the position is good.
Yeah, it looks good.
Yeah, looks good.
Yeah, and orientation looks good.
Yeah.
Yeah,
Just on the jet.
we agree.
Yes, yes.
Did this patient have commissural valve prolapse as well, or just pure?
Yeah, I think it's just a pure P3. But maybe, yeah, Dr. Lin, can you show the anatomy? Just 前面 the commercial or not? 好，把那个图像打出来。color。二维有没有？
二维有的。
二维再看看。Yeah, this is the before the procedure. 你再切到外面能切吗？
这里不能切，再留在这头。
By looking at the direction of the color jet, maybe some involvement in the commissural valve as well.
Yeah, maybe. 我觉得可能也还真是有哎。
But anyway, the strategy would not be changed. So.
Yeah,
we should try to catch the leaflet once and see what happened.
Okay, I agree.
Are there any other jets?
Yeah, if the MR related to the commercial, so maybe the strategy is not so good. We have to choose the short and the wide and close the commercial. 你再看一下这个 commercial 有累积到吗？
我觉得从这里看是没有的。
前面我们看过是没有的，觉得是没事儿。我们先按照原来的策略，我们先往前走。
这里。
好。 好吧？
那我想可以往 M 侧再来一点。
M 侧再来一点长夹子，可能现在我们空间没有了。
这个因为这个半夜长度是够的。
我再 trajectory 再试一下啊。trajectory 也是可以再加一点点 M， 可以。如果这样只有停呼吸了，再试试看了。那院长，我们就这里下了，我们试试看。
好，
好的，停呼吸。对，停呼吸。我们 OK， so we will advance the system into the left ventricle and stop the breathe. Want to get more media？
过来一点。
什么？
过来一点了，我说。
好，我不能再下去了，再下去我就怕弄了键损。再打开一点，前叶感觉还
对，
前叶感觉还不在。
好。
Okay.
Okay, check the orientation, please. Sometimes the orientation will change a little bit after advance to the left ventricle. Yeah, it looks good. The orientation looks good.
Yeah, it looks
稍微等一下，
great.
可以吗？这我们先夹起来再说。
我觉得可以。
来看看二维，我们等会让他呼吸停在那个地
Grasp
方。
the leaflet.
Yeah. So maybe. Okay. So grasp independently. This is the anterior. This is the posterior. 看到没有 ？Posterior 是不是可以再多一点？
是的。
我觉得再可以多一点。我可以再拉起来一点。Posterior 应该全部都夹到了吧 ？OK， 可以了。好，呼吸恢复。OK， the bouncing is very clear。好，那我就慢慢收起来了啊。So then we will close the dragonfly system。来看牢 LVOT， 看牢啊，看到这个 tension。
Yeah, I think
Focus on the LVOT. Focus on the tension, please.
I think the posterior leaflet is well captured. Yep.
Yes. OK， 还可以吧，张力。OK, close more. And release the tension a little bit. OK, more. More. 还可以啊，看到。
是的。
后叶还是不够多啊，感觉到。
拖的比较高。
对，他拖的比较高哎，感觉还是不够多，但是我已经夹了很多了，已经。哪里还可以啊 ？Close, close, close。
在看后面，我也不知道有没有会不会滑出去。
什么 ？OK。Color, please.
That's good.
Almost no regurgitation. The residual prolapse.
On this part. So this is another one.
Maybe it's an indentation jet from the central and the medial leaflets.
后叶够不够？我感觉已经夹到根部了，已经。高姐，你觉得呢？
我觉得已经夹好了。
哎，但是感觉幅度还挺大的。你看啊，后面你看后叶还这么多。
半叶很厚的。
Can you measure the length you grasp?
对，你的这个长度吗？
那现在长度这样。
对你前面夹的那个时候，你看一下，我觉得其实已经都把它夹的很多了，已经。你看到，从这里我觉得都已经把它，我觉得都已经把它根部都夹起来了。
是的。
是吧？
是的。
I think we have already grasped the leaflet enough. 但是呢，根部那个地方啊，你前面全部都弄好了，对吧？根部没弄好，就根部还露在那里。
在这里。
你如果让你回到前面，就回到之前，就从根部开始量前面，就最好的就把根部都改掉是最好的。
但是它翘的有点高，有点厚的，不一定。
我知道。
比较厚。
那你从这里看啊，停下来，发现根部在哪里？
这里，那这里都比较厚的。
你先把它放，重新再夹一次。啊？
我重新夹，你觉得？重新夹一个。
So I would like to grasp more posterior leaflet. What do you think, Professor Ying?
I'm not sure.
So because you see right there, we just worry about we grasp the less posterior leaflet. 就是我们希望是从根部把它改掉，这个。
Oh.
So although the regurgitation is good, we just worry about the residual prolapse. We want to grasp more posterior leaflet.
Do you think we should catch more?
Yeah,
What is that?
It's a difficult decision, and we often experience this kind of thing that in these frail leaflets, where we try to grasp the leaflet and close the clip, some small part of the leaflet come out of the clip, and as the operators notice that there's a small leaflet outside the system, is there any residual prolapse segment in the medial leaflet?
That's for the length of the posterior leaflet. Yeah, we just check before the procedure and after the clipping. So we just noticed that it's not long enough. The insertion is not long enough.
If there is a residual eccentric jet, definitely we need to recapture, regrasp. But maybe we can just try independent grasping of the posterior leaflet.
Yeah, maybe we can try, okay? So we just open the Dragon Fly system, and we don't need to.
Or one jet only.
Yeah.
Residual jet.
所以我觉得后叶确实不够多，你看到没有？然后你看 ，so maybe, so we can see there the prolapse is too high。这个后叶的这个地方，你看，是吧？我们这样子，我们再往后打，再往后打，我直接把它加到根部，那现在就加到根部了，对不对？我再往后打，你看牢没事，不要着急。OK， 再看牢，行不行？再下这个够厚了吧？等它下来的时候我再下去。
I think you should go down to the left ventricle a little bit and then
这个有没有夹住？可能还没夹住。夹住了没有？现在夹住了没有？现在可能夹住了啊。我可能没夹住。
现在在上面。
没有，它是没办法夹的太多了，你知道吗？
应该再往后去。
什么？
再往后去会被折起来。
折起来也不要紧，我把它折起来有什么关系？你看啊，你先看把这个夹子打清楚。这夹子是不是全部在上面了？我觉得全部在上面了，对吧？你看呢？那现在已经把它全部打折了。好，这样子啊，先关一点再说。Okay, so we try again. I think we just much more posteriorly and grasp more leaflet, posterior leaflet. So still, I'm not sure. 看到啊，就你把这个张力给我看了，你这个后叶显示的不够清楚。因为把这个后叶看清楚，张力看清楚，因为今天这个确实这个整个显像不够好。你能不能把我后叶让我看得更清楚一点？张力给我看清楚。
夹这个麦在这里。
什么？就看后叶，前叶就不要看了。我感觉是不是后叶还是不够多啊？所以说选择长的肯定是对的。
是的，长
你选的短的肯定是错了。
是的，长的肯定没问题的。那你还好。
你这次是不是比前面要好了？
这次好像好一点。
这次已经夹到根部了。我前叶子没有动它。
对。
Yeah, I think this much better this time. 前面看到，因为这个人呢，他是个垂位心了，这个整个显象都不太好。好 ，OK, check.
Can we have color?
Color, please. Okay. So I think so right now we ask much sure to grasp more posterior leaflet. 对吧？这个确实的啊，也只能这样了，不能再好了，差不多了。
我跟你前面关系一样的。
OK，
你说跟前面一样，不可能，比前面肯定是多了。
Professor
color 看看 color 有一点点，再看看 ，Yeah, check the residual prolapse， 看看有没有残余脱。
Professor
还好。
哎呀，这里还是有一点。
是的。
这是 lateral 这侧。
lateral。
I think they still have the residual prolapse in the lateral side.
Yeah, that's what I mean. I mean, maybe we may need a second clip.
对。Okay, check the gradient first.
Professor that we have already deployed the valves. Could we do the valve first and then we go back to the?
Okay, please.
Okay.
Sorry.
先把我们先去看另外一边。Thank you.
Okay. Thank you so much.
Oh, sorry. We forgot you.
So that we deploy the valve first and then we go back to the procedure. Okay.
All right. Just do it.
佩西哦。2:1，这是2:1，现在是2:1。OK， 180，好，
可以打，好，可以打。应该 OK 的，这样 OK 的。然后后退一点。
松一点，太深了。出来一点点。
OK， 好，这样可以。
OK，
好。哎，可以吗
？HMO。
这没办法动了，你要拉，你自己拉。
出来一点点。
OK， 拉很多了，好 ，all the way。
好，就这样 hold 着打。
对，这样 OK 是。
All right。
好。
谢谢老婆。嘿。
好 ，OK， 你再 free 一次。等他英文等你回来再说吧，先等一下。
Align 的吧。
然后那个你看
OK， 好。
OK。
还可以把血压还好。
不用，佩西哦。
I think it's okay. So maybe we can post I or something.
1、2、3、4。OK， 好。
All right.
Do you routinely do the prostylation for such transeptal? Oh
no,
it's
because it's shallow
for morphology. Okay.
Because it's only maybe 1 or even 0 on the atrial side. So we want to make it a conical shape. That would be safer.
小心哦，够到了，哎，还不错。
有。
可能再出一点。好，很好。
So let's please see the septum. Septum, okay. Yeah.
Check the flow and
And mainly left to right shunt.
Okay.
With the iatrogenic SD, yes.
Do you think we need the occluder for this?
No, in our center, mainly left to right shunt is acceptable.
Okay.
And
Okay.
yes.
So that we go to the case presentation and what we do the 那个病 Okay.
Start from the case, please.
Yeah, that's next. This 73 years old male, he got a dyspnea on exertion for 2 months. He received mitral valve replacement in 2020, and because of the mitral valve regurgitation, and at that time he received a TAVR Perimount 29 millimeter. He had a comorbidity of paroxysmal atrial fibrillation, and he received herniaplasty also. The STS-PRM was 10, and the case score was 0. Hematocrit is 12, and creatinine 1.7. NT-proBNP after dehydration is 411. Next. Here we can show the mitral stenosis and the regurgitation is so severely, and the LVOT is neo-LVOT is quite large in this echo view. Next. So the right side pressure is so high, and the heart function is preserved. The ERO for the mitral is 0.7, and the MV pressure gradient was 14/34. The high pressure half time derived mitral valve area was 0.4. Next. So this is a 29 millimeter Edward Perimount valve, and with true ID 28, the stand height was 18. The neo LVOT in this case is 460. The stroke to septum is 19, and the outer mitral angle was 110. Next. And we can see here the mitral septum is quite short. It's around 2.5 to 2.8 millimeter, and the puncture size you can see here is quite short for the procedure. Next. So today we do the right radial artery for sentinel brain protection device, and puncture the septum with SL1 BRK Artery caster and the 12 millimeter balloon. Right femoral vein for main device, and the 29 millimeter Edward Sapien valve with actual 2 millimeter balloon balloon. One plug guide was used for the cordial vein device, and the left common femoral vein was for the pacing. Now we proceed to the valve procedure. Next. So the core artery is okay. Next. So this is puncture, and it's got a little bit quite difficult because the septum is short, and we puncture the mid septum. So that's distance to valve is quite short, and a little above the half of the mitral valve. Next. And then we insert the arteries and use the JR to introduce the pigtail and the safari wire. Next. So here is our tricky stay point, because the safari usually bring all the four systems, so that we use the curved pigtail and cover the aorta, so that when we implant the insert the safari can keep stable and won't keep the device out, and we do the septostomy. Here you can see the safari wire got easier pump out, and we need balloon inflation to see effect on the balloon device crossing the valve and the septum. So that we push forward to apex, and you can see the final 3 centimeter was we bend a little bit so that the valve can go into the apex more. Next. So the shape in here, the septostomy here is relative okay, and we proceed the procedure. Next. So it's got very difficult in this side because the stents stuck in the valve, and we use the pull and the push technique, and sometimes we pull the wire and it can advance the valve a little bit, and sometimes we advance the valve a little bit. So it is yesterday we learned from the couple. And he talked about you need the pull and the push the wire into the device again. Next. Now there's a little difference in our team to position the valve. We usually aim the stroke, the top of the perimount stroke, because the perimount was 18 and the whole valve is 22. So there's if you aim the top of the perimount, there's only 4 millimeter below the annulus. So you can see here the valve projection is 3D, and this is 2 ventricle, and we adjust the balloon a little bit and pull the valve a little bit, and the full inflation. Yeah, and here you can see the alignment after balloon inflation is quite different. However, we can see the valve is all below the annulus. So that's you can see we place the valve in the same line and parallel position, and the valve was in a good position. Next. So that's we usually post-dilate because sometimes the sapien still recoil a little bit, so we always post-dilate and flare the valve a little bit. Okay. The echo pretty show the pre and the post echocardiography, and the LV neo LVOT pressure gradient.
Okay.
Dr. Lin?
Yes, please. Okay. So initially, the valve is relatively stenotic. It's a prosthetic valve, and one of its leaflet is restricted motion, almost not movement, and the other leaflet is pseudoprolapse to the left atrial side. And the mean pressure gradient is 13 millimeter mercury. So it's a stenotic valve with stenotic prosthetic valve, also mixed with the severe eccentric mitral regurgitation. So after puncture with the transeptal, we use the X-plane to monitor the site of the transeptal puncture. So, and the procedure was proceed relatively smoothly. And we can use the 3D to guide the valve to cross the stenotic prosthetic mitral valve, which is stuck from the through ring at the first time. And later it crossed the valve successfully. And this is the post-procedure 3D reconstruction. You see the valve is functioning well, and there's only minimal residual paravalvular leakage, and the mean mitral valve gradient is only 1 millimeter mercury, and the near LVOT pressure gradient is only 1 also. So it's a fantastic result.
So let's see the septum.
Okay, septum. You mean right now?
No, yeah.
Yeah, okay. So this is the septum.
There's still some left to right shunt. Will you close this?
So when will you close the septostomy wound? When there's any criteria or?
I personally think it's a little bit big. Yeah. Yeah.
Yeah. What was the size of the balloon used?
14. Yeah. What's the size? 14 only.
I guess they floss during the
12.
I think probably could be bigger than that.
Yeah, initially I doubted the size of the balloon.
And I think they mentioned that the RV function is not normal as well.
Yes.
And then some degree of pulmonary hypertension as well.
Yeah. How old is the patient? 70 something.
72.
Dr. Lee or Dr. Cao, do you think we should close the septal defect?
I think there's still left to right shunt, and we watch it for a couple of weeks and see if we need that we can do the procedure.
Okay. We can accept that.
I think
Any of
that
you
the
do
12, so that I think we inflate maybe that we wait for 10 minutes so that the septum cannot go back again.
I think that the ballooning may tear the septal tissue. Yeah. So it's flapping there.
Yeah. The previous one is a translator approach. Here is without any suture line over here. Maybe the septum is too thin in this condition.
What's the jet width? Huanqiu?
Yes.
Jet width.
The jet width.
Color jet width.
The color jet width is. So wait for a second. So it's about 0.7 centimeter, 7 millimeter.
Okay, we wait and see.
3D, okay. I
Because
can see the 2D has shows the septum is already partial. Yes.
Yeah, got
Yes.
it.
So 3D, wait for a second. Oops.
It's okay. All right, the procedure itself is okay. So maybe. Is
So
this the
here,
hole?
yes,
Oh, it's really.
the hole in the middle. Yes, this is the hydrogenic ASD. Yes.
Yeah, if it is ASD, we will do it. Okay, hopefully you will getting smaller in the future. All right, we stop here. Thank you very much for your demonstration. Yeah, successful and
Thank you.
thank you.
Thank you.
Yeah, we go back to 这二 to see the result. Oh, 先把你下来了。可以连得上吗？Yep, it looked like that. Residual. 还有一点点 residual。
你转过来了。喂
Yes。
喂，尹教授你好。就我们这边这个二静脉最后已经释放完了之后，后面的反流量在一个少量反流这个情况， 后面这个方向的话位置还挺好，对，也是从3区 P3 A3 P3这个位置，然后反正只有一点点的。
All right.
然后最后的话，从2位来看也是可以的，位置夹子也比较稳定。总体反流成因的话，就是中间还有一点点的一个反流。所以最后我们就没有再释放第2个夹子了，就总体结果达到了一个少量的一个反流这个情况，所以我们就结束这个手术了。
所以释放以后有变得更小。
释放完之后反流量就觉得差不多，但是就说它就夹子看上去感觉有点幅度摆动有点大的感觉。
是有的时候是那个 clip 的 tension 呢。
哦，就还有我想问就是像这种就是说我们不是前面是先夹了前叶嘛，后面再往后叶再去靠完之后再下这个 grip， 这样的话会不会导致就是说我这个会不会一个粘了一个扭曲啊，或者说释放完之后会不会
这个扭转有可能造成 tension， 我们也碰过。
也有可能的。
还有时候严重的会把它撕了都有可能，不过这个还好。
因为这个从这里看感觉是有点在这边在晃的感觉，但最后结果倒是还好，反正也不多，因为我们后叶应该夹的比较多的，够多的这种情况。
OK， 好，谢谢。
谢谢教授，谢谢。
All right. I think these 2 cases are very educational, and we have to accept and do some troubleshooting during the procedures. Any comments from the Yohei and Maoxin, Professor Ye? No? Okay. It should be the end of this session. So I thank you very much for your attention and the participation of this meeting. And today we have many live cases and all successfully been done. And today's program is really compact, and I think all of us have learned a lot. And I think it is because of your participation that make the meeting more interactive and productive. So I thank you for you all, and especially the overseas guests all the way from Japan, Thailand, and I think I owe you all of you. Thank you. Thank you so much.
Okay, let's start our last session and the last leg of today's Taipei Valve Summit, coronary artery disease and aortic stenosis. And let's welcome our esteemed moderators and all participating experts. Thank you.
Thank you. Good afternoon, everyone. And this is session 8, the lectures coronary artery disease and aortic stenosis. And I would like to introduce our moderators. Dr. Washin Badarik, he's from Bangkok, Thailand, and Dr. Myung Ki Hong, he's from Seoul, Korea. I think he is also the director of ENCOSOR, very famous meeting. And about the experts, Dr. Jonathan Yap, and he's from Singapore, and Dr. Marco Babenti, he's from Italy, and Dr. Kwang Yong Lee, he's from Seoul, Korea, and Dr. Xiang Ma, he's from China, and Dr. Zhen Fei Fang is also from China, and Dr. Ho Kei Wong is from Singapore, and Dr. Si Young Kan is from Seoul, Korea, and Dr. Ki Yu Chang is also from Korea. So let's start our program. And the first speaker is Dr. Kwang Yong Lee, but I think he's still on the way. He just arrived. So can we move the second talk by the Dr. Marco Babenti and to the first talk? Do you agree, Dr. Babenti? Is okay with you?
Yep. Can you hear me well?
Yeah, we can hear you and see you very well.
Okay. Perfect. So thank you very much for this invitation. And my talk will be to try to explain how to optimize coronary access after transcatheter valve implantation. And probably, I think it's very important to say why achieving optimal future coronary access in TAVI is very important today. We know that coronary artery disease and aortic stenosis very frequently coexist. So there is a burden of population treated with TAVI today, which have some different degrees of coronary artery disease. And we know from previous literature that this is very important from acute coronary syndrome, which is one of the clinical presentation of coronary artery disease. This is a multi-center retrospective study which involved 38 centers. And in this particular study, among more than 40,000 patients treated with TAVI and presented with STEMI at a median more or less than 1 year, it was a very rare phenomenon, so only 0.3%. So it means that STEMI, which is the most important clinical presentation of coronary artery disease in these patients, at the moment is a rare phenomenon, but still, let's see how this impacts on prognosis. And according to this study, these patients presenting with STEMI who had a TAVI valve inside were compared with patients presenting with STEMI with no valve inside. The results were absolutely clear. We see that the patient with TAVI had a 33% longer door to balloon time, and more importantly, 4-fold higher PCI failure in this patient as compared with a no TAVI group. And this has a remarkable impact on prognosis. So showing that at 1 year, 33% of patients with STEMI having a TAVI valve inside died at 1 year. So this is just to underline the importance of preserving coronary access after TAVI procedure. And this is way more important because we are now moving our indication in younger patients. The life expectancy is increasing very remarkably around all the world. And we know that the coronary artery disease might progress over time. So it's very important to have access to the coronaries. When we talk how to improve the coronary access after TAVI, I think we can intervene in 2 particular sessions. The first one is to optimize the index TAVI procedure. And the second one is just to go back to school and learn how to perform coronary access after transcatheter valve implantation. So if we want to start from the first one, how can we optimize our TAVR procedure, bearing in mind the access to the coronaries? We know that the presence of transcatheter aortic valve in a patient is a great deal in terms of coronary access. And we demonstrated a few years ago from the REACCESS study that there are some factors that can be associated with a reduction of chance to obtaining coronary access. And among them, there are some specific of the relation between the valve we are implanting and the anatomy of the patient. So the relation between the transcatheter valve size and the sinusoidal valve size relation. But it's also important how we implant the valve. So far there is a dogma in TAVI field that the higher the better, because we prevent the risk of conduction disturbances. But we should know that we might pay this prevention for the conduction disturbances by increasing the chance of having some troubles in engaging the coronaries. And this is particularly true with some TAVI platforms, particularly with the valves with a supraannual design and the very short short frames, and particularly with the evolute valve. So we, with this study, we recognized some patients which may be more prone to have an impairment in coronary access after TAVI. And more importantly, when we combine all these parameters, the chance of having an impairment in coronary access or impossible coronary access was very, very high. So in terms of index TAVI procedure, we are learning how to implant our valves better. And one of the aspects is to obtain commissural alignment. We know this is a not problem for the surgical counterpart because, you know, our surgical colleagues, they used to align the commissures when they implant the valve. But a few years ago, up to 5 years ago in TAVI, the commissural alignment of the transcatheter valve was absolutely random. So we have some patients with good commissures, with the commissure well aligned, some patients with not. Today, we know that with the current device, even though there are no specifically designed to obtain commissural alignment, we might be able to obtain commissural alignment. And from this study from Giuseppe Tarantini and colleagues, we observed that commissural alignment was associated with an increased chance to have coronary access after TAVI. And this was particularly true with supraannual design valves, such as the evolute and the Boston Accurate platforms. So as I said, today we can do commissural alignment, and we can do with all devices. There are some devices in which this procedure is easier, is more predictable, particularly with the Accurate Neo and Evolute Pro, less predictable with the Portico device. But in general, with the current devices, we are able to obtain a commissural alignment in a good number of patients. And this is the most studied two devices in the United States and Europe, so the Evolute valve and the Accurate Neo. So basically, by orienting, for example, in the case of Evolute, the flash port at 3 o'clock, you are able to reduce the rate of a severe commissural alignment to 20%. But still, there is some part of patients in which commissural alignment with the current device is not available yet. So with new devices, we know that the companies are working on device with which commissural alignment can be obtained much more easy. And the second part of my lecture is just how can we increase the chance to obtain coronary access after TAVI? And so in this case, I think is the best way to try to explain this is just to bring up some case. And I bring up some cases with the most challenging valve we have in the market, which is the Evolute platforms. We see here that we might have some very small spots, even in case the valve is well aligned, try to figure out if we have to engage the coronaries in this case where the valve is not aligned, so we have just in front of the origin of the ostium, or the part of the valve sealed into the frame. So we have to go from these sides. But I think when we want to try to engage the coronaries, the most important part is just to use a regular J catheter. This is a JL4 catheter. Keep always the wire in and try to aim with a standard J wire the nadir of the cusp you see here, and then advance very gently the catheter and just to try to find a way to find a cell which can be aligned with the origin of the ostia. So one tip is keep always the wire in, because otherwise you're gonna stuck with the frames here with the cell of the transcatheter valve, and try to play with wire and catheters to rotate and trying to find a good alignment between the cell and the origin of the ostia. One of the aspects that some of us talking about reducing the curve of the JL for the JL catheter, I think I found much more useful sometimes to increase the curve, because as you can see here, sometimes it may happen if you have a short frame, the valve, it can stay, the tip of the catheter might impinge on the roof of the sinus of Valsalva. If you have a longer tip, such as in JL4 or JL5, you may go deeper into the coronaries. This is another case example. In this case, we have no commissural alignment, and after a few attempts, it was almost impossible to find a good alignment between the cell and the origin of the ostia. So in this case, such as in this case, we went to the spider view. You see this kind of a misalignment between the tip of the catheter and the origin of the left main. In this case, when you cannot obtain a better alignment, it may be an option to use a guiding catheter and go ahead with kind of called fishing technique. Just park the tip of the catheter in sinus of Valsalva, go with a coronary wire, try to engage the coronaries, like in this case, and use a guide extension catheter. So in this case, may be done as a regular procedure. And you can see also, you can find all these tips in this paper published by our group, in which we summarized some strategies to do PCI in the TAVI setting. So of course, the objective should be to obtain a selective coronary engagement. If you are able to do that, of course, you can perform PCI in a standard fashion. But if you're not able to obtain selective coronary engagement, the first thing to do is try to use a guiding catheter to find a coaxiality between the coronary ostia and the cells we are crossing. And in case not, try to change the cell. But even in this case, it's not available to obtain a good alignment. Using a fishing technique may be a good option, and a guide extension catheter. So in conclusion, we might say that coronary artery disease is highly prevalent within the TAVI population. And we know that lower risk and younger patients are likely to develop coronary events because the progression of coronary artery disease. PCI after TAVI is not frequent at the moment, but it's feasible and associated with a high rates of success compared with a no TAVI setting. Specific anatomical and transcatheter valve patient interacting factors are associated with more challenging or sometimes even impossible coronary access after TAVI. And THV design and implant technique matter. We observed from the REACCESS study and from the aligned TAVI study. And aligned THV and THV with short stent and open cells are proven to maintain easier coronary access. And I've just show you that a few techniques may help to improve coronary cannulation after transcatheter valve implantation. So thank you very much for your attention and open to discussion.
Thank you for the great talk. Yeah. So the commissural alignment is very important for the successful coronary cannulations, and the other benefit is that it may have a better flow hemodynamics, and that may translate into the better valve durability. And from the REACCESS trial, there's a unsuccessful coronary cannulation in 300 TAVI patients, and most of the cases are patient receive core valve. So what is your experience? Is the cover the unsuccessful coronation rate 17.9 something the rate. So from our experience, I think the rate is not that high. So what's your experience about this issue?
So you touched a very important point. As I said before, I think there is a learning curve for obtaining coronary access after core valve implantation. I have to say, when we designed the ReAccess 1 trial, now we are running the ReAccess 2, but when we are in the ReAccess 1 first, no commissural alignment was achieved, systematic commissural alignment. We used to implant the valve very, very high in all patients. So, and we learned this, it may be my impact on easiness to obtain coronary access. As second, we didn't know how to cannulate these coronaries. In the ReAccess 1, we had some time frame in which we had to engage the coronaries. So after 20 minutes, we had to give up because the trial suggested it. So I think why we gained experience in trying to engage these coronaries, this 17% went down remarkably. And another thing is we did this study in a patient in which we just implanted the valve. So we didn't want to force too much in trying to engage in order not to displace the valve. Also because we were at the very beginning of our experience. We learned this about keeping the wire in from the ReAccess 1, because in the ReAccess 1, we just try to engage the coronaries, just pull in the catheter into the sinusoidal valve, remove the wire, and then plug the stopcock and then try to engage. This is not the best solution. And this is why we, two years ago, this 70%. Today, this went remarkably down, but still is there because, sometimes the problem is often this patient came back in no TAVI centers. So they have no experience with the procedure. They have no idea what type of procedure or valve is in. So particularly in acute setting, it might be an issue.
I have one more question. When we select the valve type for the severe aortic stenosis patient and optimize the reservation of the future coronary access is one of the good points. In your data, is the incidence of the coronary artery disease is quite high. So, but among those patients, how many patients really happen in the future coronary event? That is one point. And second one is that that the patient without the TAVR valve, the patient with TAVR valve, actually, when we're doing the coronary angiogram and PCI, this is a totally unfamiliar situation. How many usual in common intervention is how many experience exposed to such kind of situation? The reason why we don't have much experience of in this kind of patient, therefore it is the failure rate is higher. So therefore, I think it's when we have a more experience exposure to such kind of situation, I think it's most of the intervention is to do the more easy procedure in this kind of patient.
No, absolutely yes. So as I told you, and I highlight this once more, there is a learning curve. And I think it's important to learn a few steps that can help in increasing the chance of obtaining coronary access, such as the dose I've just mentioned. Of course, if you keep on trying to engage the coronaries at the end, you might be able to obtain this the coronary access. Sometimes, particularly in an acute setting, my suggestion is if you're not able to do it, the patient with a STEMI unstable, if you are able to keep the tip of the catheter just across the valve into the sinusoidal valve, try to engage through the wire and then go with a guided extension catheter. This is a suggestion I give because I have some feedback from colleagues that have no experience in engaging coronaries with core valve, that just stay forever in trying to obtain selective coronary angiography, and the patient went not very good. I think first of all, you should be able also to understand if the valve is well aligned, but this is like a second step. Because if you realize from fluoro, if the valve is roughly well aligned, you might be able to keep on trying to engage the coronaries in a proper way. But if you realize from the fluoro and you are actually able to understand quite roughly on the fluoro, if the valve is not aligned, the valve is very high, the sinusoidal valve very short, probably it's better to do an angiographic angiogram, an aortic angiogram at the very beginning, and then try to do the fishing technique with a guide extension catheter. But still, I think you have to learn some steps, and then I don't know how many patients you need to obtaining proficiency, but if you understand these steps, I think you increase the chance to obtaining a coronary access. This is your second question. The first question is, how is a very important, you touched a very important point. It's important not to overestimate a problem. This is a problem. This is an issue, but still, if you have in front of you a patient 82 with no coronary disease, the problem of coronary access is really a minor issue. You better probably to preserve this patient from having a pacemaker, preserving this patient from having a paravalvular leak, and so on. But still, you know, the coronary disease problem, the coronary access problem is not a big deal. You need to tailor your approach according to the patient you are in front. And I think today is a problem that probably might be a problem for 20% of patients, but when we are moving to 65, probably 70 years old patients, this may be higher. So I think it's something that we should bear in mind, that we should force companies to work on obtaining coronary alignment, because also from hemodynamic standpoint, but still at the moment we have to be very careful not to overestimating and making decision just focused on coronary access, but forgetting problem like leak, patient prosthesis mismatch, and conduction disturbances.
Okay, because the time limitation, we got to move on. Thank you, Dr. Babanti, for your excellent talk. So the next talk will be the third speech on the program, which will be delivered by Dr. Khalid Sain. And Dr. Sain is Director of Cardiology, Gold Coast University Hospital, Australia. And today his topic is optimal timing and the device selection for TAVR patients in need of PCI. Please.
We cannot hear you.
Thank you. Can you hear me now?
Yes, very well.
Thank you. Thank you so much for inviting me to speak on this topic. I'll be talking about optimal timing of and device selection for TAVR patients in need for PCI. Are you able to see my slides?
Yes, we can see it.
Thank you. So the prevalence of coronary disease is high among aortic stenosis patients. And as you can see from the Partner A trial to most of the registries, a significant number of patients will have coronary disease. However, the indication of revascularization that's specifically percutaneous really depends on a number of factors. And now, in my practice, the need of revascularization depends on whether the patient is symptomatic, especially if he has angina or if she has angina, or prognostic disease, such as patients who have left main or left main equivalent disease. But what about the asymptomatic patients? We have changed our management over the years, now treating more patients who are asymptomatic and have incidental coronary disease. We are treating them medically. And in situations where we are not sure, we can use physiology testing. And occasionally we have to fix coronary disease before TAVI because of technical reasons such as osteal disease. And many times I also take into account the patient's age and the type of the device I'm going to use in case the patient needs down the line revascularization procedure. In asymptomatic patients, we now have some data, especially the activation trial, that compared the patients who were treated medically or with PCI a year after the TAVR. And what we saw that in asymptomatic patients, and the patients with left main and other equivalent disease were excluded, that while there was not much difference in overall primary outcomes, the bleeding risk increased excessively in patients who underwent PCI. Now, a part of my talk is to talk about the timing of the PCI. So if we do have an indication to perform coronary intervention, when should it be done? And of course, there are limitations and benefits of each approach. Pre-TAVI PCI is easier, the coronary access is easier. However, at the same time, there's a higher risk of hemodynamic instability in case the procedure doesn't go as planned. I also worry about the access issue. If I'm using large bore catheter or circulatory support devices before the PCI, then the same access may not be as clean when we use it for a TAVI procedure. PCI after TAVI, the normal issues are coronary access is difficult. However, because aortic stenosis is treated, the hemodynamic issues are less likely. We have done procedures, all of us, where PCI is done at the same time as a TAVI procedure, while we select carefully for patients who simply need type A lesions, but complex PCI is usually performed on a separate occasion. This is just a patient where we had severe coronary disease. The patient was done radially, and everything rather went pretty smoothly. So this patient has severe aortic stenosis, he has 3-vessel disease, and most of the procedure was finished without too much of trouble. However, that usually is the case. However, at times you can end up with severe complications. This was a complicated case where patient had a left main disease trying to be fixed. And during rotablation, there was a left main perforation and patient becomes quite unstable. Now this patient had critical aortic stenosis and hence led to impella and then balloon valvoplasty to stabilize. So what about post-TAVI PCI? The post-TAVI PCI, in my experience, is usually done in most of the situations when there's an acute coronary syndrome. And this is the data by Dr. Mantias et al., and where it shows that acute coronary syndrome can happen post-TAVI, usually happens within the first year, within the first 6 months. And most of them are actually non-ST elevation MI. And what are the predictors of acute coronary syndromes are the patients who are younger age, already have history of coronary disease, previous history of diabetes, revascularization, or acute kidney injury. However, occasionally, patients come with ST elevation MI, and that there are not a lot of patients who come with STEMI. However, when they do come with an ST elevation MI, compared to a patient who did not have a TAVR before, the patients with TAVI have 33% longer door to balloon time and 4-fold higher PCI failure rate. And that failure rate is predominantly because of difficulty in cannulation of the coronary arteries. Now, the why there's a different difficulty in the coronary is because of the TAVI frame. And PCI after TAVI, the re-access to coronary depends on multiple factors, and that may be related to the type of device we have used, the stent frame height, the leaflet position, and also importantly, the method of deployment in many cases, whether in case of self-expanding valves, commissural alignment has been done, what is the depth of the employment, what is the relation between the sinus of Valsalva and the TAVI, whether it is a large sinus of Valsalva or small. The PCI, the re-access for revascularization or angiogram is further challenging when TAVI has been performed in a bioprosthetic surgical valve, or a TAVI has been performed in another TAVI procedure. Now, looking at the three devices which we have in Australia are Evolut Pro, are Portico, and Sapien. I do not have a lot of experience with Accurate Neo per se. And as you can see, all these three devices or four devices have their different characteristics, which make the access to coronary rather simpler or difficult. For these purposes, I divide the devices into either they have a tall stent frame or a low stent frame, such as the Edwards Sapien or MyValve, where the low stent frame helps rather an easy cannulation of the left main and right coronary artery. In case of the self-expanding valves, a major difference is whether the valve has a supraannular leaflet position or intraannular, as that will cause supraannular will cause more challenges to future cannulation compared to an intraannular position such as in Portico or Navitor valve. And similarly, the stent size, cell size, and also the density among the different valves is different. The other issue, coronary access, is the depth of the implantation. And nowadays, in the last 5 years, we are deploying the TAVI valves much higher than we used to, and that's predominantly reduce the pacemaker rate, also to reduce paravalvular leak. It favors all those things. However, when the device is deployed higher, then it makes the future access of coronary a bit rather difficult. As you can see in the left-hand diagram, the Edwards Sapien, while it's easier to get an access in a normally deployed, when you deploy it higher, the access could be challenging. And similar is the case in patients who had Evolut or Portico or Navitor valve. The other issue is where is your commission, if you have done commissurer alignment or not. If those commissurers are in front of the coronary access, and as was the recent discussion, the future coronary access could be challenging. This is one of our case where we recently deployed a 26 millimeter Edwards Sapien, a 29 millimeter Edwards Sapien valve. We felt after that there was some, the STJ was narrow and there was some pinch. It appeared to be, which was not the case. That could be just the angle. However, here coronary access was rather easy, and we were able to do an IVUS quite easily to confirm there was no pinch of the left main coronary. However, the challenge comes when we do self-expanding valves. And as we already discussed, there are some advantages of one over the other. For when we look at coronary access per se, I think having a large cell size, having an intra-annular valve is helpful. And furthermore, what's more important is the commissural alignment. We all have been doing that, and we all well aware of it, how to do commissural alignment. It is essentially a two cusp overlap technique, and whether you're using a Navitor or a Evolut Pro valve, they both have techniques to do the commissural alignment. Especially, it becomes easier if you're doing a cusp overlap technique. Just to summarize the Evolut, if you look at it, and then there will be a C pedal. The top of the C pedal and the head center front is unlikely to change. So if you hold the Evolut with the flush port at 3 o'clock position and you insert it, and while you're looking at it, the head center front is in front of you, and you are in a two cusp overlap projection, which is usually areocaudal, then the C pedal, where the commissure is usually going to be aligned between the right and the left cusp commissure. Similarly, in a Portico and now the Navitor valve, if you keep the flush port at 12 o'clock, then you will, in a two-cusp overlap technique, you'll have the thick frame which will line the valve with the right and left commissure. And this is important for future TAVI into TAVI and for future coronary access. However, the studies have shown that how much we try to get the commissural alignment, it is not always 100%. And some valves are better than the other at commissural alignment by using the usual techniques. And that is predominantly because the underlying, the sinuses are not always symmetrical. And if you see here, if you say 120 degree is the symmetry, as the tricuspid valve becomes bicuspid, that symmetry is lost. So even if you try to do the commissural alignment, it may not be exactly reproducible. And similar is the issue between the coronary eccentricity. Now, I'm just going to quickly show a case where we had a Navitor valve. It was which has a large stent size. It has an annular valve design. And we had a 58-year-old woman, rather a young lady, who had severe aortic stenosis with ischemic cardiomyopathy, had known CTO, renal failure, pulmonary hypertension, peripheral artery disease, and a low BMI. She underwent percutaneous coronary revascularization after an FFR to the left anterior descending artery. And this is her, as you can see, we decided here to use a portico valve because of the extreme calcification and also the calcified STJ junction. Her peripheral arteries were not very clean. One side femoral was not really doable. The right side had a severe iliac stenosis. And hence we looked at the subclavian access and used the left subclavian access to deploy a 27 millimeter portico valve. However, after 6 months, she presented with acute coronary syndrome, and she had all the features of an anterior MI. This is just an angiogram looking at her right coronary artery. The one thing I use is that if you're unable to reach the coronary, I think it's good to telescope the wire and then use a guide liner, which makes the procedure easy. That's her right coronary artery, and we were able to engage with a JL35 guide femoral approach, her left anterior descending artery, and then even easily perform IVUS, and following IVUS, do the revascularization. What about TAVI in TAVI? TAVI in TAVI is slightly different. I have a patient who's 89. He had a balloon expandable valve 5 years earlier, and now has severe aortic stenosis. In TAVI, we have to consider a few factors for coronary obstruction and future coronary access. That what was the depth of employment of the initial TAVI, whether commissural alignment was performed or not, whether the risk plane is below or above the STJ, and what is the device used previously. And this is essentially doing a good CT and then analyzing the CT for the root anatomy in regards to the initial TAVI valve, and then assessing the risk of coronary obstruction. And one thing to be noticed is the risk plane for every valve is different. In case of an Edward sapien valve, the coronary, the leaflets come to the top of the valve, so that is your risk plane. So if the Edward sapien top bit comes above the STJ, then it is going to cause high risk of coronary obstruction. In the evolute valve, which has a supra annular design, the coronaries, the leaflet of the valve will go above 2/3 of the valve size. So this needs a bit of idea. So this is our patient. We just having a quick look. He's planning for a second TAVR. One is to assess the coronary risk. And even though he had a bypass before, he has a dominant circumflex, which is ungrafted, which is above the risk plane. So this valve is not very highly deployed. And we look at this in both the systole as well as diastolic phase to be definite about the coronaries. And after that, we also try to assess what is the mechanism of the valve failure, whether it's a structural valve degeneration or is it non-structural valve degeneration. In case this patient has halt, so that's important because that can cause issues. In case of TAVI in SAVR, that is a totally different ballgame as well. Coronary, while the one thing is to do second surgery, or there could be a snorkel technique, or there could be basilica. They all have their pros and cons. Basilica definitely is preferable for future coronary access. However, sometimes it is difficult to perform basilica, especially if they're both coronaries have to be protected. And this is a case where we did snorkel rather than basilica, where an old mitral flow valve was failing and patient has aberrant coronary artery. So this was going to be challenging. And this was, the coronary access was saved by actually doing a lot of chimney stents. However, the problem is that this is almost impossible to gain the coronary access in future. So this needs a careful decision. This lady was 89 years old, so we did not think she will need it. However, a younger person should preferably have basilica to prevent future coronary obstruction. So I would like to finish my talk there. I think the optimal timing of PCI before TAVI really depends on the symptoms, whether the patients have angina symptoms, or they have a large zone of ischemia, or there is prognostic disease. After TAVI, most of the time we perform coronary revascularization for acute coronary syndrome, which is mainly non-STEMI. However, understanding what device has been used at the index case, whether it was a low implant or a high implant, and whether in case of a self-expanding valve, there was commissural alignment or not, and whether this was a supraannular or intraannular valve are important factors. And now the final thing is, while coronary access is one of the many factors that depends on the individual case, calcification, pacemaker rate, age of the patient, etc. Thank you very much.
Thank you. Because of time limitation, we can take one question. Any questions?
In case before the TAVI, what is your timing for the PCI in patient with severe aortic stenosis and complex coronary anatomy? Is it simultaneously or stage? What I mean is a PCI and then the another day the TAVI procedure in the complex coronary anatomy.
Thank you. We always prefer to do it as a stage procedure, and the timing is more logistical. For us, we work in, we book the patient a month or so before for coronary angiogram. We already have idea on the CT TAVI. So if it is a complex case, we will do the PCI and then schedule the patient a month or 4 to 6 weeks after the procedure, really depending on their symptoms and more logistics, waiting time, etc. We do not do it ad hoc, both procedures.
Okay, so we have a few experience of severe aortic stenosis with complex coronary artery disease and severe LV dysfunction, and we do the procedure altogether. We use a mechanical security support device. We use ECMO and to support the PCI procedure, and then we perform the TAVR. So the cases will treat smoothly. So
okay. It's time to start the interesting cases presentation. First speaker is Professor Kang from the Seoul National University Bundang Hospital. Dr. Kang, please.
Thank you, Dr. Hong. Thank you, Dr. Hong. I actually thought my role is a lecturer, so I prepared a couple of cases. So in case that we still don't have some of speakers, I think I can go slower than I thought. So my topic is coronary access after TAVR. One study reported that up to 10% of patients come back for acute coronary syndrome after TAVR. Non-STEMI is the most common cause, but ST elevation myocardial infarction is also a possibility. The balloon expandable type is usually implanted intraannularly, so coronary access is usually straightforward for these kind of TAVR valve. Frame height is low, usually does not reach to coronary artery. So one case of coronary access for patients with SAPIEN 3. The height is usually lower than coronary artery, and the space for space to coronary artery in the sinus of Valsalva is usually reasonable. And right coronary artery, again, LA of U and RA of U. Can you show us the slide? Okay. Right coronary artery. But self-expandable type, for some cases, it is not straightforward and sometimes can be tricky. A lot of anatomical considerations should be included, like ST junction dimension, sinus of Valsalva width, and annulus height, sinus height, and coronary height. A lot of anatomical factors affect the ability for coronary access. Sometimes CT angio may help coronary access. We need to understand the structure of evolute valve. The most important part is skirt height. Skirt height is usually usually 13 to 14 millimeters. Only 14 millimeter for evolute are 34 millimeters. Considering one node is about 4 to 5 millimeters, 1, 2, 3. It is less than 15 millimeters. So usually skirt height is 13 millimeters and 14 millimeters for evolute are 34 millimeters. In case we have cusp alignment, it is easy to access coronary artery, but in case of misalignment, it can be tricky. The most commonly used catheters are Judkin left 4 and Judkin right 4, and recommendation is usually choose one size down, 0.5 millimeter downsizing catheter. This is one case of difficult coronary cannulation. This case is one of our earliest experience. We finally couldn't engage coronary artery for this patient. And again, this patient, another difficult case, we took ascending coronary and aortogram and confirmed left coronary is okay. And again, right coronary artery, we couldn't perform selective coronary angio, so we took angio a little away from the os of coronary artery. But not always difficult. Most cases it is straightforward. Finding the best cell that lies in front of coronary os is the key to find coronary artery. Right coronary artery again. Successful cannulation case. So I think CT angio is a good way to navigate the anatomy and choose how to decide how to access coronary artery. And besides CT angio, coronary ascending aortography also helps. It helps understand the anatomy between the valve and sinus of Valsalva and each coronary access. one key issue is to take the best view. That orthogonally view shows coronary arth and have parallax to the TAVR valve. Then select the proper catheter according to the anatomy. Downsizing catheter choice by 5 millimeters is a good way to get coronary access. An approach coaxially have the best angle and find the best cell for coronary access. And sometimes, as presented by the previous speaker, using J wire helps. Sometimes stiff wire helps manipulating the catheter as the operator wants. In case you don't have selective angiogram, daughter catheter such as Medliner or Guidezilla also helps. Wiring first and advancing daughter catheter along the coronary wire is a good way to get selective coronary angio. And disengagement, unlike routine coronary angio, you need to take care. You need to take care not to damage the valve leaflets and valve struts. So you should remove the catheter along the guide wire or sometimes Terumo wire. So taking all these considerations may help coronary access after self-expandable valve implantation. The last case is a heartbreaking one. 48 gentlemen visited to our clinic for progression of aortic stenosis. He had exertional dyspnea, Canadian CCS class 2. Echo showed calcified leaflets, and Doppler shows severe stenosis is present. Perimeter derived diameter was 23.1 and perimeter was 22.4 millimeters. So we chose to use Accurate Neo 2. This case is one of our early experience of Accurate Neo 2 device. And according to the sizing sheet, we chose this M size, 25 millimeters. Annulus was between 23 to 25, previous slide. Sorry. Average was, perimeter drive diameter was 23 millimeters. So we chose 25 millimeter device. LVOT size was enough. Average was 22.6 millimeters. And SOV diameter was again enough, about 28 to 29 millimeters, and ST junction was more than 30 millimeters. Coronary height looked okay. Left height was a little low, but around 10 millimeters. We thought it's just okay, and right height was okay. The procedure was done as planned. We first did pre-ballooning with 25 millimeters, and then advanced the device to the aortic valve, Accurate Neo 2, and placed the valve down the non-coronary cusp. Then the procedure advanced, unsheathing upper crown. Upper crown is coming out. Yep, upper crown is here. And position was okay. It didn't move. And the last process. During the release of lower crown, the valve jumped a little, as you can see here. The valve jumped upward a little, and angio aortography shows significant amount of AR. So the blood pressure of the patient dropped rapidly, was almost cardiac arrest, and intracardiac echo, intraesophageal echo showed significant amount of intra-annular regurgitation, and here you can see the valve didn't move properly. One leaflet did not move. So this is another long story, and it looks like there was a manufacturing issue. So we decided to put another valve. Before that, we checked each coronary is okay, no coronary occlusion. And we chose, we did ECMO bypass. We put ECMO into the patient and chose smaller device, SAPIEN 323 millimeters. As you see here, the heart doesn't move at all, and device was implanted as we planned. But the patient's blood pressure didn't go up. AR was still there. And unfortunately, we couldn't see left coronary artery here. So we tried to engage left coronary artery. It was valve-in-valve case, so the coronary artery was occluded. Very desperate situation. Wiring was very difficult. Finally successful. Wiring was done, and ballooning multiple times, and then we put a stent there. But flow was not recovered completely. Even though we put a coronary stent there, the patient didn't recover, and unfortunately, we lost the patient in a couple of days. According to Korean data, there are, although the rate is very small, there is rate of myocardial infarction, maybe due to coronary occlusion, 0.3% in Korea. In American data is similar. Multicenter registry showed coronary artery occlusion occurs in 0.66% in patients with TAVR. And this study showed balloon expandable valve is more prone to coronary artery occlusion. And valve-in-valve case, the risk is much higher than native aortic valve. And the outcome is very dismal. Overall mortality is 35%. And in the case of PCI failure, the mortality is approximately 100%. So thank you for your attention.
Okay, really challenging cases. I think this is a real challenging cases. A lot of question and comment about the Professor Kang's cases. Any comment or? First of all, what is the cause of the shock after the accurate nail?
Yeah, this is another long story. The device jumped up a little, so there should be paravalvular leakage, but echo showed the main portion of regurgitation came inside the valve. And it looks like, after long discussion with the manufacturer, it looks like there was a manufacturing issue. The valve suturing was not even, so one of the leaflet was too tight, so it didn't move. And the other two valves were very redundant. So our final result was that the manufacturing issue resulted in valve malfunction, and it caused significant amount of AR. Acute AR led to cardiac arrest.
Yeah. I ask you a question. How was the delay between first and second valve?
First and second, sorry.
The time delay.
Time interval. First valve and the second
valve. Yeah, it took some time because we only had Boston valves at that time. So the guy from Edwards should come to our hospital. So it took like 2 and 3 hours.
I think first the snaring of the initial valve should be done before the second valve was delivered to your hospital. So probably that would make hemodynamics maybe the original state. So what do you think about that?
Oh, snaring and pulling up the valve.
Pulling up. Yeah.
You cannot
and surgical
remove...
conversion or.
Oh, yeah. Yeah, the patient was very old. He was like 89, 84 years old, and he actually had cancer, prostate cancer, and with peritoneal seeding. So we thought that the patient is not a candidate for open heart surgery. Yeah, we tried to get another valve as soon as possible.
So after the implantation of the accurate neo, the patient has a collapse, hemodynamic collapse. So would you consider to convert into the open heart surgery at the moment?
Yeah, yeah, that was another possibility. Yeah, but as I said, he was too old, and he had cancer, and active cancer, and the situation was too grave. So yeah, we couldn't decide to convert to open heart surgery.
Okay, the first speaker is now available. I'd like to introduce the first speaker. It's Professor Lee from Korea. His topic is how to deal with the patient with severe aortic stenosis and the coronary artery disease. Dr. Lee, please.
Okay, thank you for the introduction. Okay, I'm Kwon-Young Lee from Seoul St. Mary Hospital. Today I would like to talk about the topic of how to deal with patients with severe AS concomitant CAD. So significant CAD is a frequent finding in patients with severe aortic stenosis undergoing TAVR. Globally, up to 75% of the prevalence have been reported. The management of these two conditions becomes more important with the extension of the procedure to younger and lower risk patients. In Korean national data, from 2015 to 18, the burden of CAD in patients with severe AS was 45%. A meta-analysis reports showed that the presence of CAD increased mortality at 1 year after the procedure. Another study also demonstrated the presence of severe CAD, which is defined by a syntax score over 22, showed higher 1 year mortality after TAVR. Then, however, can revascularization improve clinical outcome? According to the latest guideline, in coronary artery diameter stenosis over 70% in proximal segments with angina, PCI should be considered. However, both recommendations are equally supported by a level of C evidence. These weak recommendations mean uncertainty due to the lack of evidence to date. When we see the effect of angiography-guided PCI in prospective registries, there were no clear beneficial effect, which means that anatomical completeness of revascularization does not appear to influence long-term outcomes. There is only one RCT named activation. There were no difference in the rehospitalization or death between the medical and PCI group. On the contrary, patients undergoing PCI presented significantly more all-cause bleeds. Considering the algorithm of antithrombotics in patients undergoing TAVR and recent coronary stenting, antiplatelet agents should be added in acute phase, and the risk of bleeding is bound to go up. Several studies have shown a correlation between incomplete revascularization and worse clinical outcomes such as increased mortality or MACE. So it can be considered that complete revascularization might be beneficial. However, there are no randomized studies yet. Now we can say that the procedures for determining regions and patients requiring PCI are very important and necessary. Then how about physiology-guided revascularization? A recent study showed that FFR-guided PCI in patients with CAD undergoing TAVI yielded lower MACE-free survival compared with angiography-guided PCI, and deferred lesions based on FFR present in better outcomes compared with the angio-guided PCI. Here is our case. 81-year-old male presenting with dyspnea worsened for months, and severe AS was diagnosed by echocardiogram. On CAG, there was a diffuse intermediate stenosis on medial AD. We performed the physiology test before and after TAVI. Pre-TAVI FFR was 0.86, and it changed to 0.66 after TAVI. Interestingly, PA was mildly increased, and PD decreased, and FFR decreased and changed to positive, and CFR is increased, and IMR was decreased. FFR assessed before TAVI might be false negative, and post-TAVI FFR outcome was supposed to be a true positive FFR. We've done revascularization for that. In the condition of severe AS, there is an advanced LVH and fibrosis, which makes increased LV EDP. It causes interstitial fibrosis, hypertrophy of the cardiomyocytes, and microcirculation dysfunction, plus elevated resistance during systole. This change causes blunted vasodilatory ability and raised the distal pressure and narrowed aortic valve orifice, resulting in decreased aortic pressure, PA pressure. This change makes negative FFR becomes positive FFR after TAVI. From other reports as well, after TAVI, we could see that the flow velocity was increased and resistance was decreased, and so finally FFR was significantly decreased. Some reports say that resting indices may represent a better option in patients with AS, since it does not require adenosine and is independent of systolic flow. But the other data are still on controversy. Dr. Scarsini proposed a hybrid strategy, and he recommends using FFR only when IFR values were between 0.83 and 0.93, while maintaining 93.7% agreement with FFR lesions in severe classification. And overall, further research is needed, and here are the list of future and ongoing studies on physiological assessment. You'd see the results in the near future, especially TCW and FIGHT-TAVI trial finished next year. Then how about using QFR measured before TAVI? Additionally, we've checked the pre-TAVI QFR for our case, and pre-TAVI QFR result was 0.65. It was exactly comparable to the post-TAVI FFR, which was 0.66. A recent publication demonstrated that a QFR is a good diagnostic yield and is superior to angiography-based percent diameter stenosis measurement. The diagnostic accuracy of QFR was 81%. Another recent study showed that using post-TAVI FFR and IFR as reference, the diagnostic accuracy of pre-TAVI QFR were 83% and 52%. The accuracy of QFR was higher using FFR than IFR. Favor 4 QVAS randomized controlled trial is now ongoing to observe the usefulness of QFR-guided revascularization. And about the timing of the revascularization, I think another presenter talked about this, so I'm just gonna pass. And we care about the timing of physiologic test and revascularization because of the coronary reaccess complexity after TAVI. And clinical trial assessed the coronary reaccess after TAVI failed about 7.7%. Here is our case with SAPIEN valve. The coronary reaccess was tricky due to the valve strut, and therefore we used guideline extension catheter to advance. And another case to engage RCA in patients who implanted evolute valve. At first, we tried to enter the diamond frame in front of the ostium, but failed. And we tried to engage through valve to outer free space because the VTA area was sufficient. Theoretically and statistically, supraannular TAVI valve group showed more impaired coronary reaccess cases. The patient and device-related factors associated with coronary reaccess impairment have shown these figures. And for both type of valve, commissural tab orientation and coronary height or valve implant depth matters a lot. To solve these problems, recently we widely used the virtual 3D simulation at the time of planning TAVI. A conventional CT scan shows geometrical information of strut and aorta. However, it is difficult to recognize intuitively. Here we reconstructed our case as 3D model using segmentation of CT images. It shows us the location of coronary ostium, valve height, commissural tab location as well. We were able to use this to plan the route through which the catheter approaches the coronary artery. We have been applied this virtual pre-procedure planning by our 3D viewer to low coronary artery height case as well before implanting SAPIEN valve as well. We performed TAVI and coronary stenting concomitantly using stance knuckle technique for this case, a case of low coronary height. So, ladies and gentlemen, here is my summary about the role of PCI on top of TAVI. Unless PCI has no benefit over medical treatment on hard clinical endpoints, but carries more bleeds, and incomplete revascularization showed unfavorable outcome, suggesting complete revascularization might be beneficial, especially for younger patients, but there is a lack of data. And a recent study showed that FFR-guided PCI in patients with CAD undergoing TAVI yielded lower MACE-free survival compared with angiography-guided PCI. And tools to select appropriate physiology-guided PCI are of critical importance and under investigation now. A virtual pre-procedure planning using 3D viewer I introduced today would help avoiding early and late coronary obstruction, and it helps determining coronary reaccess route at planning before procedure. Thank you for your attention.
Okay, any excellent presentation. Any comment?
Yeah, and there's no there's no evidence-based recommendation for the PCI about the timing of the PCI. So sometimes if we do the PCI before TAVI, we might do the unnecessary PCI. So, but it's very difficult to assess the asymptomatic patients. So how do you assess the asymptomatic CAD patients undergoing PCI, undergoing TAVR?
Yes, thank you for your good question. And we have to avoid doing the unnecessary PCI for, especially for TAVI patients. They are very old and they don't have many movements. So a guideline therefore recommends that only the proximal segments and which is associated with symptom, then we should treat that. And as I said, FFR could be false negative before the TAVI. So if you do the test of FFR, and anyway, if it is positive, then it is true positive. So yeah, that's why the recent study showed the good result of FFR guided PCI. So I think FFR guided PCI is pretty okay, and probably if the data, we have more data on the QFR and the others, then we can get the more strategy about physiological strategy. Thank you for your question.
I have a little bit a confusion about the physiological guided PCI during in regarding to the TAVI. What I mean is that the pre-TAVI, there is a lot of the false positive, and then or false negative, as your case is at the initial before the TAVI, the FFR value is more than 80, more than 0.8, but they converted the 0.66 after the TAVI. It means we have to do the routine FFR in every patient. What I mean is we have to decide it, the PCI before the TAVI for the technical aspect. We have to know before the TAVI, okay, this region should be PCI. This is some cases maybe does not make sense. Second one is pre-TAVI FFR is more correlated with post-TAVI invasive more closely. What does it mean?
Yeah, thank you for your good questions. Yeah. And I've showed the pathophysiological figure in my presentation. And as you said, then if the patient have a severe aortic stenosis, then the opening is very small and the aortic pressure should be decreased compared to normal people. So the input pressure is decreased. So that makes FFR a little bit different to the real one after TAVI. And also if patient should have a LVH and hypertrophy of the cardiomyocytes and high LVEDP, which means microcirculatory resistance is high, then the distal pressure should be higher, then it makes the FFR go up. Then so the pre-TAVI FFR is not the true post-TAVI FFR. Is not. It should be different in that way. So we have to check the post-TAVI FFR. That could be the true FFR of the patient. Yeah. So it is hard to imagine how LVH is so hypertrophy is going on in this patient. So it is hard to anticipate the post-TAVI FFR. So if you can delay the procedure to do after TAVI, then it is the right way to do the physiologic test, I think. But if you can guess the post-TAVI FFR in a good way and with a good performance with like QFR, then maybe if data is more setting, then we can use QFR.
I ever read a paper regarding this issue. If the FFR before and after the TAVR, the mean value did not change significantly. But if the value before the TAVR, the FFR value is around 0.880 to 0.82, 0.83 something, and after TAVR, the value would be drop below 0.8. So this subgroup patient, we need to have more careful assessment of the FFR after the TAVR. Yeah.
Okay, we will move to the next topic.
Thank you.
Next topic is the challenging case presentation. The speaker is Jonathan Yap from the National Heart Center, Singapore.
Good evening. I'm Jonathan. I'm from Singapore, and I thank the organizing committee for giving me the opportunity to share my case. I've got a case, and I've titled it Pain and Patience. Yeah. It's going to be a short one, so we can catch up on some time with this. So just very quickly, I have had the 80-plus-year-old lady who had the full house risk factors of diabetes, hypertension, and hyperlipidemia. She had stroke, and she also had anemia. This is a quick summary of her cardiac history. She had stenting done to the LAD and circ as part of the pre-TAVI workup in 2015. And in 2015, at the outside hospital, she underwent transfemoral TAVI with an Evolute R 23 millimeters. The procedure was complicated by heart block, for which a pacemaker was inserted. Subsequently, she had recurrent admissions for non-STEMI and acute coronary syndrome. And this is interesting. In January 2020, she had left main bifurcation disease, for which a QLOT was performed, with stents both in the LAD as well as circ. 8 months later, she came in with ISR of both the LAD and circ stents, and an extra second layer of stents was put in the osteo-LAD and osteo-circ. So that was the second layer of stents. And in February 2022, she came in again with ISR of the same areas, and DEBs were performed both to the osteo-LAD as well as POBA to the circ. And each of these 3 procedures were very lengthy procedures, whereby there was multiple use of guide extensions that were spoiled, crumpled, stents got dislodged, and so on and so forth. These were quite painful procedures. So she came in, I think I'm missing one step, but it's all right. So she came in again a couple of months after the February procedure and for non-STEMI, and I happened to see her, and this series of images are from that admission in December 2022. So just to go through the steps that went through my mind as I did the case. So tip number 1, as some of the previous speakers have mentioned, always use a J-wire to guide your catheter. So I went from the femoral 6 French, ultrasound guided, and a J-wire, so that we are sure that we are through the valve and not around the valve. And so once your J-wire is in there, you can move your catheter in. And as some of the, I think one very, very important point is it's good to know the size of the valve. In this case, it's a 23 millimeter Evolute. You know that the space that you're going to have to maneuver is going to be extremely small. So the first thing that I like to do is I go to the LAO projection, straight LAO, and then I go cranial or caudal to take away the parallax. So in this case, you can see the valve is almost you see no parallax on the valve. So you align your view to the valve. And when you're there, you can take a shot. You can either use a pigtail or you inject through your catheter to get a non-selective shot, so that you understand how the coronaries are in relation to the valve. So as what most of the other speakers have said, you can aim to use a smaller catheter. In this case, I used the JL35. And you can see that this non-selective shot allows me to understand where the RCA and where the left coronary is coming from in relation to the valve with the parallax gone. So that helps a lot in cannulating the necessary struts. So after a little bit of a struggle, managed to get some non-selective shots of the left side. And so these are the cranial shots. You can see a little bit of a hint of some restenosis in the osteo-LAD, but these are better seen in the caudal shots in my next view. If you look at this view here, these are the spider shots. You can see very severe in-stent restenosis at the left main bifurcation, especially in the osteo-LAD as well as the osteo-circ. And then this is the AP caudal shot. The RCA was also non-selectively engaged with an IM catheter. You can see that just some moderate disease, but nothing too bad. So, in 2015, I guess, when cast alignment and was not really in vogue at that time. So I think that in this case, this valve was not fully aligned to the commissures. So I tried to engage with a JL35 guide. As you can see here, we take a shot. You can see my wire in the guide. I agree with all the other speakers that you need to keep your J wire in, the thing so that you can push in and push out of the valve easily. So as you can see here, we are kind of somewhere near there, but, try as I might with the fishing technique, the wire, and you can see me moving to a top strut. I was at the bottom strut, moved to the top strut, and tried many struts fishing with the wire as well. Could not enter this. So I guess the angle was very steep. If you can see here, you can imagine your J wire coming down at the angle, and there's no way that you can kind of flip it up. So I swapped out to a EBU trio guide. As you can see from some of these still images, that we are fishing with a fielder wire. I chose the fielder wire because it's a little bit more slippery, a little bit more maneuverable. So I managed to wire the LAD. So after I wired the LAD, I wired the circumflex, and then once again, tip number 5 is the guide extension support, using the balloon tracking method. So you can see here, I have a balloon here in the LAD, and then the balloon is inflated, and you can see my guide extension tracking in. So let me play that again. So I pushed the balloon into the austere LAD, I inflated it right here, and then you can see the guide extension tracking it with the balloon anchor distally. So pre-dilated the LAD with a trio balloon, and the sub also with an NC trio balloon. This is the first initial pre-dilatation, and these are the shots after that. You can see once again the guide extension railroading all the way into the left main so that you get a clearer shot. So trying to prepare the lesion a little bit more, I used the NC score flex. You can see here the left main LAD as well as the left main to circumflex scoring balloon 3.5. And then this is the selective angiogram with the guide extension after the post-dilation with the score flex balloon. And then, she already had 2 layers of stents in the LAD as well as cert and left main. And I decided that, we will try maybe a different kind of a DEB. The previous DEB was a paclitaxel-based DEB. So I used the magic touch this round. 3/15 to the left main circ, and then 3/15 to the left main LAD which burst, and I used a smaller one. I couldn't kiss because, as you know, I should have used the bigger guide, but I used a 6 French guide with a 6 French guide extension that does not allow kissing. So I had to individually inflate at each artery, and then the final port to the left main. As you can see in this diagram with a 4 balloon. And this is the final shot. Not ideal, very high risk of recurrence. We would expect, but at least for the time being, we have bought her some time. So I just want to summarize some of the practical tips and tricks that I've shown from this case. So number 1, always use the J wire to ensure that you're within and not outside the valve. And then your first thing that you should do is in the LAO position, you go either cranial or caudal to coaxial your valve. Then you take non-selective shot, either with your catheter or pigtail, so that you can understand how the coronaries are in relation to the valve. Use a smaller size catheter. And once again, as most of the other speakers have mentioned, use the guide with the J wire in situ to facilitate access to the different cells. You want to move up and down, find a cell that's most in line with the coronary opening. Do remote wiring, or what the other speakers have mentioned as fishing, and then use the guide extension and balloon assisted tracking. And last of all, I think this is the most important point. There are cases that are tough. You can feel sometimes frustration rising in your heart, your mind, but really take a deep breath and have some patience. If you try and understand, what is going on, most times you are at the end of the day manage to get a decent shot of the coronaries. Thank you.
Okay, Dr. Yap, your presentation is really excellent and educational. In every procedure is a step-by-step, and the presentation is so many persuasible. So really, I like this kind of presentation. Any comment?
This is Dr. Buzar from Bangkok. I do have questions to Dr. Yap and perhaps to all the panelists. So do you think, should we have any tools, or should we do CT after TAVI in patients who has high possibilities of having to have coronary reaccess. For example, those who you put, complex stenting in before TAVI. So you know whether the relationship between your TAVI valve and also the coronary ostium. Yeah. A lot of them got referred to to another hospital and ended up having acute coronary syndrome going to another hospital. What would you do? Any suggestion?
So most of the time, the problem is if they, no matter what you do, if they go to another hospital, that information will not be available to the other hospital. But let's say, if you're worried and that patient, you have some time and that patient may come back to your hospital. So two things. One thing that was mentioned previously, I find very useful is, at the end of the TAVI procedure, you do a aortogram. So that reference image, is very helpful for future coronary access. And second, as you mentioned, CTs are quite useful to study the commercial alignment, but may not truly help you, in the case itself, but may help you, forewarn that, the commercials are very close to the coronary ostium, you're going to have difficulty, but I would say it may not exactly help the engagement of the artery on the case itself.
Okay, Dr. Singh, you have your hands up.
Just a small comment. I'm not specifically for TAVI in TAVI, or I use the CT of the index case to, just like a coplanar angle, just like three-cusp view, I find an angle which shows the best ostium of the left main and the ostium of the right coronary artery. So in case I have an issue afterwards, I specifically go to that angle, and already I have written on my report that will show the ostium best.
Any comment? Okay, we will move to the next topic. So another challenging cases presentation. Dr. Un, actually, as we know, he's the Singapore TAVI representative. Dr. Un, please.
So thank you for the invitation, Dr. Ho Ki-Woon here. Today, I'm going to switch gears a little bit, presenting on delayed coronary occlusion, another important but maybe not so recognized phenomenon. These are my disclosures. The patient I have today is a 79-year-old lady with type 1 bicuspid aortic stenosis. She's severe AS with an EF that is 28%, but still generating a mean gradient across the aortic valve of 55 mmHg. These were the images of the coronaries prior to TAVI. So minor coronary artery disease. The right is anomalous arising from the LCC, but no significant coronary artery disease. A CT scan was done. You would see that the area and perimeter derived annulus is about 23. The left main height is 7 millimeters, pretty low. But when we compare the annulus with the sinus of Valsalva, I'm getting about 26. We felt that the likelihood of coronary occlusion is not going to be that high. These were the CT images, again confirming that there is a type 1 left-right fusion bicuspid aortic valve with severe calcification over the NCC. The sinus of Valsalva measured about 28 millimeters. So the annulus was about 23, and in this case, when we were concerned about left main patency, we went with a smaller TAVI valve. In this case, we decided for core valve Evolut Pro, 26 millimeters rather than a 29 millimeters. So this was the aerogram done before deployment. We did balloon dilatation using a 20 millimeter balloon. You can see that with the balloon inflated and contrast injection, there is still flow in the left main. The valve was deliberately deployed a little bit lower. This was in 2019 to maintain coronary perfusion. And this was after the deployment of the core valve. can see that anomalous right is still patent, the left main is still patent. You can make up the outline of the calcification as well, but we were quite happy and relieved with the result. So post-TAVI, her EF from 28% normalized, her mean gradient across the aortic valve was 15 with trivial paravalvular leak. So that was in 2019. But 3 years after TAVI, last year, I've been seeing her regularly on a yearly basis. She started reporting having daily nocturnal angina. So thinking that the CAF was pretty much normal 3 years back, the chance of coronary artery disease to me wasn't very high. I did a MIBI scan, but to my surprise, actually shows large defects, apex, inferior lateral, everywhere. So we went on with a coronary angiogram. Again, we went on with the right first. And what you will notice is that our collaterals from the right coming up the LAD. So this is something that is a little bit unusual. There was difficulty engaging the left main, and I amplified this to show the reason why. There's only a slit-like access between the skirts as well as the left main. So we had to do some fishing and remote wiring. This is getting as close to the cornea as possible using a wire to go to the circumflex. With that allowed us to use a guide extension catheter to have more selective injection. With a more selective injection, actually it confirmed that there was actually no significant LAD or circumflex disease. And our suspicion initially of delayed coronary occlusion right around where the skirt is raised. So this is multiple suspicion. She has angina, maybe strongly positive. We see collaterals from the right going to the left when we did the initial shots. So the decision was therefore to treat this delayed coronary occlusion with stenting, sort of chimney stenting, across from LAD into the aorta across the skirts of the TAVI valve. So we ballooned first the skirts and then wired both the LAD as well as the circumflex. IRIS was performed, and right where the skirt is, it shows a minimal luminal diameter of about 3.5 mm square. We then positioned a Megatron 3.5 by 28 millimeter stents, and we wanted more length to be definitely across the skirt. Once we're happy with the position, we deployed the Megatron. There was a 3.5, then we post-dilated as big as possible. Left main was quite big with a 6 millimeter balloon. The balloon looks expanded here, and this was the injection after the deployment of the stent. We did have a cine and a stem boost image of the stent extending within the frame across the skirts into left main and LAD. We went back to the RCA and we found, again, no collaterals now from the RCA to LAD, telling us we probably did the right thing. This was the IRIS image before and after. After looks like a snowman, even though we used a 6 millimeter balloon, it's still constrained by the skirt in the mid portion, but we did get about 12 mm square area, MLA post PCI. So from daily nocturnal chest pain, she had no chest pain. We put her on DAPT for life empirically. So a little bit on the late coronary occlusion. Definition is the occlusion of either left main or RCA after TAVI that is directly related to the TAVI persistis, not related to the disease progression of the coronary artery or in-stent restenosis. From the DCO registry, this happened about 0.2% post-TAVI. It can be divided into early, less than 7 days, to delayed, more than 7 days in terms of DCO, to early and late. Early etiology can be due to continued expansion of the mitral frame of the self-expanding valve, dissection or hematoma. Delayed, like in our patient, may be due to fibrosis and utilization or thrombus. Risk factors: heavy calcification, low coronary heights, like in our patients, valve-in-valve procedures, or thrombus. Risk factors plus valve-in-valve procedures: the use of self-expanding valve compared to balloon expandable valve, and a relatively high implant depth of the TAVI implant. Also, the difference between the sinus and the prosthesis that you are implanting. If it's a wide sinus with a relatively small prosthesis, you can imagine there's actually quite a bit of space in between, and the risk of DCO may be reduced. This is compared to a very narrow sinus, a large prosthesis. This increases the risk of DCO. So a summary of early versus late delayed coronary obstruction. Early, usually the presentation is very acute. They either have cardiac arrest or STEMI with high mortality rates in hospital. Delayed, like our patient, may be stable angina for months and maybe even years. And the mortality, even though it's still more than 20%, is not as high as early delayed coronary occlusion. With that, I thank you for your kind attention.
Excellent cases. Any comment or question? Would you explain more what is the cause of the delayed coronary occlusion? Where is the lesion site? In your cases, where is the lesion was located in the left main or proximal radius, or it looks like beyond the left main ostium? Is it true?
If I can bring up my slide again, I think I showed it with the amplified view. It is between the sinus and the skirt. So I hope you can see this. This is the amplified view. You can see there's a very tight slit-like narrowing. It probably, the commissure isn't aligned, and this is the source of the occlusion. The rest of the artery is no significant stenosis, and you can see collaterals that have been well formed.
So you mean actually lesion location was the originate beyond the left main ostium and the outside of the valve. It looks like some skirt.
So this is in other words, it's a sinus sequestration actually. So the sinus all round is sequestered. In very extreme cases, if you have very high implantation, it can actually have the skirts actually encircling the whole artery, and you will lose coronary flow. We do have such cases in the past before.
Very interesting.
Yeah, okay. But the fact that it didn't happen acutely, but it happened 3 years afterward, do you think there's, and presumably the stent didn't move, so there must be something kind of building up around it and cause that space to be narrower than when you implanted the valve.
Yeah.
It could be like endothelialization that you said, or pannus formation right around that particular spot and make it narrow.
I think I can start by saying that this phenomenon is not very well recognized. It is recognized when a patient has symptoms, presents with chest pain. But at the end of a procedure, when we do an aortogram, we see flow in the coronaries. We may not think twice about this occurrence. How we detect it may be very difficult. But in this case, I can only speculate on the etiology, why after 3 years, when she had no chest pain, she suddenly developed chest pain, continuing endothelialization around the skirt and valve, thrombus formation, continuing expansion. All these are factors.
And with the stent protruding in the frame, inside the frame, do you have to make sure that it doesn't interfere with the leaflet function, like monitoring the echo while you stenting your left main into the valve frame?
It's a very small portion. I imagine that the leaflets would not be impinged too much because it's actually floating back. Even if you have the leaflets extending out, in this case, not by a lot, it would not impinge on the opening of the aortic valve.
After checking the IVUS, was the catheter and the stent advanced through the diamond or valve to aorta area? And if you have another case like this, then which one would be better, you think?
Okay, thanks for this excellent question. So the initial intent was to stand across the diamond if possible. This slightly increased the chance of me going into the coronaries if I ever do need to go. I can imagine if I stand around the core valve frame, it will be very, very challenging in the future next time to reassess. So if I have a choice, it will be across the diamond.
Okay, we will move the last cases, challenge cases presentation. Dr. Chang from Seoul St. Mary Hospital. Last presentation.
Thank you, Chairman. My topic is high-risk valve-in-valve TAVR in a patient with low-lying coronary artery. 82-year-old female visited emergency room because of severe shortness of breath. In her past history, permanent pacemaker was implanted in 1993, and AFib and delayed renal infarction occurred in 2018. And surgical aortic valve replacement using mitral flow 19 millimeter was placed due to severe AR. And her eGFR was only 16, the CKD stage 4. Her NT-proBNP was remarkably high. Chest X-ray showed marked cardiomegaly and both prohibition and pulmonary edema, and electrocardiogram showed all pacing rhythm. The thoracic echocardiography showed the increased transvalvular peak velocity 4.2 millimeter per sec, and mean pressure gradient was 42.5 millimeter, and mild pulmonary hypertension and normal ejection fraction. As you can see in the Prastana Shodex, there are mild to moderate acute aortic regurgitation. And her SDS score was so high, so all surgeons agreed to valve-in-valve TAVR. We analyzed valve CT. Her perimeter was only 53.3 millimeter, and the perimeter derived diameter was only 17 millimeter. However, considering the second degenerated surgical valve, the whole true inner diameter may be only 16 millimeter. And her sinus valsalva was a little bit lower than 28 millimeter. And luckily, her SD junction diameter was large, more than 30 millimeter. Unluckily, her height of left coronary artery was 6.5, and right coronary artery height was 11.3, and the SD junction height was only 14.3 millimeter. So her problem is very low left coronary height. As you can see in this slide, mitral flow 90 millimeter by process, the height of valve is 11 millimeter. When we put Evolut R 23 millimeter, the coronary height was, left coronary height was 6.5, but valve, surgical valve deplete height is 11 millimeter. So the chance of left coronary occlusion was nearly 100%. And as you can see in this case, the shares many risk factors for coronary obstruction after valve valve TAVR, and low-lying coronary osteum, and narrow STA junction, and narrow sinus valsalva, and her bioprosthetic valve was mitral flow. Thus, we planned Basilica before valve TAVR to protect our left coronary artery, and then Sentinel would be necessary to prevent embolization during Basilica procedure, and then self-expandable valve would be implanted, and then valve fracture was our plan. So Basilica was designed to provide the coronary protection. Actually, Basilica or the snorkeling stenting are both way to protect coronary protection, but Basilica seems to be more physiologic than the stenting. We placed the Sentinel, and then the filter was located in right brachiocephalic and left carotid artery successfully. After then, we performed the Basilica. For the Basilica procedure, we have to set up the snaring system and the traversal system. And for the snaring system setup, the multipurpose catheter should be located just below the surgical aortic valve, and then the V18 anchor wire should be located in LV apex for the support of multipurpose, and then 20 millimeter gooseneck snare was positioned just below the LVOT. And for the traversal system, the short tip and branch left guiding catheter is placed just in front of left main by using areocranial and areocaudal view. And then inside the short tip AL1 guiding catheter, the diagnostic catheter is placed because of the axis of perpendicular alignment of the guide wire to the surgical valve leaflet, and within it, the fine cross and astato 20 gram is sequentially inserted. So we targeted the nadir of surgical aortic leaflet, and this astato wire, the external end is connected to the Bobby electrical system. So at the time of penetration of surgical leaflet, the 50 watts electric current is delivered to the tip of the astato wire, and we successfully penetrate, and then the gooseneck snare captured, and then externalized to through the MP guiding catheter. And then before TAVI procedure, we bended the astato wire at the center of the wire, and then decoated. So this is V-shaped. We called V-shaped wire, and we positioned the V-shaped portion of astato wire at the laceration point, and then pulling up the short tip emprange wire, and then the multipurpose wire, the pulling out, and it successfully tear the just a moment. It successfully lacerate the surgical leaflet facing left main. After then, the Evolute Pro 23 millimeter was smoothly implanted. And then we, as we planned, we fractured the surgical valve deflate by using arthroscope, the non-compliant balloon, 20 millimeter. Just a moment. During valve implantation, the TAVR valve and the surgical valve, you can see the approximation of two valve frame, and then widening of the surgical valve ring. So after TAVR and valve fracture, the final outcome showed good left coronary flow. So after all procedure was done, we look at the sentinel filter and found the embolic tissue material. Next day, transthoracic echo showed the reduced trans-aortic peak velocity and beam pressure gradient. So in conclusion, we successfully performed the valve-in-valve TAVR in a patient with failed surgical valve and no coronary artery. In case we initially placed the sentinel device to prevent embolism during basilica, and then performed TAVR and evolute R, and next valve fracture was done with the use of 20 millimeter arthroscope balloon. Thank you for attention.
Okay, very complex lesion and a number of complex procedure was successfully done. Well done. Okay, any comment?
Very good case. So we have also done some cases of a basilica, but not all the cases are successful. So when you puncture the valve, you use a startle with a fine cross microcatheter and direct puncture the valve. To use the cauterization, to pass through the valve.
Yeah, when you pass the surgical valve deeply, we should give electric current. Without electric current, the valve never penetrate. So the other technician connect the external end of the stator to the Bobby system, and then giving the electric current. So that's the timing. So because the wire cannot penetrate and it touched the aortic valve deeply the other side of native valve, native structure. In that case, the perforation between the native the aortic the structure, so that result in catastrophic result. So maybe the cooperation is very important.
So, but if you connect to the current cauterization, how about the microcatheter? Would it be injured by the electric power?
So I'm not sure that I understand your question fully, but only as I said before, the fine cross microcatheter should be done for basilica, because fine cross has no metal. So the electric current delivered from the end to the tip. So only fine cross should be done. The other microcatheter should be never used.
And cutting the valve, it wasn't done by the wire. Cutting was done by catheter.
Yeah,
shaft.
Catheter, pulling the catheter and then
mechanically.
Yeah, very strong force.
Just one question, sorry. Very well done case. A lot of operators will use transesophageal echo. I see you did not use it. A lot of time you want to see where you're cutting the leaflet, if it's in front of the left main on a transesophageal. Do you normally do basilica without any transesophageal echocardiograph guidance or no?
Pardon, I cannot understand your question.
I said many times operator will use a toe or a transesophageal echo to see where exactly you are lacerating the leaflet in relevance to the left main coronary region. I see you did not have transesophageal echocardiogram. Is it your normal practice to do fluoroscopy guidance?
Yeah, transesophageal echo I never use in my routine TAVI, but in this case we worried about the penetration of asset wire through the normal neighboring the structure. So in the case the twin flow shunt flow occurred, so the T can detect such kind of the serious side effect immediately. So I asked the T specialist to monitor our procedure. During my procedure, during laceration of valve leaflet did not result in severe AR, only a mild AR, because the laceration can little bit small distance, not large distance. After TAVI, large gap between the lacerated valve leaflets.
Thank you. I think we finished all the lectures, and I think this is a very excellent sections. We have very excellent speakers talking about the coronary artery disease and the patient with a severe aortic stenosis, and talk about how to do the commissural alignment and how to assess the patients with coronary disease undergoing TAVR, and the technical tips and tricks to facilitate the coronary cannulation, and on the step-by-step the